Dr. Achintya Maulik,
If you may stand, please.
the visionary architect. Dr. Achintya Maulik doesn't just operate on hearts. He builds system that keeps them beating. Cardiothoracic surgeon, innovator, bridge builder between continents, he dreamt of a place where the best minds could think without borders, and then he made it happen.
Mr. Sanat Chattopadhyay. If I may. The quiet power behind global manufacturing, the man who scaled Merck with humanity intact, Sanat Chattopadhyay proves that leadership isn't noise. It's precision, ethics, and relentless excellence at scale.
I like to refer to Sanat as the industrial sage. Dr. Sameen Sharma. The heartbeat of Mount Sinai, the stent king himself. Dr. Sameen Sharma, a surgeon whose hands have saved thousands and whose humility teaches millions. When he steps into a cath lab, time slows because mastery moves in silence.
And together, they are the foundation of this Congress. Proof that vision can scale, compassion can lead, and excellence can unite.
Ladies and gentlemen, I will request the three founders to please come on the stage. The founders of Global Health Congress 2025. Is that working?
Good morning. I'm not quite sure you have a hangover from yesterday. Let's try one more time. Good morning. Good morning. Yes, looks like we're all awake. Good morning. Good morning. So, Dr. Achintya Maulik, Dr. Sameen Sharma, and I are so happy that we are getting a chance to welcome you all today for the 2-day session that we are going to have at the Yale Lab. And this kind of gives us a lot of satisfaction because when we started our conversation, we didn't know the destination. We just knew that it will be an arduous journey given the over-fragmented nature of these kind of conferences that happen. So we wanted to make it unique. We wanted to make it distinctive. We wanted to have its own niche. And most importantly, it must be value added for the audience. So over the next 2 days, what you would see is you're moving in a big canvas, not just discussing about the big picture challenges, but also talking about pragmatic solutions. Meaning, we will talk about the investment trends, but we'll also talk about the bedside innovation. We will talk about the ethics of AI, but we'll also talk about the unheard voices in safety net hospitals. And to do that, we need to understand that the agenda has to be broad enough so that it can have the right intersection of policy, finance, the entire ecosystem comprising physicians, the payers, the insurance, all of that, and which is what we have tried to construct. Now, to do it well, to listen and engage better, may I request the 3 things for us to do. First, let's extend our curiosity, because we know that breakthrough happens only at the intersection of disciplines. Second, let's be pragmatic. We'll all be hearing great ideas, and there will be visionary ideas. But the value of this room is translating them into actions and models which can create actionable, valuable tips and actions for the practitioners. And third, let's try to connect intentionally. What I mean by that is, let's create partnerships. Partnerships between India and the US, partnerships between the startup and the peer, between the physician and the technologist, because only through that we can be aspiring to create a scale for innovation to sustain access to equity. So therefore, to make the healthcare worthy of the next generation, let us all challenge the assumptions of AI, the assumptions of new care models, the assumptions of how to fund and invest in healthcare for equitable access. And we are going to do all of that today, but please don't forget also to use the quiet moments over lunch, dinner, coffee, to test your idea, to offer critique, and also to form new collaboration. With that, I'm handing over to Dr. Achintya Maulik to bring it home and get the conference started. Achintya.
Let me adjust my bow tie. So I'm not used to following Sanat in speeches, and it's always difficult to follow. But I'm extremely glad to see so many people show up. And this is just within 4 or 5 months of conceiving this thought. Thank you very much. People who have flown in, come to visit us. People still stuck in aeroplanes who can probably see this on a live streaming. And the people who will take these thoughts forward, let me just turn this off. This is Dr. Kali Chowdhury, he's the next speaker. Dr. Chowdhury, I'm on the mic. Dr. Chowdhury, you're also on the mic. Yes.
Give me a call.
I'll give you a call. Okay, thank you. So this is the ethos of this conference. So when I started conceiving this concept of this conference, was to be something immersive, interactive. I've had the fortune to have built systems across the world. And I get into this accidentally. It's always been an accident. I've never planned or designed anything. I was trained in Mass General, Emory, and every other place, was practicing in US. And I meet some people in a plane. And they ask me, we're building a health system. And I said, yeah, right, I've heard that before. And this is how I landed up in India building Fortis Healthcare. And the first person to give me a job was Mr. Vinay Singhal, the first CEO of Fortis Healthcare, which is a $10 billion company. Mr. Singhal, where are you? Right here. Please stand up. Will the Slim Shady please stand up? So the people like them, Mr. Vinay Singhal, Dr. Purnendu Roy, who was my teacher in general surgery, I mean, he still regrets having taught me. My classmates from medical school. There are people who I've met in the gym who's going to show up later. There are people all around the world. Mr. Sandeep Bajaj, who's sitting and eating something. So all of them have come from all over the world just to hear what we are going to put together in this forum. Healthcare is fragmented and everyone's hearing about it, but no one's doing anything about it. They are doing, but it's fragmented. We are coming up with new acronyms every day. You go to a big meeting and you hear another new acronym. I think we all should silence the phone, including myself. That's Samin and me. Okay, let's silence the phones. So you'll hear a lot of acronyms and new words and terminologies, but they've not led to any significant savings or improvement of quality of life. Here I'm in India building a new health system, and I had no idea that I'll get the next patient and the next patient. And 30 years later, or 25 years later, I see a $10 billion health system. Here I join another health system, which ends up closing because there's not enough funding, despite all the effort that we put in. So there's something fundamentally wrong. And the solution to this fundamental ills can only come by people across border, across industries, coming up with new ideas, creating new concepts. Not like that we are all sitting around and the next AI buzzword or company is going to solve all our problems. It'll be a cross-sectional, industry-wide discussion. Like you have a pharmaceutical president there. We have a surgeon and a cardiologist here. We have people from fintech. We have people who IoT champion. Vasilis, could you please stand up? He's one of the, we call him the father of IoT. We have people from across the industry who have come together. Ideas will come from here. Here we have to prove that healthcare is not a privilege, it's a fundamental right of every human being. And as we go forward in the next few days, and we create new ideas, we should get together, come up with solution, and keep this going forward for the next many years. My goal was twofold for this. One is to disrupt, disrupt, disrupt. And number two, have friends that I can talk it with and have this conference for the next 30 years because we'll need friends at that time. So please, let's get together. Make this a special ecosystem, a special movement that we all lead together. We are all party to this inaugural. This is the first Global Health Forum. This was conceived recently, and this is going to take us far. Thank you very much. God bless. Samin Sharma, please come on.
Well, I'm so happy to see the way it has really came up with this meeting. You know, we, for last 3-4 months, weekly or every 2 weekly meetings used to take place because of Achinta and Sanat trying to put this thing together. And my question always was, what is the theme? Because usually we all know, like there is actually a nice conglomeration of here, the business section, the doctors, ITs and others, industrialists. Usually we have our own meeting. The medical meeting is medical meeting, business meeting is business, IT and banking, you say it. But put it together. Achinta, Dr. Achinta Maulik, I'll just call him Achinta, he said, you know what, I'm going to say different. Who says that they have to be separate? And we know the health care in America, despite so much money spent on healthcare, 20+% of the GDP is spent on the healthcare, we still are not on the top in terms of the longest survival in the world. Male about 79 and female about 82 here. Many countries, they have 85+. And secondly, the way the healthcare is, and those who are aware of the hospital chains, majority of the hospitals are losing money. You say, how can that be? Government is spending so much money, how can we lose? The way the whole structure has been set up. So I'm very glad to see that totally different presentation, totally different setup, me to learn, and as has been said, that try to make best use of it. It's not just to what you know and how we network. And in the way, we can make healthcare better locally, nationally, and internationally. And of course, India is the prime of part of it, and many people who have traveled from India to make this happen for this meeting. We welcome, and 2 days, very intense, more focused, personal experience meeting will take place. I know some slide presentations also, but most important is the viewpoint of the expert in the field which have been selected for these presentations. With that note, I welcome all of you for this 2 days of very mixed educational learning gala. Thank you very much.
Thank you so much. All right, so if you would kindly proceed to your seats, we'll proceed with the program. Right. So before we begin, we would like to take a moment and acknowledge the partners and sponsors who's made this extraordinary gathering possible. The Global Health Congress stands on collaboration, and it's through the vision and generosity of our sponsors that we are able to bring this community together. A heartfelt thank you to eClinical Works, IBM, Mount Sinai, Onyx, Dilworth Paxson, Orbindo Westbridge Capital, Thermo Fisher Scientific, Digital Zone, Rackspace Technology, IHP, Guide Health, Cheston Critical Care Consultation, and Zebitech. Your support reminds us that innovation thrives when industry and intellect come together. This Congress truly would not have been possible without you, so thank you so much. And now, to officially set the tone for the day, a leader who's been defining the digital future of healthcare while the rest of the world was still figuring out Wi-Fi. He is president and CEO of HIMSS, a global organization linking hospitals, data, humanity under one intelligent network. He doesn't just forecast the future of healthcare, he architects it. Please join me in welcoming to the stage Mr. Hal Wolf.
Good morning. Good morning. Well, you got them really well prepped for that. That was good. That was very good. I think we have some slides, if you guys can pull them up in the back. There we go. Great. I don't know if you can see it or not. Chairs? Okay. We'll work it through. It's all good. So I'm Hal Wolf, President and CEO of HIMSS. For those of you, there are a number of HIMSS members in the audience, so thank you so much. If you don't know HIMSS, HIMSS is a global nonprofit which is focused on the support of care delivery, and all the way to the individual. There we go. Perfect. You can just leave it, it's fine. These will be good. So as a global advisor, we work with hospitals, clinics, governments, systems globally, with over 130,000 members now, about 80,000 in North America and the rest across Europe, Asia-Pac, the Middle East, South America, and Africa. Our vision is to realize the full health potential of every human everywhere. And within that is an absolute commitment to health equity. It's at the fundamental core of our global nonprofit. And our mission is to reform the global health ecosystem through the power of information and technology. And we're going to split that up because it's really core to where we are as an industry and where we're headed. It's not IT. It's information and the technology, because today it's all about the information we get and what we're going to do with it. Now, healthcare systems on a global basis are all facing largely the same challenges. You can see the bar go up and down depending upon where you are. But the reality of it is that we have an aging population, which is a good thing, which is also followed by chronic disease and chronic disease management, which is a critical part. You all can hear me okay through the mic? Okay, good. Thank you. Chronic disease management and the fundamental burden of it. And this is really a derivative of two things. Because we're getting older, and the older you get, you will wind up at some point in time in a chronic disease state. And we are so much better at diagnosis and anticipation of diagnosis of chronic disease. And this is also a real key to a few of our other challenges. The other challenge is geographic displacement. It's a nice way to say access. And that does not mean rural versus urban. There are far too many people that live in the shadows of some of the finest hospitals in the world, but they simply cannot gain access. So we have a demand problem. We have a supply problem. And there's not a healthcare system in the globe that is not facing funding challenges. There were a couple for a while. The last holdout was Norway, but even Norway has challenges now on a funding basis. And their entire healthcare system was fueled by interest off of their oil trust that they established years ago. We have an educated and demanding consumer, and we have a lack of actionable information, which is getting better, but the demand on that information now is higher than ever before. And then finally, and critically, are our fundamental staffing challenges on a global basis. Physicians, clinicians, nurses, we have a growing gap. And that gap, by simple estimations today of the WHO, has been running roughly from 7 with a target gap of about 10 million. And that's a revised number from last year because it was up to 13.5, and then we sort of changed the formula with the WHO. But the bottom line is the system situation is the same. We have a massive staff shortage with growing demand sitting on top. So now we got to figure out what we're going to do. And we need to figure out how we're going to approach this to utilize both the technologies, the design processes against this challenging backdrop. So I want to take just a half step back and recognize this critical word, which is anomaly, because this is what healthcare is all about. We define normal at a population level. We define normal at the individual level. And then we look for and we define the anomaly. We find the thing that is wrong, something that hurts, something that's going to hurt. Our testing, our preventative approach is designed to find the anomaly. And when we can define the anomaly, we put the individual on the best care pathway that we know of based upon our trials, experience, the white papers, the clinical use, through our quality departments. That's what we do. So it's about this anomaly word that we have to focus how we handle this demand and this growth. Now, the continuum of care is broader than these four, but for the sake of our discussions, they really fall into this primary prevention, secondary prevention, acute care, and of course, chronic disease management. Now, this is where we get our opportunity. So, within the health model, we've been innovating. You all know it. We've been on this journey aggressively over the last 20 years. And we can argue with the speed, but it is about personalization. We start fundamentally at a population health level to define that normalcy, and we work our way up the chain at the individual person and its needs all the way to a genomic in order to get a snapshot of that individual. And we've been moving at a fairly slow but steady pace, right? Incremental gains. And at the same time, the health model, which is being driven by the global app ecosystem, is also been brought around. This comes from that consumer we talked about earlier, who has high demands. And they begin to use and consume rings, devices, applications on their phones. They're becoming engaged because they're also getting a little impatient, to be frank with you. And so what we've thought about over the last couple of years in this realm of personalization is this fundamental need to weave the two together. That's what we've been looking at over the last 10 years. How do I bring some of those technologies, capabilities, the outside into the medical model while the medical model tries to catch up to this fundamental demand which is happening all around us, along with the shortage on the finances and the personal challenges. But there's a catch. And this is where I'm seeing a separation, we're beginning to see it globally, is that the health model isn't weaving in purposefully the way it was before. The health model is starting to leave the medical model behind. Their business plans are not designed to have to go back into the hospital or the clinic. They're going straight to the consumer. It can be devices. It can be primary care that's now at the grocery store. But this disconnect is going to grow because the global app ecosystem and the investments are pouring into the health model at a faster pace because it can. And this is a challenge. So, we're going to have to make some changes inside the medical model. We're going to have to make some leaps. And one of my favorite expressions is that the incandescent electric light did not come from the continuous improvement of the candle. You can get so far, it's all illumination, but there is a fundamental leap that has to take place. And the incremental approach, which is why the health models left us behind a bit, this is the challenge. And when I say we, you can immediately see from a hospital-based environment. But this digital health transformation of the medical model is now what we must accelerate to keep pace, or to think about the fact that the weaving won't occur. How do I approach my world differently? And yes, operations, sustainability, equity to improve fundamental clinical outcomes, all of this is what we have to have in our digitization and our targets in the redesign of the medical model. And it is a digital, mature ecosystem that has to be developed. There's nothing surprising here. We understand the cycle. The question is, what do we do with it? And so within the midst of this fundamental medical model of analyzing, we have to look for the outcomes and the information that informs our design. And I focus on information versus data because data is useless. It is nothing but ones and zeros sitting inside servers. When you compare it and you bring it into analysis and turn it into information, it's worth something. Until then, it's lights blinking, right? So you'll hear me use information and not data, and they are not the same thing. So this brings us to artificial intelligence. You may have caught on. It's a slight buzz phrase. Has anyone caught that? Okay. Now look, it's happening largely in three buckets. The first one we talked about, it's the devices, right? It's what's happening, it's monitoring the individuals, and they're really effective. I can keep up with blood pressure all day long. I can keep up with my sleep patterns. I don't need to go to the clinic every 6 months or every 3 months to have something checked when a device on me can actually show me what's going on and point out an anomaly before it occurs. You know, if you use a ring or something of that nature, it tells you in the morning, it goes, you know, something might be going on. Your temperature went up during the night and so forth and so on. We're beginning to see this engagement that's happening outside that medical model. Where AI is being deployed rapidly is in the operational space. Either independently applications that are doing predictive modeling as to who's going to walk in through the door, or they're built into EHRs and their fundamental capabilities. And then finally, of course, the knowledge management. My background was actually building clinical decision support for the physicians in the ecosystem in which I was raised. And now we have to have this clinical support. And it's really simple math. 1972, for those of you who have history books, encyclopedias, something of that nature, there were basically 4 major medical journals that were produced every month and shipped out sometimes quarterly. And there were 400-ish articles sent to your door because a publisher sat there somewhere, looked at 200, chose 6, put them in a magazine, and they got sent. And by the time they got to you, they were roughly several months, if not 6 months to a year, behind their original publication date. But if you were a diligent clinician, you could read an article a day, and keep up. Last year, over 150,000 peer-review articles were published. I've seen estimates as high as 300,000. But let's stick with 150. There is no way that any of us can keep up with the advancements and the changes. So if I identify an anomaly, am I going off my knowledge, or am I supplementing it with global knowledge that AI and machine learning can bring us? And therein lies the essence and its influence by the outside information. So we're at a breaking point and an opportunity. Several years ago, we had a scope of practice change where we took nurses and brought them forward into our practices at a higher state of license, and we shifted responsibilities off of primary care into the nursing care as well as in the ICU, so everyone could practice at the top of their license in order to make up for the gaps we had. We've all been a part of that. We've seen it. And it helped, but it didn't solve our shortage problem and the growing one we have. And what I believe is going to occur, and must occur over the next few years, is another scope of practice change that shifts many of the things we do and don't have to do to the burden of AI, devices, and capabilities of the engaged patient at home. We can find the anomaly and save our precious resources of our staffs to engage with the patient within the medical model. And this is the question you're going to have to answer strategically in the next couple years. Do I continue to force the weave? Or do I recognize and see an opportunity that this health model is separating itself, and I use it as a scope of practice opportunity in order to better serve the actual patients that walk in through my door? And this is the fun challenge that I hope it will land. And the predictive analysis that can come from utilizing this on the outside is not just at the individual level, it's at the population health level as well. And we're beginning to see that happen. We understand where our investments need to go. We understand it at the community level, we understand it at the hospital level, and we see it all the way up to the individual level where we can actually create digital twins. So I can anticipate the predictive modeling of the individual from an anomaly standpoint from outside in, and recognize that even at the population health level, I now can predict where this is going to hit and what I need to do differently. We have never had this abundance of information, and quite frankly, even more on the way. And it demands the recognition of the modalities in which it's coming. It's going to come at us from text. It's going to come at us from computers. It'll come at us from devices. But the point is, the outside information will show trends and capabilities that we just must pay attention to for our own capabilities to deliver care. Now, we talk about this a little bit from a technology standpoint, but let's be really clear. We are talking about the redesign of systems. People, process, technology. Technology alone. Folks, we have all the technology we need. It's going to keep getting better, okay? But let's be clear. Just a couple years ago, I was sitting watching the NASA channel. Does anyone get that, if you ever watch it? And I was watching a live feed from the surface of Mars of a helicopter sending back a 4K video as it cut across the surface of Mars, live into my room. Not kidding here. The next day, my son couldn't get his record sent across the parking lot to another building. Do I have a technology problem? I do not. It is a process issue. And if anyone's been involved in any large-scale implementation, and every one of you have, you know that it's not the technology, it's the people and the process that we put behind it. And we must stay absolutely focused on that. Because here it comes down to this. This is the best formula I can give you, and the person who wrote it, it is not mine. It's Dr. Michael Chase, who is head of quality at Kaiser Permanente, Colorado, where I was raised up in healthcare. And I was talking to Mike literally yesterday, and I used to say, I owe you a drink every time I use it, or someone reuses it, and he's going to turn into an alcoholic. It's not helpful. But this formula is NT plus OO equals COO. And that means new technology plus old organization equals costly old organization. Right? Dr. Chase was spot on. And it has been absolutely the most important thing you can walk away with. Because if you think the goal is to take a new technology and simply incrementally add it in, you're going to get back to that loss of the light that we desperately need to move forward. So for the rest of the conference, to incredible leadership, thank you so much for bringing us all into this opportunity to share and to be a part of the panels that are going to be touching on some of this. I hope this has been helpful, and thank you so much for your time. Thank you.
What a visionary. Can you hear me? Yes, what a visionary. Thank you all. That incredible keynote, a perfect reminder that technology without humanity is just hardware. And now I'm thinking COO, I'm a founder and CEO, so it's costly, expensive orgy or something, we just get high. So again, now that vision sets the stage beautifully for our next session, where we turn insight into action. To lead this conversation, please welcome the founder and driving force behind the Global Health Congress, Dr. Ochintya Maulik, along with his distinguished panel of global leaders. Panel 1, setting the stage for the future of global healthcare. How do we solve impossible problems, scale compassion, and still make it make sense on a balanced sheet?
Joining Dr. Maulik on stage will be the leaders who've built, scaled, and reshaped healthcare on a global canvas. Dr. Robert Gabbay, Harvard's chronic care alchemist, rewriting the playbook on diabetes. Mr. Vinay Singhal, former CEO of Fortis Healthcare and founder of SJV Consultants, a Harvard-trained strategist who built one of India's most modern hospitals in record time and later led the Clinton Foundation's health initiative. Lawrence McMichael, healthcare policy architect, turning complex systems into coordinated strategy. Dr. Anu Navani, physician leader and entrepreneur, redefining precision pain medicine through innovation and empathy.
Well, I'm a stopgap leader for this panel. Just get you the real perspective of this. The person going to lead this was Leo Holt, who is actually a shipping tycoon. He's not even a doctor. But he's very good at logistics, and he led the Jackson lab. But he got held up. He's going to come later. And just fun fact, Vinay Singhal was the first person to give me a job. I think second person. Second person give me a job, so give him a big hand. He took the risk. And Larry McMichael lets me have my job. He's my lawyer. Bigger hand. So quickly, a brief note before I tell you about Dr. Gabby. I'm meeting him for the first time. I was reading his CV, very impressive. He's in Harvard. He's done a lot of stuff we're going to ask you about. Anu Navani, I met her 1 month back. She's a force. She's a pain medicine doctor, sold her huge enterprise in California to a private equity, is now one of the leaders in regenerative medicine. So a lot of us here who want to regenerate yourself, she's the person to go to. So the topic today is global health challenges, innovations, and investment panels. I know this is a lot of words together, but I'm trying to frame it and quickly try to get this through the next 15, 20 minutes. And I'll go around the room, and I'm going to start off with Larry McMichael. Larry, what are the challenges you see in current health systems in US when you're seeing it's inequity, large healthcare deserts, a lot of issues that you're facing? As a lawyer, as a restructuring lawyer, where do you see the problems and where do you see the opportunities? Mike. You can speak here, you can take the mic. You can use the mic.
Use this mic?
Yeah.
Okay, fine. I'll stay where I am and use this mic. Can you all hear me okay? So I'm not a doctor, as Dr. Mulek mentioned. I'm just a lawyer, and I specialize in mistakes. I observe mistakes, I make mistakes, and I try to figure out how to fix mistakes. The mistakes that are made in the delivery system in the United States in healthcare have resulted in what Dr. Mulek just described as a massive amount of healthcare inequity. And that's because the system has not adapted to the needs of the current population. And the system is relying on old ways of doing things and old ways of financing things. So a restructuring lawyer like me, we see mistakes having been made, putting healthcare systems in jeopardy. And what are those mistakes? Well, there are a couple interesting statistics that are important to think about. And I'm just going to talk for another minute or so, and I'll let the other panelists jump in here. But according to the latest National Institute of Health survey, which was in 2024, so it's a year old, about 25% of the healthcare systems in the United States are in financial distress, i.e. their potential clients. So why are they in financial distress? Well, it isn't hard, because what they do is they deliver medical care at a cost that exceeds what they get paid for, right? Here's another statistic. Inflation. In the last 3 years, cumulatively, in the economy in the United States, inflation has been just over 14%. It's actually higher in healthcare. How much have reimbursement rates gone up during that same period? 5.1%. So this is a classic example of selling every product at a loss and trying to make up for it by volume. It doesn't work. You wind up in financial distress. And when you wind up in financial distress, you start doing things like, I got a great idea. Let's sell all our real estate to a real estate investor, and we'll just lease it back. We're not in the real estate business. A lot of hospitals have gotten into a massive amount of trouble by doing exactly that, because it doesn't really remove cost. You still have the same cost. All these leases are triple net leases. You're still paying the taxes and the insurance, the maintenance, everything else you were paying before when you owned the real estate, except now you have a landlord and you've got to pay rent every month, and you can't afford to do that. So you've brought some money in the short term, and you have created a long-term problem that is going to make your financial situation worse rather than better. Next solution, private equity. What a great idea. Let's get private equity involved. Now, let me be clear. Private equity is a wonderful thing. There's nothing wrong with private equity. In fact, private equity is part of the solution. It drives innovation. But when you take a money-losing system and you sell it to investors, it's still a money-losing system. How many privately owned, investor-owned hospitals are in trouble in the United States? According to the same survey I cited earlier, and this is the last thing I'm going to say, 35%. 35%, more than the general population. Because you can't just replace ownership and think that that's going to solve the problem. You have to attack it in a completely different way. How do you do that? You listen to people like Hal. I don't know Hal at all. I've never met Hal, but I was sitting back there watching his slides, and the answer is you change the model for the delivery. You use technology in smart ways to bring costs down so that you're actually delivering healthcare at a cost that you're getting paid for, so you don't wind up being one of my clients.
Thank you, Larry. So what I'm going to do also, I'm going to call one person from the audience. I've kept this chair empty. And so I'm going to call somebody from the audience to sit here and to fill in, since I'm going to take it up from Larry. And I'm going to tell you who it is shortly. So Anu, you have worked with private equity. You have built systems. You have built up large practice. What's your opinion dealing with private equity, and where do you see, do you think they will sustain what you built, and what do you see the future?
Great question. I do like private equity
Check
because I
1,
think
2,
it's important
3,
to
4.
have the funding and
1,
investment
2.
to
Check
scale
1, 2.
after a certain point. So I have 25 locations in California, and I don't want to stop at that. I want to disrupt. I want to cross state lines, and I want to be 150 locations, and I want to do it in 2 years. And I don't think it's possible just by myself. That's why we need the private equity and likes. But at the same time, there has to be an alignment of vision, because unless that happens, we fail. So my experience has been tremendous so far, and I think the infrastructure, the funding, the bigger vision that they bring to a normal medical practice, it's unparalleled in that. But again, it really has to be aligned with what your vision is, and that's why choosing the right partner is really, really important.
Thank you, Anu. Larry Kaiser, can you come up, please? You're the person I was going to call up, because you transcend a lot of borders, and I'll tell you how. And I can see you don't need a step. I knew it. He was complaining. We had the event today because of the marathon.
6,
so I'm making him walk now.
7, 8, hey.
So next question is for Dr. Gebe. So I'm going to take this forward, and the future of health is heading towards more of home health. According to Neil Tyson, what's the name, full name? Neil deGrasse Tyson. He says in the next 20 years, 40% of all your healthcare is going to be at home. And you have set up a network of primary care physicians, and you're from Harvard. I read that, very impressive. Where do you see the future? Where do you see the future with the healthcare in the United States?
Well, first, it's great to be here at the Yale Club, and I wasn't sure coming from Harvard whether I'd be allowed in. But I figured if I spoke confidently, the security would think that I belonged here. You know, I think it's really an exciting time, and I do agree that a lot of healthcare is going to move out of the hospital and out of sort of traditional healthcare systems. What is driving that is what we heard a little bit about in the previous presentation, is not data, but information. Being able to monitor, and diabetes is a great prototype of this, where continuous glucose monitors are now ubiquitous. They're even available over the counter. One can look at a variety of health parameters and then be able to use that data to do interventions and ones that are scalable. Particularly the incredible reach and potentially low cost of AI-driven digital health. For example, there are wonderful solutions for the prevention of diabetes that have been, just last week in JAMA was an example of a randomized controlled trial of a AI-driven digital health solution not involving any people interacting, and it was demonstrated to be very effective at lowering the risk of developing diabetes, which you know, is really, in many ways, diabetes and obesity is the global stress test for our healthcare system. You know, in 1990, there were 200 million people with diabetes. Now there are 800 million. It's 1 out of 4 healthcare dollars in the U.S. And the country with the most cases of diabetes right now is India. And that's a place where there's incredible innovation that I think we can learn from because of low-cost solutions that could be scalable.
Thank you very much. That's a very thoughtful insight, and thank you. And our next question is for somebody, and I'm going to come to Vinay Singhal last because he's got a long history. So he's got like 50 years of healthcare to recount. Next, I'm going to come to Larry Kaiser. Larry Kaiser, for those who don't know, I followed his footsteps a little bit. He's a leading thoracic surgeon in the world. A very famous transplant surgeon, chairman of surgeries in Penn. He also was the CEO of Temple. Subsequently, he was with Alvarez and Marsal. I was there for a little bit. He stayed for a long time. And he has seen healthcare in distress. He has led safety net hospitals. Larry, where do you see the future? Mike.
Where do I see the future? Well, first of all, here I am at the Yale Club, and I'm from Penn. So, but I did have a son who went to Yale, so I'm okay. So, who, by the way, when I told him I was staying at the Penn Club, he said, "Stay at the Yale Club. It's much nicer." So, where do I see the future? Well, I think one of the things we're seeing in this country right now is the movement. The centrality of medical care is no longer the inpatient setting. I don't think there's any question about that. And what we're seeing is the movement toward outpatient and then into the home as well. I think when you look at specialties like orthopedic surgery, 50% of orthopedics is already being done in an outpatient center. In urology, doing prostates in ambulatory surgical centers as well, sending patients home the same day. So I don't think there's any question that despite the fact that the inpatient setting is the biggest driver of margin, moving those cases to the outpatient setting is better for patients. It's easier for patients. Patients want to be treated closer to home. The systems, and as I've traveled around the country as a consultant, the systems that are successful are those that have a robust outpatient strategy right now. And again, into the home as well is where this is moving. But I think when you look at what could be done in the outpatient setting, and we learned a lot about this during the pandemic as to the types of cases that can be done in the outpatient setting. It looks as if CMS may remove the inpatient-only list as well. There was discussion about that just this past week. And if that's the case, I think you're going to see more and more cases being moved to the outpatient setting. So I think it's better for patients. I think certainly it's a less expensive way to provide care, and care can be provided, I think, expertly in the outpatient setting. So the challenge now is, what do you do about the margin that you're bringing out of the inpatient setting? And it's going to be challenging. Certainly the payers are very happy about moving things to the outpatient setting because it's less expensive. So I think we're just going to see more and more, and especially with people wanting to be treated closer to home.
Thank you, Larry. And last question for Vinay, and then some of you are going to stay back on this podium. I think Larry stays back. And then I'll ask Vinay to stay back also for the next round. So you can carry on your thoughts into the next session. So Vinay, he's the founder, CEO of Fortis Healthcare. I was his first hire as a doctor. He's not regretted it, I hope. Anyways, Vinay, where do you see India today in healthcare? And and now you're in US for some time, your son is in Citibank. Where do you see American healthcare? We were the first people to get Mass General and Brigham into India, if you remember, in 99, 2000. Where do you see us versus here in America versus India?
Well, good morning to everybody here. And it is only Dr. Achintya Malik that I'm sitting here. Otherwise, I have not much of a role. But I want to tell you a story first, and that is that back in 1997, I was working with Ranbaxy. Ranbaxy, you all know, was the largest pharma company of India. And there, one day I was called by the chairman of the Ranbaxy, and he said, "I'm looking for a CEO for a hospital." I said, "Sir, I am a mechanical engineer, and I don't know that part of the world, that part of the thing, because I have not even, fortunately, I have never been to a hospital or lived there." So he said, "No, but I want a medical person to take charge. And he said the job is to set up a 300-bed hospital. And he gave the timeline as 18 months because he at his end had lost 1 year already. So he said that that year is gone, so you will have to cover it up and you have to make this hospital in 18 months. And this hospital should be the best in India, of course, but one of the best in the world. Now, I said that either I'm crazy or he's crazy, but anyway, the diktat was from the boss, and so I took it up. And I say that with the help of people like Achintya Maulik, and I will tell you how does he come into the picture, but we could complete a hospital, make it the best in India, of course, but maybe somewhere, I don't have any ranking, but somewhere there as the world's best. And this hospital got the first prize of architecture by the American Society of Architecture in those old days. And that hospital is a signpost for anybody who wants to go there and see it. It is now JCI approved, and it earns the maximum revenue out of the Fortis hospitals and is treated like that. But before the hospital was commissioned, the commissioner of that hospital's operating room on the 18th month was Dr. Achintya Maulik. And Achintya, we got to know about him that there is a bright young doctor in United States. Actually, my daughter-in-law told me that there is a doctor I met who recommended that one Dr. Maulik would like to go to India. And I caught hold of that lead. And then we were having meetings here and there. Sometimes he was watching a movie, sometimes I was watching a movie, but when the call came, we took that up, and it went on for a month or two, and there he was kind enough to accept the offer which we were giving, which was peanuts, I can tell you right now. And he joined. And when he joined, he ran the hospital medically in such a way that that hospital came up to these heights. Now, this is the part of the story which I definitely wanted that you should all know. This conference, I am totally stunned that how he has organized this great conference. Of course, I see many faces who are back from India, but this conference to organize it is not a joke. So when he called me up, I said, this is fantastic job which you are going to do. Anyway, so this is where we are. I'm probably exceeding my time. So what I want to tell you, the question which he put forth to me is, where is India? India, as on today, is the 4th largest economy in the world. And within next 2 years or 3 years, India will be the 3rd largest economy of the world after US, China, and then India. And this thing is written, I mean to say this cannot change because the developed nations are increasing their GDP by 2%, while India's GDP is rising as 7% or 8%. So this has to happen. Now, when this happens, the biggest problem which I see in this healthcare scenario, that one end it is India having about 150, how much, 1.5 billion population and so on. And the other side is USA, the richest country in the world. But they are spending 17% of their GDP on healthcare. India is spending 3.3% of the GDP on healthcare. The rise of the age that we can live at up to, what is it called? Some specific name I'm forgetting, is 75 years in India and 78 years in USA. With all the resources, with all the medical inventions coming from USA, because they only have the money. Apparently, this is what the world thinks, or at least the people in India think. But why this is happening? There are different problems. I just heard 3 people saying that there is no money and the institutions are losing money and so on. Well, if this is happening to India, what will happen to countries like India? So there is a ray of hope, and that ray of hope is how do you deliver that healthcare? On the other side in the world, if we take the picture, Taiwan, South Korea, and such countries have actually much lower expenses, but quite a good healthcare. Even in JCI, Thailand has about 55 hospitals, and India has 62 hospitals which are covered by JCI. So there is a system, or I would like that there are about 25 or 30% doctors ex-India who are working here. And I think one day, if India and USA can combine together and work together, one will bring in all the digital things like AI and ChatGPT and so on and so forth. Telemedicine has already moved in. And the other side provides the manpower, which is available. Of course, India needs, first of all, more, but they can come to any place in the world.
So Vinayji, so let's hold the thought for the next session. You can continue this thought of getting cross-pollination. So this brings back memories 25 years back. Whenever I let Vinay speak, I had to go late for my surgery. So, but he is very profound, and you're going to hear a lot more from him. Thank you, Vinay. Keep sitting there. We can't get you on and off the stage. It'll be difficult. So you're sitting here. So guys, take on. You sit here.
Thank you, panelists, and thank you for joining us. I also would like to announce that we have excellent panels going on on 18th floor in Trumbull Room. We have venture capital stimulation.
Yeah, so before we move to our next panel here in the Grand Ballroom, I just wanted to mention that in the Trumbull Room, which is on the 18th floor, so it's 2 floors down, we have our experimental learning session. They are in full swing. It's from venture capital simulation to AI workshops and even wellness experiences. So if you want to sneak over and check them out, that'll be the perfect time. It's where the hands-on magic is happening. So, all right, back to the center stage, because the next conversation is one you don't want to miss. East meets West, bridging healthcare frontiers. Next up, East meets West, where ancient wisdom meets cutting-edge science and somehow ends up in the same hospital corridor.
This is what happens when Ayurveda and AI share a patient file.
Exactly. The conversation isn't about who is right. It's about how collaboration makes everyone stronger.
And we have got the dream lineup to prove it. Dr. Samin Sharma, Mount Sinai's Stent King, redefining cardiac precision with surgical poetry. Dr. Larry Kaiser, whom we just heard, a legendary academic leader who turns hospitals into institutions. Dr. David Berger, CEO of University Hospital at Downstate, the man giving Brooklyn its own healthcare blueprint. Mr. Ravi Singh, global strategist and connector across borders, bridging system and economies. And guiding the powerhouse panel, Mr. Prashant Sharma, the quiet force behind big ideas and the man who reminds the real bridges are built on shared purposes. Mr. Sharma, please take it away.
Good morning, everybody, and thanks for being here. The only person on a stage who needs an introduction is me. Rest of the all erudite speakers are brilliantly placed. Starting with the handicap of succeeding with Dr. Achunta, who is both brilliant and so funny at the same time. I lack both these qualities, so please pardon me for that. So I come from India, and I'm heading a healthcare system called Charnock Hospital. So we have a few hospitals there. My mandate today would be to sort of have a balance between comparing US and Indian systems. So let me just paint a picture globally. US, you are all aware that the kind of spend that US is doing on healthcare, close to 20%, and the advancements and all the systems that US has in place. If we transverse eastwards, Europe would be about between 8 and 9%, most countries around that level. Very saturated, a lot of healthcare systems. Eastern Europe probably slightly less, about 7-ish. If you move to Asia, overall it's about 5 to 6% of the GDP is spent on healthcare. Most of the countries are doing a phenomenal job. For example, Thailand, Taiwan, they have universal health systems which are embedded both with inflation and cost raises. So they have a system which keeps them going. Japan is another great example. China, we don't have a number because the data is what they want us to know. So it's very difficult to understand what's happening in China. Although in China, most of the healthcare is only government healthcare. There's hardly any private healthcare. 95% of the hospitals, and these are very large centers, mega centers, 4,000, 6,000 beds, in which from a billionaire to a bottom level worker, they all go and they access different levels of accommodation. India in this whole scenario is about 2 to 2.5%. But most of this money is spent by the government on primary care, reaching out to the masses, reaching out to the larger scale for basically treating the masses to primary level consultations. Most of the tertiary quaternary care in India is being done by the private sector. So today, the split between private and government sector is between almost like 1/3, 2/3. 1/3 being handled by the government and 2/3 being handled by the private sector. Large systems, large chains have come on board. Now, there are few enterprises which are 10 billion plus. We have 3 of them in India. And with the kind of population, with the kind of spending that's going to happen, so that is probably only going to rise in the future. Newer and newer health systems are coming on board. More health systems with multiple thousand beds are all in the charts, and it's going to come in the next few years in the market. So we have a very interesting panel here, and let me start firstly with Dr. Samin Sharma, who doesn't require any introduction whatsoever. He is a stalwart by himself. And Dr. Sharma, you have seen the best side of both sides of the world, and what would be your take on India versus US and the connects and the sharing and the learning?
So great. I mean, this question always comes up. What is the delivery of care even in America? As we know, that 10+% are physicians. They deliver almost 30% of the medical care. And from India point of view, we have spoken already how much money is spent and so. So concept of universal insurance, so everybody should get medical care. We say it here, but are very fragmented, as we all know, in terms of what type of insurance person has, where they can go, not go, approval, not approval. So there's a lot of complexity of the healthcare in America. And most important is the expense of doing the business. It's so expensive, so you take a one bed, just to say that how much money is spent to take care of the one bed, compared to what is money spent in India to take care of one bed. So it is a multifold. That is one of the region that many of the hospitals are having a trouble. But India as such, just want to say, there also the concept of universal insurance. Many of the schemes have come, particularly Ayushman Bhava, many of that everybody should get a health care. And the division of the Medicare, Medicaid type situation that is happening also. But still, the majority, the elite care in India is still being delivered by the private sector. So clearly, there are government-run hospitals, but still the elite care is still done by the private sector. And That, I would say, probably the major difference here versus there. Here, anybody can get to any center without any issues because of the ethics of the medical care we have. Compared to India, only people can get to the elite care or private hospitals, which will be spending some extra money. So there are clearly differences. I have my own hospital in Jaipur, and I know the difference being working there and working here. But by and large, equipments are the same. The manpower is the same, or knowledge, I would say medical knowledge is the same. The issue just remain in the infrastructure, what we always have been blamed, having infection and so, but all those things are getting better from Indian perspective.
Thank you, sir. And what he talked about is Ayushman Bharat. So that's the largest universal healthcare scheme which has been rolled out by the Modi government. That covers everybody. The entire spectrum of population is covered by it. So in fact, a farmer can go to a tertiary care hospital, flash a card, and get a bypass surgery. It's a walk-in facility. There's no wait time. And the highest level of quaternary care is available for the masses. So that's dramatically changing healthcare in India. That provides access across the board. So, sir, that is absolutely a game changer. Let me also invite Dr. Purnendu Roy to please join us on stage. And he's a renowned surgeon in India, runs hospitals in Eastern India, and he will be joining us on stage. I believe that Ayash Tiwari could not make it on time because he's stuck in due to logistics. Surely. So let me move to our next speaker, and Dr. David Berger. So Dr. Berger, if I can ask you about your perspective on the matter, especially given the cross-learnings across doctors, health workers, and mobilization of people, given that the technology is now bridging the gap of language barriers and access issues.
Yeah, so thank you. And I want to, first of all, congratulate Dr. Mulek for the vision of having this conference. I believe global healthcare is essential and healthcare is global. I also agree with Mr. Wolf when he said that healthcare is a right. Those are two of the most fundamental things you're going to hear over the next 2 days. The rest is implementation. So I'm going to throw out a really big idea, and you can agree or disagree. And another thing Mr. Wolf said that I also agree with is we currently have all the technology we need. It's the people and the processes that are the major barrier. And the big idea is, how do we globalize the healthcare workforce? We, and not just the United States, but governments across the world, have created artificial barriers to allow practitioners from one country to practice in another country. Those are the things we need to start looking at democratizing. And AI, digital health, technology, drones, telemedicine, all these things are now available so we can standardize healthcare education across the globe. We can deliver services and medications to remote places throughout the world. We can lift up impoverished nations and populations by training them in healthcare and being able to provide to their populations. So this is, while it's great for two of the largest economies in the world to have these interactions, healthcare is a global issue. Charging $100,000 for an H-1B visa is absurd. We should be looking at decreasing those barriers, not putting more of those barriers in place. That's the big idea I want to throw out there. How can the people in this room influence their governments? You know, a lot of people have very, very significant positions, to start moving the needle to be able to globalize the healthcare workforce.
Thank you, sir. And so on one hand, we have the barriers to entry, and this is practically in every country. For example, Indonesia, most of the countries are having these massive walls which disallow clinicians to move back and forth and have practices shared. And also there is demand-supply situation where Asia is producing a very large number of qualified health force, which can effectively fulfill the gap of the lack of manpower, both in Europe and America as well. So Government of India has a policy which is called Heal in India, Heal by India. Heal in India is primarily towards medical tourism, and Heal by India is to teach people and provide them with knowledge and information and certified training so that they can go to the rest of the world and provide these kind of services, especially in countries which are lacking the younger workforce. Thank you, sir, and I think technology is only going to help us in building and sort of scaling up this issue. Let me move to Dr. Purnendu Roy. Dr. Roy is a renowned surgeon. He was also running Genesis Hospitals in Calcutta. He has been a regular speaker, and he has a fantastic talk coming up as well. But before that, let me also ask you, what is your perspective between, you've seen both sides of the world, you're practicing in India for the last many decades, and what do you think would be the lovely sharings?
Thank you very much. Before I got onto the stage, Chinto was giving me certain indication. He kept saying this. So I interpreted that as a single malt whiskey, one small peg, but he's saying, please cut it short and don't talk too much. I think instead of going into that, what I try to say is just like your residence, just like going and having a dinner, just like going on holiday, there could be different classes. Now, trying to globalize and make a same care of healthcare for everybody across in a democratic or a capitalistic country is going to be difficult. If you are having a socialistic country, yes, I can understand that you can enforce the system. I think there is a possibility, like in India, there is a 7-star hospital which will be running and making money, and also an average place where in private sector, in a very low budget, you can give the things, and also government sectors will take care of it. Over here also, if you feel that everything will be like standard of Harvard, Yale, Stanford, Caltech, no, I'm sorry, that is not going to be possible. This bell is continuously making me remind for my surgical conferences that, Ting, it's enough, please. Next, we are going to cut the electric connection from your microphone. So all I'm trying to say, instead of adding all these huge jargons, that yes, there is positivity, and actually healthcare can survive in every place as long as you accept there is going to be A plus, A, B, C, and different types of healthcare. You can't equalize in a capitalistic country. That's the message, and we all should feel optimistic. Just to end, I'll just give a small quote. What is optimistic thinking? When I look up to the beautiful blue sky, I see lovely birds fly. Unfortunately, it popped in my eye, but I don't feel sad, neither do I cry. I only thank God that cows don't fly. That's an optimistic way of thinking.
Well, when you have people like Dr. Roy here, then it's very difficult to not be absolutely entertained and thrilled at the same time. Speaking of what you said, sir, so let me move to Dr. Vinay Singhal. And so when you had put up the system a few decades earlier, Indian consumers were very different. Most of the consumers were out of pocket. They would pay for their own treatment. But today, the consumers are different. You have 30 to 50% which are out of pocket. You have 30 to 50% which are insurance backed. And then you have another 30% which are government scheme, which Dr. Samin Sharma mentioned, like Ayushman Bharat. So there's a whole spectrum of consumers, ones who are alighting from Maybachs and one who are coming in rickshaws. But a system must provide equitable healthcare to the entire spectrum. A lot of people are building systems which cater to these. For example, large hospitals which are 1,000 beds, which cater to all spectrums of this society, are also now coming up with educational facilities. But the consumer has changed completely. And how do you see that now, sitting from where you are?
See, India for ages did not have any substantial insurance. And traditionally, the healthcare was delivered either by charitable hospitals, which were run privately, and by the government, which ran this as a public entity. Now, naturally, the public entity hospitals were totally free. And so anybody who wanted healthcare, he would go to those hospitals. But since those hospitals were overcrowded and they were not able to provide enough solace to that class, they sold off their things and went to the better hospitals which were in the charitable thing, which were also very insufficient. What the government has done is the government has virtually covered 50% of the lower class of the people who can't afford to, they have covered them with insurance. And so 500,000 rupees is the insurance money available per year to a family who is below the poverty line, and they have a specific card to avail that benefit. And so they go to any hospital, the best hospital. Say the best hospital is Fortis Hospital, then they will go to Fortis and they will avail facilities up to 500,000 rupees. This has made the out-of-pocket expenses of the people, which were actually making people really poor, to come down from 60% to some 40% or 30%. The actual figures keep changing. Now, when this is the situation going on, we aim, and the government of India and the people in India aim that after 10 years, everybody should get tolerable, good health care. The difference between the top rank and the bottom rank will remain. India is a democracy. Unless until somebody makes it a dictatorship, I don't think that that thing is going to happen. And then we have this example of USA. Everything is there. The money is flowing over. Nobody spends 17% of their GDP. GDP, mind you, because the American GDP is the highest, then the figure is also very high. And no country spends this much money. But American system is 29th in the world, corresponding to the quality of delivery. So something is wrong. But if suppose tomorrow America stops doing research and devising the newer equipment or newer medicine or newer ways, the world cannot progress. So there is a big need of collaboration between this side and that side. And that is what I was trying to request you, if we can have a discussion, it will be very fruitful.
Thank you, sir. And on the issue of collaboration, and let me invite Dr. Kaiser here. So from being a physician, and you've seen the entire spectrum of collaboration between both geographies across the world in so many different ways, how do you think this collaboration can benefit both sides of the world, and what's the best way to go forward?
Despite the fact that we have a lot to learn from many other countries that have universal health coverage for all of their citizens and have it available, unfortunately, in the richest country in the world, which is the United States, we still have millions of people who are uninsured, and likely, with the current administration, we're going to have more people who are uninsured, especially if they have been used to buying on the exchange with the wipeout of the subsidies. So it's a tragedy that in this country we still have people who have trouble accessing health care because they don't have health insurance. And unfortunately, even if they do have health insurance, we still have access issues in this country that need to be solved. And I'm sure that in India they still have access problems as well, just with the size of the population and trying to access health care. But in this country right now, try to make an appointment with a dermatologist, for instance. So access is a huge issue, and I think it's probably an issue in many other places, despite the fact that essentially every other country insures all of their citizens. And yes, it's been mentioned before, we are spending close to 18% of the gross domestic product in this country on healthcare, despite the fact that our results are not as good as most of the other countries in the world when you look at things like maternal complications or maternal mortality, whatever you look at, and you can say, well, we just monitor it and we measure it more closely, but I think it's not just that. So we spend more money and our quality is not as good as many others. So we have a lot to learn from many of these other nations around the world who are doing it better than we are, despite the fact we certainly have the technology here to to answer many of these questions.
Fantastic. So what the US can teach India perhaps is what it can share expertise is on capital, experience, expertise. And perhaps what could come from India to this side of the world would be labor, innovation, IT, and solutions to frugality and so many other things. Before we end, because I think the buzzer just went off, can we have closing remarks from Dr. Samin Sharma as to how he thinks?
Yeah. So no, I mean, this kind of forum and many others, knowing that we each need to learn from our respective areas, that how can we, in this day and age of the AI, there's so much advancement and such a cross-training can happen. More and more kind of this discussion will yield to more close collaboration and expansion of the healthcare in a different way in India and a little different way in America. And I'm so glad that we had a very lovely session, opinion from all the experts, and we'll continue to have it in the next 2 days.
Thank you, sir. Thank you very much. And just as a departing thought, I'd leave you with the thought that the fortresses which were created 20 years ago, the Max Healthcare, which have reached more than 10 million valuations, at least 10 more systems in India are on the way in process. So one, Aviral is sort of leading and to create a system which will be about 1,000 beds. We are creating a system which is me, Meghdut, and with Dr. Achunta, which will be almost 1,000-bed hospital, 1,000-seat medical college, 10 such units about in different parts of the world, which would be, in terms of valuation, a very attractive proposition, both with clinical and academic background. India has a mandate of doubling its clinical seats in the next 4 years. This government is very proactive in taking those steps. They are reducing regulation. They are allowing medical college in private institutions. Most of this innovation and this growth is being driven by the private sector. And it's amongst the entire spectrum, if you look at the atlas, then probably India is the most potential area for investing into healthcare. With this, I invite you to my country, and it's great experience having such wonderful panelists and such a lovely audience. Thank you.
Thank you. Thank you.
Well, this was fascinating. If people in the back don't mind sitting, if you guys are getting tired, but this was really fascinating. Look at the collaboration break boundaries, and now we meet the man who breaks the digital ones.
Few names in healthcare technology carry the weight of innovation and integrity quite like his. He turned a startup idea into one of the world's most influential healthcare platforms, eClinicalWorks, a system that now connects over 1 million medical professionals worldwide.
He's a visionary who saw what most didn't, that data can save lives if you take it with empathy.
Please join us in welcoming to the stage the CEO and founder of eClinicalWorks, a pioneer who's reimagined how care is delivered, Mr. Girish Navani.
Thank you. Can you hear me clear? Well, that's not me. That's the older version of me with a mustache, but that's great. Well, I think it's been great to be here this morning. I don't know if you can all hear me loud and clear in the back, but while I'm hearing stories around digitization in US and India, I'd like to put a footnote that I had not planned to say, but we're seeing the same acceleration of digitization in India that we heard of this morning. I think there is a big demand to go ahead and do what the United States did over the last 20 years in trying to digitize its own healthcare system. We are seeing similar equivalent technology transformations happening in India. The difference now is that it's becoming an AI-first capability. It's not just a traditional world. My talk this morning is to try and give you certain problem statements and then show you some live demonstrations, if they work, including a smart glass one. So pay attention to it. Your phone's not going to be as exciting as this phone, the glass demonstration. We may actually make that phone obsolete in a few years. Welcome again. AI, we've heard this word and you're going to hear it for the next 2 days. I don't like to say it's artificial intelligence. I think it's the age of intelligence. It's nothing artificial about it. There is something very, very profound and real in this world that is impacting us daily. It is allowing us to overcome barriers of language. It's allowing us to think and reason a lot more faster than we ever did. It's going to help us transform a lot of care delivery and definitely improve our lifespans and help us live better. So there's nothing artificial about artificial intelligence. We are all familiar with chatbots. I think we use it, and that's what we think the world is about, whether it's ChatGPT, Gemini, or anybody from Claude or any other technologies you use. That's not the end-all and be-all of AI. That is just a mere front end to the capability of what a model does for you. So do not equate a chatbot to the world of AI when somebody mentions that. That's my first talk to you. If you look at what something changed profoundly even the last year for a company that makes over $100 billion a quarter now, is Google search. We all were familiar with the blue links. We always thought those were the way you surf the web. And then you realize very saliently in the last year that the Google search model changed to not just including blue links, but now it has an AI mode that basically summarizes the entire web for you, so you don't have to end up clicking. That is something remarkable that just happened very quietly and very distinctly in this technology platform that we use. So where do we see AI coming into healthcare? That's the question and the topic of the morning. Before I get into it, let's also talk about something else that's been happening, and we've been a part of it, which is the revolution of the user interface. You remember the day we all got a personal computer in our homes? We moved it out to a smartphone a decade or two later and got addicted to the pinch, zoom, and swipe. We still are, if you can watch this room. And then we all got to wearing some form of wearable. That became our mode of operandi for information gathering and accessing, a smartwatch. How does this thing also play into healthcare with AI is the interesting intersection of technology. Let's remember this world before, because we're going to forget it soon. I was at Boston University when the first Macintosh showed up in the library, and there was no end of excitement that you could end up writing your paper on a computer with a mouse and a keyboard. And it transformed how we ended up doing our work assignments, to a point where we took this model and put it in every one of your offices if you were a doctor or a clinic or a hospital, computer on wheels, and told you to spend more time on the keyboard and less time with the patient. That was a genius idea of technology, and I am part and parcel of having done that. But there is where the world starts changing quite quickly as we look forward. You may see a world where this artifact of technology does not exist in a waiting room, in an examination room, or anywhere else in healthcare. How is that possible? Well, let's start with ambient listening. While we think this is cutting-edge technology, inside my workplace, we are thinking of this as mature technology. It is how fast software and its capabilities are moving forward. Something that was so new and innovative 18 months ago feels that much more status quo and understood. So let's talk about something else. But before I assume that every one of us in this room is familiar with it, I took the time and the liberty to try and explain it. Ambient listening is the capability of a phone, a microphone, listening to a conversation between a provider and a patient, independent of any language, independent of how many people are in it. And eventually, at the end of this particular exercise, 20 minutes on in an exam room, including if there was more than one person in a room, like a pediatrics practice where there's a mom and a child, or if there was something that needed to be done for coding because the insurance company wouldn't pay for that visit unless you coded it properly with ICD-10s, or for the orders that had to go to the pharmacy because you didn't want to sit there and pencil those by pen and paper. Technology got to a point where it could handle this, and it could handle sequential interactions, whereby you could start the conversation with the nurse, take it down to the level of the provider, and then eventually summarize it all into one note, one order entry system, and still get it done at the end of the visit without having to click on your mouse or your keyboard. This is relevant technology today. There is nothing so exciting about it that you've never seen or heard of this. In fact, we've seen the fastest increase of this usage in doctors' offices across the United States. We compound this growth every single day now. I mean, there is new benchmarks of usage happening on a weekly basis. That is how crazy and how exciting it is. We'll probably end up crossing over 10 million visits just this year being done with technology, and next year I think it's going to be 50. That's the speed at which this particular technology is getting accepted by providers. So what's next? Well, it's getting used in ambulatory surgery centers, even when the patient's sedated. It's covering most languages, so you're not tied to English. You can do Spanish, you can do Mandarin, you can do whatever language you want. Doctors love it. I'll skip that part. So where do we get to? That was ambient listening. Let's talk about the ambient computer. What is it? Well, you've not heard of it before, so you can go back after this weekend and say, I just learned something new. There's a story to tell before I get into it. The story is of a teddy bear that started right here in New York City almost 2 decades ago. I had a talk here in the city when the Primary Care Information Project was underway. And a provider walked up to me and said, you know, we had a patient walk in today with their mother. And while at school, there was an exercise given to sketch the doctor. I thought it was an exciting picture that the patient would end up drawing, and it would be one with a stethoscope. To his dismay or excitement, I don't know, the patient actually drew a doctor with a computer in his hand. That's the perception of a child seeing their physician in an examination room, was not one with a stethoscope, but was that me saying stop? Okay. Or that was one of a computer in a physician's hand. So wherein lies this teddy bear story in 2025? The reality is you don't need the computer either, you still need the stethoscope. So there's a new teddy bear in the midst of us. It's the one wearing glasses. That's all I need. That's all you need. And I can take that smart glass into an exam room today, and I can have my entire conversation with a patient. I can take it outside my examination room, go watch my son play a game of soccer, and still take my electronic health records with me. I could be driving into work in a busy traffic place and catch up with my morning and not have to wait to get into the office to see who's my next patient and try to understand my schedule or my existing messages. It's about putting that entire electronic health record on your glass so that this article that came out in the New York Times just a few weeks ago that says that a smartphone might become a device of yesterday. Pretty remarkable that we think that the Macintosh that we don't use anymore, that tomorrow I may stand in front of you or somebody else will tell you that the phone you carry in your pocket today will not be relevant and you won't be carrying it. Instead, some form of an interesting wearable called an ambient computer will help you. By the way, that's what we've done. So we've actually put technology now on a glass to allow a physician to be as productive as they can. We gave out 4,000 of these glasses this October to every one of our attendees at the conference. We started getting pictures on Mondays, doctors wearing glasses into an examination room and seeing their patients, communicating, listening, transcribing, doing their visit. Orders get sent, prescriptions get done, labs get completed. You don't touch your keyboard. You don't touch the remote. That's what an ambient computer is. If technology works, I'd like to show it live. We have a few minutes. You want to see it? Yes. Let's see if it works. I got to connect it to your speaker system. That's the only interesting problem. It's a regular smart glass. Hello, Suna. Can you connect this to the speaker system? Hello? I can't hear it. It's not playing even for me. Hello? This is not technology right now. I just need to connect it to your AV system in the back. It's not paired up. We'll give it another 10 seconds, else I'll continue to switch because I know we need to. But you love seeing what technology really can be and is today in the day and age of computing. Does it? Ready to go? Let's see. We'll give it a try again. Can you hear me? Hello, Suna? Let me continue with the talk. If this works, we'll do it at the end. Okay. So we've talked about this computer with a keyboard and a mouse. So I drew an interesting picture for you, one with a computer that doesn't have a keyboard and a mouse. But then why would you need it? Well, you need it for interesting data displays to your patients. Because you're talking to them or patients in the exam room. How do you communicate? Well, I think you just put a screen on your wall. And that's all you need to do. You wear glasses, have a television, and you talk. And as you converse, as in real-time communication happens, information starts changing on that screen, and patients follow along, and you can have in-depth conversations with patients and have them educated in their care plan care. That's what we call cards. These are cards that listen to conversations that are happening in real time and stream them up in front of a television screen that you can talk to your patients about. If I'm talking about your lab results will come up on the computer screen. If I talk to you about your prescriptions, it will show up. So I can have a patient visit without ever having to look at something else other than a common display. I'll skip the video as well. Let's just continue. So where do we see technology going? Well, I witnessed it live a week ago at the Meta store in Best Buy. Sam and I went there because Meta just announced glasses with pop-up displays. Our goal is to put technology now so you don't even need that television screen, because you will see while you hear something in your pop-up display of glasses. That's technology in today's day and age. Ambient computing. You can play that? Oh, there was a loud applause to hear it, so we'll try it one more time. Hello?
Good morning, Dr. Willis. It's Saturday, November 1st, 2025, 11:14 a.m. here in New York, with mostly sunny skies and 52 degrees. We have 2 telephone encounters to review today, 0 e-prescription refill requests, 4 unreviewed labs, 3 unread messages, and 3 patient appointments on your schedule. I'm Teddy, and this is your morning briefing. Let's start with telephone encounters. There are 2 to review. The first is for Laura Smith, a 48-year-old female who called regarding a rash. She reports developing a mildly itchy, red rash over both forearms and lower legs. She hasn't started any new soaps or detergents, hasn't traveled recently, and hasn't had any insect bites. The only recent change is starting hydrochlorothiazide about 10 days ago. Would you like more details about Laura's encounter, or should I move on to the next item?
Actually, could you send this telephone encounter to my nurse Samantha Jones and book an appointment?
Absolutely. Dr. Willis, I hear you. What would you like to discuss or clarify before we continue?
Could you take a pause for a minute? I need to go see my son score this goal. I'll be back in a few minutes.
That's an interesting thought, Dr. Willis. Could you clarify a bit what you mean by being people's
There it goes.
demand
That's okay.
on the source of the story of
We
the
can cut that one
vaccine?
off now. But you can actually talk to it if you're not hearing echoes. You can pause it. You can continue it. You can keep on. But let's just go back. Let's just go back. I want to talk to you about something else as well before. He did score the goal. I can actually restart it now. But there's another problem statement I want you to look at. It's your offices. We talked about staff shortages. Phone calls come in Saturdays, after hours, during the day. Monday mornings, you do not have enough people to take them. Your front offices are overwhelmed with technology. It's becoming difficult to keep up, and you're not going to be able to handle it. That's where comes voice models, where you got your front desk that's busy. They also need to get up and then take the insurance card while they put somebody on hold and say, well, I'll get back to you again. What if this experience also changed as fluidly as the watch experience? And now you actually have nobody at 4 o'clock there to take a call, yet you have an AI model that works for you. This is so fabulous. I've been listening to these calls as we have been deploying it with the permission of our practices. It is heartwarming to see how patients get help on a Saturday or a Sunday, get a refill handled, get a phone call answered with technology that is so fluid they can understand a patient, different languages, and you don't need to worry about staffing models and all. That's what Genie does. What it does is becomes your contact center agent for you. Can take any patient phone calls, can help them pay their bills, book their appointments, do their refills, get you an on-call provider if you have one. That is technology that is relevant and prevalent today. How am I doing on time? Doesn't matter? Okay, well, we're going to show this to you live then too. Why not? Is that okay? Great. Well, I'm going to try and take the liberty of showing this capability live. This one, I'll just use my lapel so I don't need to do this. I'm just going to call into a doctor's office this morning because I need to see somebody today, and it's a weekend, so why not just do it live? You hear it?
You have reached Westboro Main Street Medical. Please call 911 if this is an emergency. This is your AI assistant, Jesse. How can I help you?
I'm not feeling too good. I got a severe headache. Can I speak to the doctor on call?
In order to connect you with the on-call provider, I need to verify your identity. Please provide the patient's first name, last name, date of birth, and registered cell number.
First name is Girish, last name Navani, date of birth 1/1/1970, date of birth, cell phone actually, 774-275-0562. It's not my real number, don't write it down.
I was unable to find a matching patient.
It's okay, you get the idea. I purposely did that. You get a link, you verify, you can talk, get your messages out, on-call provider calls you. That's how fascinating it is. It can handle all languages too, makes it that much easier to provide access. Well, why did I get to talk about these AI projects and not the other 50? Because I think the problem statements are very clear. Physician burnout, clinical staff shortages, figuring out how to efficiently run, have just these on-call providers we'll skip some of this, we'll get to it. The bold statement you need to ask is the traditional, we've heard this morning from speakers, is new technology, old organization the solution, or there is new technology and new organization to create better processes that create better access for patients? While we can solve problems many different ways, I think you've heard of RPM solutions for monitoring patients at home. You can also look at interesting technology that can further create less burden for physicians as they see their patients, give them more time, allow them to manage chronic care conditions and actually order that test so they're not busy typing and they're busy listening to the patients. Those are stories we hear. If you look at your staff, that's basically getting burdened because they need to multitask too much. There's technology that solves it. It goes on, whether it's your revenue cycle management department that automates claim submissions, whether it's faxes that come in that get routed electronically now, you don't have to have a person do it. AI is here. AI is not tomorrow's buzzword. It is not a chat bot. It's not Google search that gives you an AI mode. Those are all simplistic use cases. There are far deeper ones that you and I can implement in healthcare that will have meaningful benefit to human life. There cannot be a better technology transformation other than what I just spoke about. We're excited to do this. We're doing it at scale. We're doing it at size. So if you don't trust whatever I said, at least relevant, trust me for this. 2 decades of doing this in the United States, almost 1/3 of all outpatient visits now go through eClinicalWorks doctors' offices. We're seeing this day to day. We're able to make an impact. What we're also seeing is 700+ hospitals live in India now, digitizing not just with billing systems, but with clinical systems. When you heard the speaker speak about academics and private sector getting together in India, that is real. There is a great pinch and demand to go ahead and build out more bigger technologically advanced systems even in India. So I think this global health conference seems to bring both together in this place. I think it's a venue where you should look at opportunities of not just digitizing, transforming, and putting intelligence in your practices, but how you could probably do it far out east as well, all the way back in India. So thank you again for the time to come speak to you this morning. I hope you found and learned something new that you didn't know of. Oh, thank you.
I am speechless. I am speechless. I love it. I want to have it as soon as possible. You were always my favorite person. Now I'm a fan.
Okay, good. Thank you, Dr. Bajaj.
All right. So, moving on. Thank you, Girish. Pure gold. From code to compassion, you make tech sound almost romantic.
And speaking of romance, Nikki, calm down. Our next session explores medicine's newest relationship status. It's complicated.
Will AI replace physicians? Very appropriate right after that. The robots are learning empathy and the doctors are learning Python.
So will the machine replace us, assist us, or just keep asking for more software updates? And we just saw that technology is there, but then AV system doesn't work. Well, let's find out from the people shaping that future right now.
All right, so leading the session, we have Dr. Rahul Sharma, Cornell's Emergency Medicine Chair, mastering chaos with calm and showing us what leadership looks like under pressure. Dr. Ronald Razmi, AI entrepreneur who translates algorithm into application and buzzwords into breakthroughs. Dr. Saeed Ibrahim, National Academy of Medicine leader, making sure innovation never forgets equity. Jyoti Rai and Lama Mohammed, voices at the intersection of intelligence, humanity, and the digital design.
And Mr. Ravi Singh also, we would love to invite you over for this panel. And if ChatGPT ever develops bedside manners, we'll thank you, all these people here, to help us guide through it.
Please welcome our panelists for Will AI Replace Physicians?
Okay, great. Thank you so much. What a great segue from our last talk, and I'm really excited to get that device as well. But I always tell everyone that if you have a great idea and you want to successfully kill it, just get your legal and regulatory people on board, which I could see being the issue. But I really want to commend our previous speaker for really having that great discussion on AI. Now, good morning, everyone, and welcome to our session on one of the most provocative questions facing healthcare today. Will AI replace physicians or humans? Artificial intelligence is already transforming how we diagnose, document, and deliver care, from radiology and pathology to primary care and administrative workflows. Yet, the rapid evolution of these tools raises deep questions about trust, responsibility, and the very nature of the physician or clinical provider's roles. My name is Rahul Sharma. I'm Chair of Emergency Medicine at Weill Cornell and New York Presbyterian, and I'll be moderating today's discussion. We have an exceptional panel representing a diverse range of perspectives across medicine, healthcare administration, and technology. As you saw before, Ms. Jyoti Rai, who I actually know, we're colleagues at New York Presbyterian. She's the Chief Talent Officer at New York Presbyterian, leading human-centered workflow transformation to unlock organizational and people potential. We also have Lama Mohammed, who is a tech policy fellow at NYU's Center for Social Media and Politics, where she advises policymakers on AI governance, data privacy, and platform accountability. Dr. Ron Razmi is a physician, entrepreneur, and author known for pioneering the use of MRI in cardiology and advancing AI-driven healthcare solutions. He's also co-founder of Zoe Capital and author of AI Doctor, a widely acclaimed book on artificial intelligence in medicine. Also, Dr. Saeed Ibrahim, who is a friend and a colleague, is a nationally recognized physician scientist and healthcare leader. Currently is the Dean of the Sidney Kimmel Medical College and President of Jefferson Health's Hospital and Clinical Practices. And I also want to welcome Dr. Singh as well. Thank you. So over the next few minutes, we'll explore not just whether AI will replace humans, but how it might reshape what it means to practice medicine, and what that means for patients, providers, and healthcare systems alike. So let's get started. What I'd like to do is start with all the panelists. And just a brief question. When you hear the question AI, will AI replace humans? What does that mean to you? Is it the wrong question to ask? So why don't I start with you?
Yeah, sure. Thank you so much for having me. When I think of this question, I often think about how AI may be used to optimize and wipe out the working class and middle class and potentially create a divide between the 1% and the working class people. And that's why I think it's the wrong question to ask, if not dangerous, because it also creates some kind of distrust between people and the technology. So I think the question we should be focusing on is, will AI replace connection? Will AI isolate us? Will AI not create community? And I think these are some of the things that we should be thinking about as we're integrating it into every aspect of society, including healthcare.
Saeed?
Well, first of all, good morning, everyone. This question, will AI replace me or the physician, is actually a very real question for me as a dean of one of the largest medical schools in the United States. The Jefferson Medical School, which just turned 200 years, has trained more physicians in the United States than any other medical school. So we have about over 1,000 students, and I am also sort of part of the health system that oversees 5,700 physicians. Almost every day, somebody asks me the question, what's happening with AI? Will I be replaced? And the answer I give really depends on what conference I attend that sort of day. I mean, the exciting talk that I just heard makes me sort of wonder. But the reality is it really depends on what you mean. It depends on the kind of medicine we're talking about. The reality also is that I think somebody once wrote that in the short term, we underestimate the impact of new technology. I mean, we overestimate the impact of new technology. That's the reason why there's a lot of potential hype about AI now. But the reality is that in the long term, we often underestimate the impact of new technology. It's conceivable that AI would be massively transformational for healthcare, but it may take time. So I think my answer is it depends. Some parts of healthcare may be replaced, but not everything. Healthcare or medicine is both an art and science. It's conceivable that AI will actually facilitate the scientific part of healthcare delivery. But the art of healthcare, the compassion, the humanity, the need to sort of hold hands with the patient, that may or may not be replaced by AI. So I could see a scenario actually in the future where a patient may sort of say, yes, I know what to do, but can I talk to somebody, not an AI? That could be a sort of something patients are willing to pay more for, so in the future. So the answer is it really depends, but I think we should be really excited about what AI could do for us. The question I am asking often is, I know AI would be useful, but will it be value added? And that's really the real question.
Great. Dr. Razmi, you wrote a whole book on the AI doctor.
Yes, so I spent 3 years writing this book and examined AI's impact in healthcare from every possible angle. What's interesting is earlier this year, I was part of a debate about, which was called, Will AI Replace Physicians? And it was an hour-long live stream debate, and my antagonist and I went back and forth on it. But the reality of the situation is that healthcare is disorganized. Often, I mean, I'm not a practicing physician. I only practiced for a few years before I crossed over to the dark side, on the business side of healthcare. However, oftentimes when I saw patients, the last piece of information that they gave me verbally is how I made my decision. So practice of medicine is not all digital. There are a lot of things that happen. It's a chaotic environment. And software has had limited impact. I think that is going to change with the power of AI, because AI can take in multimodal data. It can have context, memory, and reasoning capabilities. However, the reality is, in 2015, when I was running my last company, I was on a panel, and I was in San Francisco. I was on a panel with Vinod Khosla, who, as everybody knows, is not immune to hyperbolic predictions. And he said in 5 years, we're not going to need radiologists. That was 10 years ago. Today, we've never had a greater shortage of radiologists.
Right.
So I would stay away from any predictions about whether AI is going to replace doctors and in what time frame. There are many things involved in terms of reimbursement, regulatory issues, and so forth. So I'm confident saying in the near future, AI is not going to replace anything.
Great. And we'll get a little deeper into the different different types of areas in healthcare. How about you, Dr. Singh? What do you think?
Like you, I transitioned from practicing medicine to becoming an entrepreneur. But I've been involved as a venture capitalist for a long time. And I think what I'd like to say about this, just having been part of the confluence of technology and clinical care for about 30 years, that AI in many ways is just a continuum of a technological trend where at every stage the threat of that specific technology replacing clinicians has been debated. And I think right now it's hypercharged, but I'll give you an example of a company that I built a while ago, first as a venture capitalist and then I ran it for 2 years, called Mako Surgical. Mako Surgical at that time was the first robotic surgery company ever created, and basically at this point has over, if there are orthopedists in the room, 50% market share for robotically conducting knee surgeries. So, or no knee replacements. Now, at that time, this was a major issue and was heavily debated. And one of the problems we were finding in taking that technology to market was the way they were selling it was such that physicians were getting intimidated by the fact that this could actually replace them. And the change that we made that ultimately made it successful and sold it to Stryker Industries where it is right now was that it was never really a threat to the physicians. It was just the way it was being portrayed. And as long as you told them that this was a tool that would help them increase their productivity and the consistency of patient outcomes, that messaging made the difference. It's obviously very successful now. In many ways, a lot of the use cases that you see right now in AI are similar in nature, right? I mean, what you're seeing is there is a threat to that is perceived for clinicians, and you have to overcome it. Dr. Sharma was here earlier, but I helped in introducing patient engagement technologies, for example, at 2 of the major hospitals in New York City, which are unionized. The part of the implementation process involved the head of the nursing union approving the product. Right? So this was not a product that we could anyway push past in New York, given the economics of the unions and how important they are in the management, without them feeling comfortable that this will not take jobs away. Right? We are successful right now in that. It has worked. There has been 96% diversion. And we haven't seen any replacement. All it has done is taken some of the burnout out, allowed them to focus on things that they want to focus on, like patient care, as opposed to doing things that they consider cumbersome. And I think it's just feeding into productivity enhancement rather than replacement of clinicians.
Can I quickly mention, in 2025, right now, the trend in nurses' union contract negotiations is that they're putting a clause in there that you can't bring AI that affect the nurse's job. That is the trend this year. So very apropos to what you just said.
So this is a great segue to the person who knows this all is Jyoti. She's our Chief Talent Officer at New York Presbyterian and SVP. So Jyoti, talk a little about, from a workplace perspective, do you see AI changing the number of people and providers that we need? How are things changing? We're talking about unions, we're talking about people. You and I were talking about this at the table.
Sure.
What are you seeing out there?
Sure. First, let me just talk about it first from a consumer and as a mom, because when you're talking about sitting with physicians, I'll just share a story, because as a mom of 17-year-old twins, my son, who's been an active sports player, was just, and especially football, so pretty, high contact sport. And he was told by, he got an MRI report done because he had some injuries. And it was, think about the MRI report that he first put it in the ChatGPT before even going to the doctor. He knew exactly what is coming. But it was not just about reading the report. It was not just about getting the information. It was the moment of us sitting down with the surgeon for him to understand that while he cannot play that sport again in his life, but getting hope for the future, what can he do? And when we talk about in terms of compassion, care, I'm still narrating a very small incident. When all this room is taking care of the sickest of the patients in their most vulnerable state, we are talking about what physicians are doing is care and hope. And that's what I think we are still far away from what AI can do. So that's the first thing. Second, back to your question in terms of when we think about workforce and the change that we are talking about, I love that talked about that it's new technology and old organization. It is so much about a cultural change. It is so much about a talent change. Because one, what is with this every change, and change is messy. No one likes change. But when we talk about in terms of the first change we have to look at is workflow. Because wherever we are adding technology, it is changing the process. It is changing how we are going to do work. And it may be in certain part of that workflow or the entire workflow. So we are looking at in terms of each of our roles, where and how that role is changing. That's the first. So work innovation is the first part. The second is around roles and skills. Now we are talking about data scientists. Now we are talking about ethics. Now we are talking about in terms of AI governance. All those roles which are new coming in, and we have to think about collaboration differently and look at our organization structures and what skills we need differently in each of those roles. So there is a huge challenge around skilling and reskilling and upskilling. And what will that career look like when we think about clinicians, when we think about clinical roles, as well as non-clinical roles, and how do they come together and collaborate together? Great. The third is around culture. Because while we can give the technology, but technology is so much about adoption. When we are talking about nursing unions, saying that I have to first take care of my job and you have to protect my job. So this is so much about cultural change and adoption and change and looking at what behaviors we need to inculcate in the organization. Somebody talked about curiosity. We talked about connections. But there is also about collaboration and critical thinking. And lastly, it's about leadership. Because leadership, as this room is filled with leaders, and in our organization as a leadership team, what will our role be for us to engage the organization, engage our team members, engage our stakeholders, and how we will have to lead in the future. And that's something we have to. So if we have to be steward of some change, we have to first be a student of that change and be student and learn that change. So how do we build that culture of experimentation and innovation?
So, that's a great point. And I want to pivot a little to policy, ethics, trust. And this is a question for Lama. You've done some work on this. Obviously, one of the struggles, especially just being a practicing clinician, is whenever you do have any sort of great AI idea like we saw earlier, getting it approved, making sure that the policy people, the regulatory people get it through is critical. So Lama, what regulatory or ethical guardrails are most urgent to ensure AI supports rather than replaces humans?
Yeah, that's a great question, and one that we should be thinking a lot about. There are many things that we should consider implementing, but I'll summarize a couple. First and most important is ensuring equity and fairness. We really have to ensure that the AI systems that we're using are not perpetuating or exacerbating existing biases, especially on grounds around race, class, and gender. And that's all about making sure that we're training these systems on diverse data sets, as well as keeping a human in the loop to make sure that we're also not allowing social determinants of health impact who's accessing care, especially around marginalized communities. Second, transparency is also really important. Both the clinician and the patient should clearly understand what the system is and what it's doing, especially with their data. Third is accountability. Who is taking responsibility for the technology if someone is being harmed? Is there a way to report? Is there a way to detect? And that is something that is a big question in policy, like, do we put it on the provider? Do we put it on the person who was giving the service? And I think there is a bit of a debate around that, but personally, I think the creator and developer of the AI system has a lot of responsibility in making sure that they're communicating with clinicians to make sure that there is a sort of mechanism in place for that. I also think privacy and security is extremely important. We have to make sure that there's data anonymization, that AI systems are compliant with HIPAA, that the third-party vendors that are storing these data services are clear and communicative. This is a big problem in the UK right now. They just passed the Online Services Act, which part of it means you have to actually scan your face to determine if you're 18 or above to access particular websites. But the UK government doesn't actually know who's storing this facial recognition data. It's just a random third-party vendor. And that introduces a lot of questions about privacy, data security, accountability. What happens if these things are hacked? We have a lot of foreign adversaries that are interested in like healthcare data. And DNA data, facial recognition data cannot be replaced. So we have to think a lot about these things if we're going to protect our patients. And I think lastly is ensuring a collaboration and communication across government, researchers, and clinicians to make sure that we're continuously studying and understanding the impacts of our artificial intelligence, especially generative AI, so that we're building regulatory systems that are modern. And I think this is a struggle of also both policy and law, is that it's not keeping up with the transitions in tech. And I think building a multi-stakeholder approach to compliance and regulatory regimes is really important for ensuring that.
Great. Let's talk a little about our trainees and the future of education. So, I still practice, and every time I work a shift, one of the residents presents something they got from open evidence or put something else in, that's pretty much the norm. And I want to direct this question to Saeed. Being a dean, an educator, and also maybe some of the other clinicians, how is AI changing medical education and training, and what are the skills that the next generation of clinicians should be learning?
That's a really great question, Raul. It's actually an issue that many healthcare educators today are struggling with. First of all, today's medical students and residents are already using aspects of AI like ChatGPT. So they're a little bit ahead of us in terms of the usage of the simple sort of tools that AI provides now. But the reality, the question that I think Raul's asking is, the healthcare education needs to actually probably change in ways that prepares our medical students and residents for the future practice of medicine. It was in 1910 when Flexner came up with the first sort of transformative healthcare sort of education process, and things have been changing with the with internet, with the proliferation of digital forms of communication. Things have been changing, but I think AI really presents a completely new challenge because it's going to impact not only how students learn. Because remember, just to give you one example, one of the things that we have taught many medical students is how to write an HBI, or the history of present illness, and sort of think through the process. Well, if they are going to use AI to really do that, does that change the thinking of the physician? It may. It may actually change about how we even form ideas. I think having AI-facilitated sort of diagnostic tools would be great, but how would the students use this? How would physicians use this? Would they do so in a responsible, ethical way? Would they be able to sort of address the biases? I mean, these are all the questions that we are really struggling with. Many medical schools are now thinking about ways to incorporate AI into the sort of day-to-day training of medical students. And I think that needs to really sort of be done in a more uniform and systematic way.
You know, we could probably talk about this for hours, but you know, since we have limited time, what I'd like each panelist to do is, you know, let's end on this. And Ron, maybe we'll start with you. What gives you the most optimism and what gives you the most concern about the future of AI in healthcare?
So I've been on my book tour since last year, and my publisher, Wiley, has sent me all over the world. I ended up going to places I've never been to before. And when you come in to promote a book like AI Doctor, and you're speaking at conferences and such, oftentimes you get invitations from the Ministry of Health to come in and advise them on what they should do about their improving the healthcare of their population using AI. What I learned is that everybody is struggling with the same problem, which is shortage of resources. This is the #1 problem facing almost every healthcare system around the world, which is older population, higher disease burden, not enough resources to take care of it. So if you have a technology coming online that can start offloading things from humans, it could be writing notes, it could be coding, it could be operational, scheduling, and so forth. If it's not curing cancer immediately, it's okay. That's a lot of benefit to provide to the healthcare system. I was on Power Lunch on CNBC, and the first question that Tyler Matheson asked me was, he said, Jamie Dimon said an hour ago in this network that AI is going to cure cancer. What say you? I mean, we're in a headline society. People want to talk about living to 160 and curing cancer. Meanwhile, AI could do a lot of great things to lower the manual burden and free up our resources so we can take care of more people with higher quality. And there is nothing wrong with those early, less sexy use cases.
You know, we have 3 questions. We probably have 10 seconds left, but we do have 3 questions from the audience. And does anyone have a question? Someone has a question from the audience? I was told we have 3 questions. No? Okay, go ahead, Dr. Singh. What is your, what gives you the most optimism and the most concern?
I mean, over the long term, I think I'm wildly optimistic, frankly, about what AI will do. I think the speed of adoption is at significant risk if we do this wrong. And what I mean by that is, I think in healthcare in particular, since you're dealing with lives, taking generic technologies that have worked in other domains and bringing them into healthcare is not going to work. So the degree of domain expertise that you integrate into the AI solution for healthcare with the specific aspects of healthcare, I think is going to be super important. But, you know, I think leading AI solutions with clinical expertise rather than leading AI solutions with technology is the key to adoption in healthcare. And getting that right, I think, is very important if we basically got to take advantage of AI quicker than rather than later. It will happen.
Jyoti, any final remarks?
All right. I think what I'm most optimistic about is that we'll be intelligently human in the future, because when machines are getting better at being machines, I think we can be better at being humans. So that's what I'm excited about.
Great. Well, listen, thank you for such a thoughtful discussion. What's clear is that AI isn't just a technological change, it's a cultural and professional one. Whether or not AI replaces humans, it will undoubtedly reshape medicine, and our challenge is to ensure that this transformation strengthens rather than undermines the human connection at the heart of care. Please join me in thanking our panelists for their insights, and thank you for being part of this important conversation.
All right. After AI tried to replace us, let's talk about something it still hasn't figured out: staying young. Our next panel, Wellness and Longevity, an integrated care approach.
I know the topic is very interesting, but seems like people are getting a little bit sleepy or bored. Let's play a little tiny game here. How many do you guys think are healthcare physicians here versus healthcare technology providing people? Any guesses? What's the weightage of physicians and technology? 50-50. Any other answers? 80-20 for 80 for what? 80 physicians, 20 technology. Okay, any other guesses? Say that again, sir. 80 technology, 20 physician. Let's see. All right, all the physicians in the house, raise your hands. All right, and rest is technology. I guess 80-20 guy wins. I have a little gift for you, sir, if you can come and collect it. All right, for the next panel, the wellness, I would like to invite Dr. Shoaib Imtiaz, Chief Medical Officer at People Inc., turning wearable data into wisdom. Dr. Denise Warden, the healer who speaks fluent mitochondria. Carl Mehta, the investor who'd rather fund youth than chase it. And I would also like to invite Dr. Anu Navani, if she's still in the house, for this lively panel, as one of our panelists couldn't make it here.
Hello. Yeah, Dr. Tawari couldn't make it. Yeah, no, Dr. Tawari couldn't make it, so I was going to help host, but then...
Please take away Dr. Susan Beanie.
Hello! I'm Susan Bean, Executive Medical Director for Health First, a managed care organization here in the New York City region. And I'm going to ask you a question first. Are you ready for your question, audience? Yes. Are you ready? Yes. All right. How many of you would like to lead a short, illness-filled life? Raise your hands. Raise your hands. All right, so no one does. And that's why this panel really matters. We have put together a diverse panel in terms of what they do every day and their backgrounds. I'll let them tell you a little bit about that. But here on this panel, the center of the stage would be people, patients, communities. So we're going to talk about what matters not so much to us as healthcare providers, professionals, and so on, and organizations. We're going to talk about what matters to people. And in my experience, people also want to lead a long, healthy life. So panel, what I'm going to do is ask each of you to answer the first question and briefly tell us who you are. We have a lot to cover, so I'm going to ask you to be mindful so that everyone gets to speak. And my first question is, today people are making health decisions, I know I am, from social media. The wellness space is flooded with information. We talked about AI and so on. And we're talking about treatments that may or may not be what we would want for them, but people are making these decisions. So my question to each of you is this. As you tell us a little bit about yourself and your perspective, if you could have, or if you could, your wish could come true, what one intervention might truly change the trajectory of long, healthy life for the citizens, people, patients, communities of this country? In other words, what would you recommend first and foremost? So I'll start with Denise.
All right, 27 years, integrative medicine. I'm a researcher, an author, and a speaker.
Really loud, yeah.
A speaker. You guys hear that now? All right. Physician, but I would say I've been working in this space for a very, very long time. And to me, it's not another pill. It's not another wearable. It's not another biohack. The number one intervention that I would say is that we have got to take a hold, you mentioned it, about social media. There's a lot of misinformation out there. Our patients are coming in, they're confused, they heard of somebody on some influencer, they're coming in with misinformation, and we as clinicians and researchers need to take the mic back. We've got to start looking at truth in medicine, but we also have to have a clear message. We're not speaking to the patients, to the public. We're talking in our world, and that doesn't help us in the long run. So we need more of us, not afraid, to go against the biohackers, to say, does everybody, I was in a group with entrepreneurs last week, and I said, how many of you have tried a cold plunge? All 80 people had their hand up, and I said, how many of you did any kind of testing to make sure that was going to be safe for you? Not one hand went up. We have work to do. My intervention is education and good information from the right credible sources.
Thank you, thank you, thank you. Sahab.
Hi, Dr. Sohaib Imtiaz, board certified lifestyle medicine. So I'm the chief medical officer at People Inc. So health information is a big part of what we do. So you're People Magazine, health.com, very well. People Magazine, health.com, very well health. We're in the business of good health communication. So like you said, social media is really important. And we hear so much misinformation, and myself, as a physician certified in lifestyle medicine, a lot what I do is weekly I'll make videos with longevity trends. And cold plunge is such a good example because we have data that, if you're trying to build muscle, for example, and you go for a cold plunge, it will blunt your muscular response, right? So at one end, you're trying to build muscle, on the other end, you're ruining it by going for a cold plunge. But these things get viral, we know influencers have power, and that's why I was in Vegas 2 weeks ago, and there's a powerful group of physicians now who are battling this on social media. In terms of longevity, I think GLP-1s right now, looking at kind of the rates of obesity and diabetes and Alzheimer's disease, can probably have the most impact if they can be afforded by the masses, as well as making them accessible. I mean, I trained in England, I have some people from England here, but it's a lot cheaper over there than it is in the US. And I think GLP-1s will be seen as a longevity medication. And I'm excited where that goes. With biohackers, I am excited about the wearable space. I'm part of the quantified self movement. I track.
You only get one. You only get.
I track almost everything, but I'll leave it there. Thanks.
One. Thank you so much, though. GLP-1s are really critical, and I know from the managed care perspective. Harvey.
My name is Dr. Harvey Castro. I'm an emergency room doctor for 20 years. I know I look really old for those years. And with that said, my career, basically, I wrote a book called ChatGPT in Healthcare in 22, and I'm an advisor for the country of Singapore, and I'm the chief AI officer for a space company. We do rocket satellites. On my one tip of longevity, I know it's a domino effect. It is literally your decision. Can you decide what I'm going to put in my mouth? Will you decide how I'm going to leverage your clinical gestalt? Some of you guys are doctors, the knowledge. Will you decide to live longer, or will you decide to live a better life longer? And just because the two things real quick is, if you make that decision, leverage AI. Using that AI plus your clinical gestalt together will give you that longevity.
Thank you, thank you. Thank you so much. Carl.
All right, thanks, Susie. I'm not a physician, so hopefully I'll bring some different viewpoint. I'm an engineer, tech entrepreneur, and a venture capitalist, past 30 years in Silicon Valley building technology systems. But lately, through my own personal pain points, I've been very interested in health span, more in health span than in lifespan, and bringing more like a systems engineering approach to a human body. For the past 30 years, we've been building systems for manufacturing, supply chain, various other technologies based on long-term predictability and taking lots set of data and crunching that into predictability. And as I see my own biomarkers, as I turn into my 50s and I see my biomarkers declining in key areas, I've been very surprised that the healthcare system is designed not to look at predictability, not to look at preventive, because they want to save money in the short term from a financial incentive and then end up spending more money in the long term. So my focus has been in AI in terms of looking at the LLM technologies, which based on what the question here is, there's a lot of hallucination, there's a lot of trust and safety problem, there's a lot of discriminative bias in the general LLMs. So my focus has been in building more of an HLM, which is a health language model, and also bringing newer technologies like NSR, which is neurosymbolic reasoning models, that is absolutely needed before you start using just the regular ChatGPT or LLM, which I would, as a technology person who has been working in AI for the past 29 years, and I've written a book on AI, I would not recommend you using just the general LLM and making decisions based on that.
So what would you recommend? One thing.
Well, I mean, you know, we are building HLM, and we need a system, you know, an AI system which is specifically designed for health.
All right. Thank you so much. That's really important, and I know you've spent a lot of time thinking about this.
Yeah.
And my colleague here?
Yes, Nidhi Goyal.
Nidhi.
Hi, everyone. I'm a psychiatrist, and I am seeing the other side of all these people in my real world, how social media is impacting behaviors. People are, the like culture or the dislike culture. If I get one like, people hate me. If I get thousands or millions like, everybody love me. But it is also leading to a lot of harmful effect. ChatGPT, now teenagers are just going for therapy. They're abandoning their therapy just to go a ChatGPT as a therapy companion. Again, very, very dangerous. So if people like you can put boundaries in these social media or ChatGPT and intervention, I would say, physicians need to also have more voice on these social media. We are very social media shy people, but we need to put our voices there for awareness and education. Thank you.
All right, thank you, panel, for the first round. We're ready for round two. Many of you mentioned digital health. How many of us have this on our wrist? All right. Okay, all right. You're not counting your steps? You're not measuring your pulse right now? No? Oh, well, what are we going to do about that? Is that helpful for wellness and longevity? I'm going to go right to the end. Sahid, please.
So I've been an Oura Ring user for about 10 years. I wear Whoop as well. I have an 8-sleep mattress. So I'm very much brought into the quantified self movement. Also use continuous glucose monitors. And I feel medicine where it is today, we apply population principles to everyone, but genetically we are different. And I think learning about your own body helps you make certain decisions that may not work for someone else. So I think the power of wearables also helps drive behavior change. For example, if you're sleep deprived, we know the next day you'll consume 200 to 300 extra calories, right? So if you can see that data and you can link that, that's this type of positive reinforcement that happens, and you can change your eating behavior. And similarly, that's why I think CGMs are popular, even though the data on CGMs right now, we don't know how effective they are in healthy populations. But from a motivational standpoint, I think data and wearables can be very powerful if used in the right way.
I would say data and information can absolutely be powerful, but it also can work the other way around. Some of the most stressed people I know are the biohackers that are looking at every bite they eat, tracking every single thing, and their stress is off the chart, and they can't wonder why they can't get those CGMs under control because they're stressing out about their numbers. Yes, used appropriately, I love them. However, I'm taking people off some of theirs. I'll put them on, we'll take a look at it, let's get a baseline. After that, get that off and start getting out in sunlight, doing the exercise, back to the basics. That's the hack. That is the hack.
Awesome, awesome.
My favorite phrase is, we don't know what we don't know. So by having a wearable that tells me that I'm stressed out, that my HRV is going bad, that maybe I should do something about that, or maybe last night I didn't sleep enough, but then taking that knowledge and actually doing something. That's why we are at disadvantage, at advantage of the rest of the population, because we can look at it and be like, this is what we need to do, boom, 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 whereas the regular population doesn't. And that's where AI can come in with a little asterisk point, because it could be right or wrong.
I think sensor data is super critical and super important, but it has to be matched with a whole bunch of other data points to make sense of it, because first issue is calibration. A lot of data is not calibrated even from the sensor or wearable data. The second thing is the ability to model that against other behaviors before you jump into conclusions. So again, modeling and predictability is very important. And the third thing is that the placebo effect, like what you talked about, which is if you stress too much about negative data, it can actually, it's a psychosomatic thing, and it can actually start hurting you. So the human side of the whole nudging and having that human touch in that technological nudge is super important, and be able to take the data and make sense of it in the right context. All of that has not yet come together. So just be cautioned about that.
Absolutely. Any technology is as good as its use, right? I'm very, very excited about sleep monitors like Oura Ring. And real story, a patient who was going into mania 2 days ago, Oura Ring was predicting that this person is losing sleep and it's not good. So again, technology is good, but then data, we physician, we do not know what data means. You can give us a lot of lines and charts and spikes and whatnot. I cannot make a head and tails of it. So if you can translate it into a simplicity or a simple one-word translation of that data, I think that will be much more useful. Thank you.
Awesome. Thank you so much. Well, we talked about technology. Let's swing it around to, you talked about sunshine outside. And we know that from the lifestyle point of view, there's so many things that we can do for ourselves right now in this environment that's really important. So how would you advise us and others to put down our technology for a moment and do the other things that can help us to live a long life? Where shall I start? Carl.
Well, so I'm a big fan of what I call the brilliant basics. We all are not doing that, and I just put them into 4 foundational pillars, which is eating right, sleeping right, exercising or movement in the right, the right level of movement, and then the 4th thing is just managing your stress correctly. So these 4 things don't require any medicine or any medical intervention. This is something that we all can do by our own self, and like examples of sunshine or vitamin D and stuff like that. So as long as technology can help us to do those 4 things, which it can, in terms of the right nudges and understanding of the data, we can all have better wellness and better longevity.
Yeah, I know this is kind of out there, but I truly believe we don't know when our last day is. As an ER doctor, I'm really humbled by life, and I live life where I try to do my best every single day. So I try to see a sunrise or a sunset, and I make sure I call my loved ones every day to say, hey, Dad loves you. And I say that to you because that, on the mental being side, that is so important. Because if you can do that, now on the analytical side, that will decrease your HRV and help you, or increase your HRV, depending.
We talk about primary and secondary prevention, but primordial prevention is what we're talking about. In my world, in the research that I do, it's metabolic flexibility. And exercise is underappreciated. Yes, we need to eat correct, we need to de-stress, we need all that, but exercise is one of the best longevity hacks that we've got. We need to stop talking more about that instead of just saying, get in some steps every day, that's great, but it's beyond that. And we've got to get that message out there, that people have to move and we have to do strength training and balance training as we age. So.
Yes, and the final thing that I would like to add is... Oh.
I'm sorry, just the other thing, and one more thing on the wearables. Even with the Oura Ring, my understanding at this point, it's 75% accurate for certain sleep markers, and we're going to talk more about that in our sleep thing coming out. But for women, all the wearables, they're not there yet. They're working on it, the Whoop and the Oura Ring, but they're not there yet. And when it shows a problem in a woman, a lot of the times it has to do with the cycle, and it's not actually accurate information. So I just want to get that out.
Absolutely, absolutely. And just to add to all the 5 elements, air, sky, earth, and whatnot, humility and gratitude. I think if we practice that every day, I'm sitting here and amongst all of you experts here, it gives me gratitude and humility, and I think that helps reset you for health.
I'll talk about the microbiome then. I think the gut-brain axis is really important. We have, moving from England to the US, the diet quality is very different. The food is very processed here. And I do see differences in my health markers, which I've seen personally and I've seen in patients that I know as well. So I think it's very important to understand nutrition and what we're putting in our body, because that's the fuel we use for cognitive performance, for physical performance, for emotional performance. And I think what's really interesting is I was in Vegas 2 weeks ago, and they're building a Google AI personal agent, and it works out what your limitations are, because it's good saying to a patient, go exercise, but they have osteoarthritis and knee pain, they're not gonna be running a marathon, right? So I think AI really helps us understand the data that we have and then work out what the next best steps can be for our longevity, which varies for everyone.
All right, thank you. So we have a few more minutes, I think. I think we're doing great on time. If there is a question, please let us know. We're glad to entertain some questions. But I think we have to talk about science, evidence, and what we can know in terms of what is newest, what is on deck, that will help us with longevity. And there are things every day. And I think one of our speakers talked about 150,000, articles to read. I know they're on my desk. Who wants to start with that? Just to talk about breaking news here for longevity and wellness. I'll throw that out there. Who would like to? Carl, you would like to.
Well, the great news is that we are entering into a golden era of personalized health, and I think through a technological revolution that we've never seen. If we can all just live for the next 5 years, I can guarantee you that we will all live for the next 50 years. Just the amount of technology that is just in the pipeline, that if you see that's coming through the pike, it's just mind-blowing. Right down at the cellular level, at every cell, we have the technologies that is coming out that can repair your cell, that can revitalize your cells, that can reprogram your cells. And if we can get it down to every one of those trillion cells, I think we are going to completely revolutionize, where the human body and the human, health is. So that's the positive technological news. The other big thing, obviously, is how AI is able to do the predictiveness, because I think we need to flip the entire healthcare system, which is today on a reactive basis. Like, we only go to a doctor when we are sick, so it is a sick care. We have to flip it into completely proactive. And once we do that, but that requires the predictive capability. And AI with the sensor data, with the biomarkers, all of that helps us to do predictability. So my mantra is kind of like the 5 Ps that I look at it from a future of health, which is the predictability that drives the preventability and preventiveness, that makes us be proactive about our health and deliver a personalized health and with precision medicine. So those are the 5 Ps if you want to take it away from
I like
today.
those 5 Ps. Thank you, thank you. I'm going to go back here because we normally think of psychiatry as just, a passive kind of profession or portion of our healthcare. What's new and exciting in your realm?
Precision medicine, that's the new thing in psychiatry. So we now have, you guys may have heard shock treatment, ECT. So now we have transmagnetic stimulation and by mapping the brain, we can precisely deliver stimulation to reboot the long-term depressed neurons, or we can inhibit the long-term stimulated neurons to balance the brain. So a lot of new innovations are coming in psychiatry. Psychedelics are in works, and where we used to say 3 months or 4 months to relieve from depression, now we can get those results in 1 day. And that's very, very exciting. It is no longer passive branch of field. Thank you.
All right. Excellent, excellent. Please.
And I just want to add a quick hack. At the end of the day, let's leverage technology, right? I have an AI agent that I have a couple of core things that lets me know. So if I want to know longevity, every day I literally get whatever came out in the news, and not just the news, but like deep research, and I can get criteria, and it's in my inbox every day or in my AI. And so let's leverage these tools, not just hear about it. You're here to learn different things, and I call it a mini hack. One quick thing I did is I used my own personal data, created my own RAG model, so that's not giving the information to ChatGPT, but the skinny is I'm using that to tell me how me, Harvey Castro, can live longer. What am I doing? Am I exercising? Am I doing the right exercising? Not just steps. So take it to the next level.
I think, too, we've got to be careful. A lot of people are spending a lot of money outside of managed care where they're paying cash for these tests, and they're not reproducible. I've for years taking these tests, and I'll send 2 patients' blood or samples, whatever it is, microbiome, and they look completely different when they come back. And I think we need to have that education out there, too, because we're building AI, we're building all these things on non-reproducible information. and information that's lacking, especially in women's health care. So we're going to get there. I'm very excited. I love AI. I use it all day, every day for lots of things. However, I don't trust it yet. And I verify everything it tells me, and I catch it all the time. I'm sure you guys do too, in mistakes. So we're still teaching it, especially in medicine.
I want to just pause because you deal with some very special populations in People Inc. Can you talk a little bit about, we're talking about ourselves, but there are those who really struggle with longevity. Behavioral health is one of those, and some of the people that you're working with.
Yeah, our research group, we have about 80 of us now that are researchers and clinicians working in metabolic oncology. So we're working with ketogenic diet, hyperbaric oxygen, repurposed drugs, but we're putting the science behind it. And so those patient populations are coming into a stage 4 usually. Or they're stage 1, thank God those are easy, right? For all of us to be able to help them. But that population is looking like your ER patients, looking at death in the face. And their longevity means something different. And it's about quality of life and health span.
Awesome. Please, same question.
I think I would agree. I think there's a lot of non-evidence-based tests out there that marketing and make a lot of money. But I think we're seeing a dichotomy. We're seeing a lot of the young and wealthy invest in startups, superpower. Brian Johnson just raised a $60 million round. There's a lot of longevity apps. I did my thesis in longevity and digital health, and the investment has been insane over the last year. But then we go back to the hospitals and we see people with chronic disease, and it's a completely different question what longevity means to them, right? After a surgery, after cancer recovery, is it they can walk up and down the stairs, right? Is your VO2 max dependent on that? So I think there's two separate conversations happening, and I think we have to address both because then one will get left behind. And I feel AI will help us decipher all the papers, all the data, look at a multi-omic, almost digital twin model where we have all the data with our bloods, wearable data, microbiome, etc., and then make sense of it. Because even like microbiome tests, so many of them are so different and they're based on 1 or 2 markers. You can't really make clinical decisions based on that. And that's the problem. And the physician of the future will have to understand this data, which in medical school, we aren't really taught.
Well, I think that we are out of time. I really learned a lot. Thank you so much to this wonderful panel. And we'll turn it back over to our...
Thank you so much. That was very enlightening, so helpful. There is so much out there that is so wonderful to hear it right from the horse's mouth. All right, so yeah, let me open it. All right, so next up, before we move forward with our entrepreneur, next keynote speaker, I would like to tell you guys that okay. Our keynote speaker is going to be virtual. So we're just trying to make sure we can, the technical.
Anybody from the Gautam, can we get him on the main screen? People can see, so he can see.
You're not showing your mute.
Hello, this is Des from the KPC. Can you hear us?
All right. As we close this morning, we honor a man whose story defines what happens when vision meets velocity. Surgeon, entrepreneur, global architect of healthcare and real estate mogul. An orthopedic surgeon who left the operating room to operate on scale, building not just hospitals, but an entire ecosystem of care. Where others saw red tape, he saw opportunity. While others saw limits, he saw bridges between continents, communities, and systems of leadership. Founder and chairman of the KPC Group, he transformed a physician's idea into one of California's largest integrated health system, spanning hospitals, pharmaceuticals, education, and infrastructure. He's also among the largest private real estate owners in California, with holdings that redefine skylines and landscapes alike. From 1,000 acres in Coachella, soon to become the California with a K, resort and hotel, to the new Kali Hotel, rising beside Sophie Stadium in LA. Each project mirrors his unmatched scale and foresight. Across the world, his vision reaches India, marked by the tallest building in Calcutta, a momentum to ambition anchored in purpose. He's not just a leader, he's a force of nature, a thinker whose nights blur into conversation on strategy, medicine, and the art of leadership itself. Today, he joins us virtually to share his vision for the future of modern medicine, why physicians must reclaim their power, and how the next era of healthcare will be written by those bold enough to build it. Please join us in welcoming Dr. Kali Pradeep Chaudhary.
Good morning. Can you all hear me? Yes. Yes, good morning. Normally, California is sunny. Today, it looks gloomy. But you have gathered so many stars. With the brightness of those stars, I'm sure the New York looks much more shiny. Doesn't matter what it is. I heard part of the discussion, last few people spoken, and everybody is talking about how long we live longer, how we can innovate the medicine, make it better. All these are absolutely true. But the problem is, who is going to run it? I know Elon Musk created a car where you don't need a driver. But I don't see healthcare can be driven without doctors, physicians, nurses. So where is the fate of the doctors today? What is happening? Are you getting young people, your son and daughter? Are they very excited to join medicine? Or they are not? I want to speak about that. So I'd like to run a short video first, if you don't mind.
The United States could see a physician shortage numbering in the tens of thousands in the next several decades.
Southwest Florida is facing a huge shortage of doctors. You've probably noticed it's tough to get an appointment.
The shortage is severe today, but actually it's going to be getting considerably worse as the package shared.
So with the jobless rate near a 50-year low, the labor market remains very tight, making it harder for some companies to find workers and now for some hospitals to find doctors.
Nevada has one of the lowest rankings in the country when it comes to our number of doctors.
What happens when we run out of doctors? With more than 61 million baby boomers, the U.S. is getting older.
That's the first slide. I'm sorry, the idea of showing this video was not to show how great guy I am that created a new city. My goal was different. Next slide. You see, I want to drive a point at the end. When I came to this country in 1984, the whole budget of the United States was $756 billion. And the healthcare budget was 29, almost 30% of that. I don't know, you can follow the graph. You look at the top, today, 2024, our national budget is 5.6 trillion. And our healthcare budget is roughly about 939 billion. It is roughly 17% of the budget. But other countries like Japan, they increased their healthcare budget. Used to be around 20% in 1984. Now they are 33%. Even UK, which is going through, United Kingdom, going through financial difficulty, their budget has increased in national health. It is 21% of their national budget. US, once again, is 17%. Now, we don't look at the number. Doctors are look at the robotic doing all other things, but we do not look at our own finance. And the insurance company is very good. What they have done, they've created a big fight between ourselves, fight between primary care doctor and specialist. What they are saying, they pay primary care in one way, they torture the specialist. So there is a fight between this. But overall, if you look at it, from 1984 to now, we are one of the highest paid parties. A primary care in general make to about 300,000 and specialists make 400,000. The another problem that we fight that, oh, we need our doctors. We don't like foreign medical graduate. I think we made some improvement on that. If you look at 2006 and today, the foreign medical graduate as compared to the American-born graduate, the number is bigger, which is good, but still there is fight between foreign medical graduate and local graduate. Where is the problem? All the new innovation, artificial intelligence, IT, BT, CT, we can talk every day. Where is the real problem? Real problem is, in India, to become a doctor, after their school, they spend 5.5 years to become a graduate, a primary care doctor. If they want to take residency, another 3 to 4 years. So age of 23 and 26, they are earning, they become full-fledged doctor. United Kingdom, 25 years to 29 years, they become doctor. Japan, 26 to 30 years. But in America, we have to be matured. We have to be 31 to 34 years to get a proper degree, proper training to start our practice. If my son and my daughter want to go to medical school, or anybody's, they are smart people, they are going to look at it. In my life, I was dreaming from the day one, my son would become a doctor. But at the age of 6, when I took him to for a blood test, he almost fainted looking at the blood. And I fainted because I thought he is not good to be a doctor. To become a doctor, we need special people. Not everybody cannot become a doctor. You need dedication. You need concentration. But if you look at this slide, if one of your son, you push them to become doctor, he does not, and he become engineer. At the age of 22, and you don't pay him any money, he can start making money, 70 to 80,000, and he probably, he has no scholarship, no income, he's borrowed about $180,000. IT specialist, you can look at the list. I don't want to bore you with the detail. For a person who is trying to find a new life, everybody starts making money at the age of 20 to 25. But what is wrong with the doctors? Doctors has to be, primary care doctor in America has to be 30 to 31 years old. In residency, he make only 60 to 75,000, while his sister, who is an IT specialist, making 4 times more. And his sister has paid off all the loan, but primary care is stuck with $520,000 loan in the bank. If he become a specialist, it is 34 years before you see the sunlight. And by that time, if you don't have a rich father, or you did not have scholarship, your loan in the bank is $600,000. And he must have lost 3 or 4 girlfriends, because ladies doesn't like his work hours. He may end up in a divorce, and he has not produced any children. He is in a shambles. And when he goes to other country, especially India, they are becoming a full-fledged doctor by 25 years and so 27 years. So what is the problem? You all talk about AI, you talk about all the innovation, all the great things happening, but why there is a shortage of doctors? You have created a car, you can drive it without a driver. Can you run healthcare without a doctor? So the video that I showed you I proved my point. I don't know anybody, because video ran fast, probably you did not see the last sentences. I took a young man who was very smart, son of my colleague, because nobody, a Caucasian person, had a lot of issues at that time, and now they have dread picture of India, didn't want to go to India. I took him to India with myself. He was 18 years of age. At the age of 19, I convinced his father and mother. He was admitted to KPC Medical College in India. Went through 4.5 years to 5 years and came out with a gold medal and did very well. He came here, took a ECMLA exam, and his grade was 98%. He then took 3 years of pulmonary residency, 1 year of fellowship. At the age of 27, he married an Indian girl. That was the only good thing, because he went to India and fell in love with somebody. So he came here. They now have one son. They have a very happy life, and he's doing very well. And he does not have a debt of 600,000 in the bank, and he did not have changed girlfriend 10 times. He's happy. So, issue that I want to bring it to you. All the great people that attend this conference, I respect you. I pay tribute to you. You've done a great job. You're doing a great job. But please pay attention to these poor doctors. Why we have to be suffering like this? When I came, if I did surgery, total hip replacement, I would have got in 1992, $5,482. For same surgery, today we'll get $1,400 if you're lucky. From same hospitalization, hospital is screwed. They don't get enough. Yet, United Healthcare, great. They are doing very well. All other healthcare, doing very well. We don't have enough doctors. We don't have, our young men have no incentive to become a doctor. That is not a good picture. I'm not a keynote speaker. I'm a bloody practical guy. I wanted to hear everybody, all the big guys here. I'm sorry, I apologize, because I was very much wanted to come, and I want to talk like a dog, not like a gentleman. I want to talk like a guy who's revolting, not following the guideline of all the politicians. We need to face the practical part of it. Why a physician, why a person need to spend 34 years to become orthopedic surgeon? Why he become orthopedic surgeon? Why he has to be slave? Why he has to run around? Malpractice. Look at malpractice. Doctors' fees has gone down. Lawyers' fees has gone up. Ladies and gentlemen, if one thing I can instill in your thinking, love the doctor. take care of the doctor, make their future better, then all this confidence and everything will become very successful. Thank you. Sorry. Thank you.
All right, everyone. We will be starting. Welcome back. I hope the lunch was as energizing as this morning's session. We're diving straight into our next conversation where science meets software and reality checks the hype. Because while AI is rewriting healthcare, someone still has to proofread the code.
So our next panelists are here, Pragmatic Perspective in AI and Healthcare. And the leading facilitator for this session is Dr. Isaac Dapkins. He is a CMO at NYU Family Health Center. And he's proving AI can actually be useful and not just trendy. Joining him in this talk is Dr. Harvey Castro, ER doc turning AI whisperer, giving empathy a software update, and no wonder he's called Dr. GPT. Then we have Dr. Manchal Range. I apologize if I'm butchering your name. I'm so sorry about that. Michigan Medicine Dean, who turns policy into precision. And joining all of them is our own Dr. Annapurna Kinney from Mount Sinai's Heart of Gold and Hands of Steel, bringing clinical elegance to innovation. So I request all the panelists, again, Dr. Isaac Dapkins, Dr. Harvey Castro, Hal Wolf, Dr. Marshall, and Dr. Keeney.
All right, everyone, we're about to begin. Can I please have your kind attention? Let's bring the conversation down. We're about to begin, please. We need the conversation down and the energy back up. Thank you so much. We will start our next panel, Pragmatic Perspectives on AI in Healthcare.
I have the distinguished honor of being between you and your postprandial coma. So please, stay awake, stay active, stay excited. I'm waiting for my two other colleagues to join. How much time do I get? 25 minutes. Okay.
Oh, nice to meet you. Yeah.
All right, I'm going to start.
Hello. Nice to meet you.
AI hype. It's about pragmatism, though. It's about actually getting this stuff to actually get implemented and have it work. What does it take to adopt now? What do we need to shelve? How do we avoid that classic implementation trap where we implement something and it doesn't really work? Or maybe we didn't wait long enough for it to work correctly. Early productivity dips, how do we avoid them? Pilot purgatory, misaligned incentives. We need to use lessons we've learned from the past, implementation of EHRs, imaging, telehealth, and stress test where AI stands in this hype curve and diffusion curve. So I have distinguished guests. I'm missing one of them.
Hal.
Dr. Sandeep Bajaj, if you're available. Ms. Harvey. I think we're missing Hal, correct? Okay, got it. Okay, all right, we're going to get started. So I have a couple questions for my group here. Considering the history of technological advancements in healthcare and recurring patterns in adoption curves and implementation challenges, how do we inform adoption? And so I'm going to actually start with Dr. Castro, and then we can go down the line.
All right, guys. Well, I know this is a really hard time because we just ate and you guys wouldn't want to fall asleep. So I'll do my best not to put you to sleep, okay, guys? So how can we do this? At the end of the day, it's all about the culture, right? I call it the AI IQ of understanding. And I'm going to take you back to what I just said a couple hours ago. When you first started using ChatGPT, you had some walls. You had some things that like, no, I'm not doing this. what changed? What changed is you guys were coming to things like this, you were learning how these tools worked, and what it is just education. So your culture changed with education. So how can you implement this in your institutions? You're gonna have some webinars, and then think of it this way, you gotta bring them from level 101 to 102, 103, and then eventually, when they get here, they will understand the AI, and as a result, you'll be able to implement these ideas.
Dr. Keeney, would you, since you have deep background in science and service, and you have implemented apps with regard to STEMI and managing other issues, can you comment on your approach to what we talked about with adoption?
Yeah, good afternoon, everybody, and I hope you'll enjoy this session. Having said that, yes, I'm an interventional cardiologist running a busy lab here in the New York City. So going to, like over the last, I would say, 8 to 10 years, we have moved on to technology with regards to, help in teaching. We started with the teaching, but then subsequently what we did was to adopt what is called as a communication platform to help patients who are coming with a heart attack. So if you see somebody who is coming with a heart attack, we have all these timelines that within a matter of 90 minutes, when they come into the ER, they got to get into the cath lab and their blocked artery has to be opened. So no matter what we do, even in a country like America, which has such a great, I would say, EMS system, only 20% of the patients are able to reach within 90 minutes of the same, or maybe even the transfer. Suppose that particular hospital does not have a cath lab, they got to transfer the patient to some other place. That takes about 120 minutes, and very rarely patients reach there. So we used to have a lot of issue because multiple people are involved. ED physicians, the ambulance people, cath labs, sometimes ICU doctors, fellows. So that's when we created this communication platform. Simple way, as soon as a patient arrives, diagnosis is made by an EKG, then there is a discussion between the physicians involved, and the patient goes to the cath lab. So coming back to the point, was it easy to adopt? No, it's not easy to adopt, because as soon as technology comes into equation, a lot of people are worried. Most important is HIPAA and security. So we had to go through a lot of, I would say, changes in the sense that going through multiple levels of security within the hospital, then the physician themselves, because you have to understand there is various generation. What I say, every 10 years, there's a change in the sense that people do not want to adopt technology. It was not easy to train ED physicians, then have the NYPD who have their own way of doing things. People are not ready for a change. So it was not easy. So going back to a point, now we are telling them, because when you say artificial intelligence, you know what people think? Oh, someone else is making a decision. So yes, someone else is making a decision, not in healthcare. What I would say is, in healthcare, where we are involving these kind of tools, a physician and other healthcare people are part of that deployment. So there is a human in that system, so they can be relaxed, comfortable. That is human. It is not completely so-called artificial or someone else somewhere is taking care. So to get that across, into everybody, and then we say, okay, can we adopt it? It's not easy, but we are moving slowly, and I think at some stage we will make the break, and we will be able to get this kind of, various AI, I would say, deployment tools into the healthcare.
Thank you. Dr. Rungia, I am going to ask you about structural in a minute, but I want to ask you, I recently learned about implementation science, and I wonder if you would comment on adoption in your experience at Michigan.
Well, thank you for asking that. And what I think in general about healthcare is healthcare has been, during my 40 years, fast to embrace change, but slow to actually adopt it. And what I've seen in the last year at the University of Michigan, till recently I was dean and CEO of the health system there, is an incredibly positive experience with technology, and that is with ambient AI. The rollout of that, and I think probably everybody knows what I mean when I say ambient AI. But we were just talking about it and how you were able to see a busy afternoon and be completely finished with your notes by the end of it, and a much more satisfying patient-physician interaction where instead of the physician sitting there wildly typing electronic medical records, which I would say the electronic medical record is the poster child for something that has been very, very difficult to implement and continues to be difficult to implement. I think we have opportunities in AI, and if we can follow this recipe of having technology, AI-driven technology, come to a place where providers, the people who are providing healthcare, really benefit from it, as well as the patients. I think that's a combination that will be unique in my 40 years in healthcare.
I just want to ask everybody, keep the microphone closer because folks can't hear you in the back. But thanks.
But same in the back.
Okay, thank you so much. I'm actually going to move on to a new topic, which is of interest to me, having been a physician going through the implementation of EHRs. So, Mr. Wolf, if you don't mind, I would like to ask you if you could comment on the pragmatic technological challenges that we face as we interface different types of technology in implementing AI, and if you could comment on things like FHIR interfaces or other types of interfaces that you think are successful and how people should prepare for best practices for implementation.
In less than 2 hours?
Yes.
Okay.
You
in
can
under
use
2
AI
hours.
if you want.
Well, this is a really important topic, so I'm going to have to let me process. So we have a massive amount of information, raw data and information coming from a multitude of systems. That's just internal. When you look up and you recognize all of the information we talked about earlier coming from the outside, you have a ton that either you as an entity have got to figure out how to combine, or you've got to go to a service that does it for you, right? So interoperability for that information or data to come together traditionally has been one of the most expensive parts of IT, which is how do I integrate systems and how do I translate that data through. HL7 FHIR exchange is designed to help with the end state of that data. And originally it was thought that it would go all the way through to the core so that as you set up your systems, you would set them up. That's not what happened. FHIR stayed at kind of a high level, and systems from a proprietary standpoint kept working. Today, people are using AI to take the place of hard coding in order to put FHIR in. So basically, it's acting like a learning Rosetta Stone, which allows it to go ahead and say, I'm going to send this information here, this is what they're using, and it gets transformed more automatically. So then, if that problem is solved, here comes the bigger question, which is what we refer to as associated or non-associated data or information. Either one, because they're not the same, as we talked about earlier. What does that mean? When I have a device, and people were talking about Oura rings earlier, yep, as an example, when or if should that information make it into my record? When does it become pertinent to be associated with me as an individual? And does it matter if it's 70% or 80% correct? What does the trend show? So I think the bigger challenges are going to be less about how do I integrate and how do I choose.
Thank you. That's excellent. I hope you tech guys are paying attention. Dr. Bajaj, in your storied career as a cardiologist, how do you think the interface of all of this data is going to influence the practice that you currently have, and where do you see that going?
So I'm going to I'm going to take over from what Leo left at. So I'm going to skip the cardiology part. So I was listening in the morning about the cost of healthcare in the U.S. and why we are number 47 as the fourth largest economy in the world by itself. And the single question is asked, what's the reason for that? The reason is only one, fragmentation, where data is in silos and you cannot connect. And so today when the patient goes to the ER, most of the time you know nothing about the patient. So you have to research and find out what's wrong. What if that pertinent data was available to the treating physician before the patient got there? So with that thought in mind, we embarked on a journey many years ago to essentially create a patient master chart that interfaces with 90% of the EMRs, where data is pooled into one source and is actionable, and it is live data. So we connect this from different sources, and we create this longitudinal chart that stays with the patient for the rest of their life journey. And it is also available on your phone, telephone, and via direct secure messaging, you can actually take it to an EMR and just hand it to the doctor, the data gets in. So once you take over the fragmentation part and you're able to connect the providers directly with the treating physicians at the appropriate time, the care is delivered at the right time, at the right place, and maybe for the right price. Because today we spend a lot of money taking care of failure of management of chronic conditions, which is 80% of the money that is spent. And probably it's not necessary if this was, fast forward. And I think AI in the future will actually assist in many of these functionalities. Unfortunately, I've heard lots of beautiful things about AI today, but I went to a conference, I met some people here. This was the Florida ACO conference just last week. And the single question was asked to the folks, how many people have invested money in AI to date? And so there were 16 large groups. They have not seen an ROI yet. It's obviously very expensive. And the second problem with that is that it's not consistent. So today, there's no AI tool that can deliver this 100% safely. So they always need a human backup. So I think where the journey has started.
Thank you. Now, AI is, in some ways, the moonshot. It's the stars and the sky, and it's... Dr. Castro, in your experience, all this interface likely will be revolving around the transfer of data back and forth. Do you want to comment on the technology and infrastructure necessary to do that kind of thing?
Yeah, great question. So, quick background, I'm the chief AI officer for a company called Phantom Space. Literally, they do rockets, satellites, and data centers in space. The reason I mention it is to that question is, if there's 3.7 billion people around the world that do not have access to the internet, including everybody in this room, at some point you're like, man, I'm in a dead zone. Imagine if we created a structure around the world that has data centers. Again, think of ChatGPT in space, and you have a question, you have a wearable data, and then that data is interacting directly with the satellite, processing, and then coming back to you and giving you that personalized medicine. That is what we're creating. That is the future of what I see. So think of it just that network. We're moving literally outside of the Earth communication to above the Earth to communicate with the planet.
Thanks. That sounds really wild and exciting. I'm going to bring us back down to earth and a more pragmatic question, which we all have to suffer through. The question of oversight and structure. So I'm going to start with Dr. Runge, and then I'm going to ask Dr. Keeney also to talk what governance and structural models do you think we need to protect safety and to truly correctly evaluate ROI when you're talking about clinical outcomes, et cetera?
Those two are great questions, and I'll start with safety and protection of information, and specifically talk about PHI, protected health information. And when you think of the vast array of data that can be available and can be connected through AI, I do worry greatly about protection of our own health information. And so I think, I don't have an answer to that question, except for I think the people who are really expert in AI, which I am definitely really not, I hope that that's something that will be high on their list of goals. Secondly, I think that I've had a great experience with AI in that, like some of you who are physicians or other healthcare providers, you have to maintain you have maintenance of certification where you have to answer questions all the time. So sometimes I say, well, I'll see what ChatGPT says about this or another AI source. And what I've found is I actually think that it is better than most of the online sources, whether it's UpToDate or WebMD, but it's not always right. And the first time through, I thought, well, it's gotten so good, it must be right. And I had to look up the answer because it was an area, a very subspecialized area. I'm a cardiologist too, but we're not all cardiologists. But it was about heart failure and some recent developments in heart failure. And I thought, well, maybe I'm just not right. But then when I read about it, I was right. And ChatGPT was wrong. So I sent it a note and it said, oh, thank you. So if that thank you means it's being incorporated, AI will get smarter and smarter, but I think we all have to have that realism that, like any data source, it's not always going to be right. And so, but I do think it has great potential for us. Thank you.
Dr. Keeney, let me frame the question a little bit more. So I work in primary care, and I feel like the standardization of primary care is often not in place. And you work often in a procedural environment, and having patients be correctly prepared in a standardized way when they come into a procedure is a key part of your service. Can you comment on how you've been able to use technology and how you think about that and how you're overseeing that it's working well and being successful?
Yeah. So like I think previously mentioned, cath lab being very busy, you want to make sure the patients arrive fully informed. That's number one. And number two, they are very apprehensive when they're coming for the procedure to understand. So, you know, if you can think about it, 25 years ago, these procedures were not done the way they are being done now. They are not ambulatory anymore. So from there, telling somebody that you have, nowadays, everybody who walks into a cardiologist's office gets a CT scan. Then they say you have a blockage. Now you have to go and get the blockage fixed. Or sometimes you may even get an open heart surgery. So they get very scared and apprehensive. So usually used to be in a healthcare, which is, like you said, is highly regulated. A nurse has to talk to the patients. Often, the physician has to come online to answer their questions. So they are very comfortable to come. Very rarely patients will say, no, I need to see in the office first before I want to come and have the procedure. From that kind of an environment, now we are moving on to the so-called agent calling, right? Okay, agent is booking your flight, agent is doing everything else for you in your life, okay? But when you say the agent is now calling you and preparing you for a procedure, there is, you know, the legal is all over you. When I'm calling a patient, right? So I type the number and I tell the patient, are you Mr. So-and-so? Yes, I'm Dr. Keeney and I'm talking to you. That's it, right? But now the legal comes into equation and they tell, no, you have to double check it, triple check it to make sure you're talking to the right person. That's number one. So the patient has to confirm the name, confirm the date of birth, and it has to be only the patient. Often, the elderly patients are not able to talk to you or communicate to you. It's a family member that's talking to you. So when that comes into equation, they do not want the AI agent talking to the patient. So our point is, how difficult or was it easy? It was not easy to deploy this particular agent that we are talking about to call the patient. We called her Sophia, okay? So much training went on. Yeah, so much training went on to get this Sophia on board. My team is right here, nurse practitioners, where, like I told you, you need a physician, nurses, nurse practitioner, everybody involved to be part of it. And we want to make sure they were involved in making this happen. And why did it happen? Because to begin with, we have had a protocol. So that the nurses used to call the patient and there is a protocol. So we had to double train it, and then we had a pilot. When the pilot was happening, every single phone call was reviewed by my team here as well as myself, making sure that was appropriate. But if a human is calling, what do? Right? They talk to the patient, they just will write 2 lines, or spoke to the patient, answered all the question, and that's all it's written in the Epic. But here, you got to be like us, you have to make sure all that is recorded, and we now made it part of the Epic chart that the agent called the patient and all the answers were, questions were answered. So it is not easy to deploy. It is not easy for anybody to adopt it, but Mount Sinai has adopted it. Right now we are using the agent to call our patients for our cardiac procedures.
Thank you very much. We are at time. Did you have another thing?
That's my team.
If I may, so I would just point out 2 really points that the panel made that I hope everyone takes to heart. AI is not perfect, and it will not be. If 100% is your measure, we just need to stop. Space exploration was not 100%. Self-driving cars are not 100%. My question is, are the percentages of success better than humans? Because we seem to put a label on the technology that it has to be more perfect than us, as opposed to recognizing it as a fundamental supplement. Now, the danger is if we just take it for its word without doing the excellent checking that Dr. Keeney just mentioned as an example, then we'll fail. But if we expect perfection, then it's unfair, because the last time I checked, perfection is not a human trait.
Thank you very much. So that will be the conclusion of our panel. I thank my esteemed colleagues. AI Hype, it's about pragmatism. We went up to the moon and we came back down. Thank you all very much.
Good meeting you.
Thank you, Dr. Kinney. What an incredible discussion, from algorithms to empathy. That's the kind of intelligence that keeps healthcare human. Again, just a reminder, please, whenever you get a chance, we have other rooms. We have the Trumbull room, which is on the 18th floor, and we're actually discussing about the biases in healthcare. Very enlightening, and something definitely you should look into. All right, moving on. So, next up, patient care 2.0. No waiting rooms, no clipboard, no excuses. Healthcare just got a software update, and this is your user manual. Panel number next, innovation in direct patient care and precision medicine.
Thank you, Nikki. And for that, I invite our panelist, Dr. Zayed Baker, Consumer Medicine School Factor in the Lab Coat. Then we have Dr. Akin Oyalovu, Associate Medical Director at Included Health, Making Telehealth Feel Human. We have Dr. Krishnan Narasimhan, Value-Based Care Visionary, Proving Outcomes Outrank Output. And then Dr. Isaac Tapkins, I would like you to come back again. Returning because apparently one panel just wasn't enough for him. We like to hear more. And Dr. A.J. Rastogi, a data strategist turning care pathways into precision roadmap. Thank you. All the panelists, please. Dr. A.J. Rastogi, are you here? Somewhere, anywhere? Oh, there he is. Sorry. My near vision glasses and car.
Good afternoon, everybody. My name is Ziad Baker. I'm fortunate enough to be the facilitator. I was very excited at this opportunity. And I was more excited when we did our pre-planning the other day and I got to meet and discuss briefly with the folks to my right. I think for the next 20, 25 minutes, you're going to find it really scintillating and interesting. So we're just going to jump into it. We don't have that much time and there's a lot of discussion. So I just want to make sure we get to as much as we can. Innovation in direct patient care, concierge care, and precision medicine. Another way to consider this topic is we're not happy with healthcare and we need to fix it. I wanted to start with DPC, direct primary care. We have some experts who are familiar with this. I don't know how many of you are or have been familiar with direct primary care before today, but maybe if Dr. Krishnan, if you'd like to just start, give a brief background on it and your perspective.
Yeah, thank you, Ziad. Good afternoon, everybody. You can hear me okay? All right. Well, you know, before we just touch on DPC, direct primary care, I just want to step back a little bit, right? And you alluded to it in your comments. I think we're at a bit of a collision course, right? And we've talked about it a little bit. We're at a collision course between changing expectations around access from the public and structural issues that we have. And these include the infrastructure we've already built to deliver care, but it's maybe not the care that people want anymore, or they want something different, as well as, especially in the US, other structural problems, chronic underinvestment in primary care, misaligned incentives that maybe don't promote the type of access that people want. So that's the need that people are searching for. So it's access to be able to get the care that they want when they need it. It's access to having a relationship with someone who will work with you. It's access to new interventions. So there's a disconnect here. So why that thing's important is that collision course is the setup for all these types of models, right? So wherever there's some churn, there's chaos, there's opportunity, there's innovation. And that's, I think, what we see. So direct primary care is one response to that, which basically says, we don't like the current payment structures, especially under insurance models, right? Typically fee for service. So we'll depart from that. So it's essentially a subscription model where a primary care doctor contracts with about 400 to 500 patients, a small panel size, and it's a monthly or annual subscription, usually in the hundreds, sometimes to thousands, and they cover all primary care and some other add-on services, but not ER, not hospitalizations, not specialty care. So, but they do it so they can give more attention to a smaller panel of patients, give more time, same-day appointments, reestablish that relationship. So a lot of physicians really like that. About 10% of family medicine doctors in the United States have migrated to direct primary care practices. So it's a growing option, but it's almost an opt-out option.
Yeah, that's well said. I don't know how many of you have been familiar with this concept. Most doctors I speak to never heard of it 10 years ago, started to hear about it 5 years ago, but didn't know anybody who's doing it. And now it's a thing. And that 10% number is significant, but the rate of acceleration, I think, that we're seeing in the physician community is even more impressive. And I think the only reason something that when I was in training 17 years ago would have been impossible to fathom is now front and center, is you have the consumer patient frustrated with the system because they're paying more for less. And then you have doctors who are frustrated with doing more and getting less out of what they've invested their careers in, both financially and personally, reward-wise. Very few doctors I know today say, you know what, I'm making more than I did when I started, and I feel better about what I'm doing. And that stark truth, I think, is the spark. And the interesting thing about DPC is usually when doctors have an idea, we're great at fumbling the ball. It's rare that we could get together, put something together, and get the ball over the goal line. Usually the hospital systems and certainly the payers are the ones that score the touchdown. This, to me, is a bit of a canary in the coal mine, more than anything, more than the idea, because doctors are actually getting the ball down the field here. So I'm excited about it. But before we go a little deeper, Doctor, can you highlight some of the potential negatives with this model? What could go wrong and some of the criticisms?
Sure, happy to chat about that. And hello, everyone. My name is Akin Oyalawo. I'm a gastroenterologist by background, but don't see patients regularly right now. And the reason for that is a story from a few years ago when I was seeing patients, and it was a moment that kind of summarized a lot of the challenges that were going on in healthcare at the time. And to give just a brief summary, I had a patient in front of me who at the end of the visit essentially said something like, I waited 6 months for this appointment just for you to waste my time. And her frustration reflected a lot of the challenges I was seeing at the time, challenges with access to get in to see a specialist or even primary care, where if you look at survey data now, it still takes a month to see primary care physician in most geographies. Just missed expectations in terms of what a doctor visit could do and how that was going to help her symptoms and her health. And that motivated me to take a different path to figure out how we can improve care delivery and make the system better for patients. And I'm now in an organization where we focus on virtual first integrated care across all 50 states, including primary care as well as navigation and advocacy. On the topic of direct primary care, as mentioned, there are different models now. One Medical by Amazon is probably the one that maybe people in this room have heard, where you just pay a flat rate and you know exactly what you get from that. And I think consumers value that because with healthcare, it's hard to know, even if I have a doctor and insurance, when am I going to get my next visit? How long am I going to sit in the waiting room? How much time am I going to get to have with them? With One Medical and other direct primary care programs, all of that is laid out up front. Similar to Amazon Prime, you know what you're going to get, what you pay for. The downside is, as one of the panelists mentioned earlier when we were talking about artificial intelligence, you have to think about who has access to direct primary care and who does not. So this is probably going to skew towards people who have the disposable income to be able to pay out of their own pocket, to pay additional fees for that privilege to be able to have that primary care physician on call or to have that more dedicated support from a primary care physician. And we know that primary care is essential for a lot of the health outcomes such as chronic disease, preventive care. So are we going to now see existing disparities get worse because the people who are already higher income, higher education levels, those are the ones that are going to use direct primary care over those who don't have the income to do so. There's also disparities by geography. A lot of these direct primary care practices are based in metropolitan areas, so if you live in a rural area, you have access to this. And then the third thing being that it's a growing field, but the number of direct primary care practices in the US is still very small. So at a certain point, you will actually saturate what's available. And like I said, that's going to go to people who are in metropolitan areas and higher income areas. So I think it's on us as well who are pursuing direct primary care as an option, whether you're a system, an individual provider, to think about how are we making this something that's sustainable and equitable.
Thank you. And the next question on this topic, I think just as we think about the natural evolution of how this plays out is, well, if I as a consumer are going to be paying more of my wallet share to the doctor directly, is the insurance company going to be left out of the party? And so whether, maybe Dr. Dapkins, if you want to talk about this, do you see a world 3 years, 5 years, 7 years, 10 years, where many consumers are opting out of insurance altogether, and or there's disruptors from the insurance side, startups, that embrace this and they go back to catastrophic insurance models or so on, where this can trickle down, or do you think it's going to be siloed and contained by the great forces that are United, Cigna, Aetna, and company?
Boy, that's a deep question with a lot of potential answers. I have to disclose something to everybody, and that is that I love my job. I'm a primary care doctor, and I have evolved to be, an administrator. But I love my job because I love the relationship with people. I think that ties a lot of doctors together, this sort of love for this engagement with people. And I think care, especially in primary care, has changed. It used to be criteria-based. If somebody came in, you had to remember whether they had something done. And now, our jobs are much more about interpreting risk and helping people understand decisions, especially when decisions from various different layers of the health system come back to people and they don't know how to make decisions. And all of that is to say that the way that we render care will lend itself way more to shared savings types of contracts more and more. I have the luxury of and the benefit of overseeing Medicaid IPA, and I can tell you that our cost in a very well-structured primary care practice that focuses on wellness, prevention, and chronic disease management is a very successful way to reduce cost in a healthcare system. So I can't comment on the future exactly, but I can tell you that I really will still be doing the same kind of thing I'm doing now. I'm just going to be doing it a little bit different, helping people understand their risk and helping use that to drive the quality of care that we deliver.
Thank you. On the point of value-based care, I think this is one of the few audiences that understand like VBC, IPA, CINs, and this alphabet soup that's seeped into healthcare that I think, and I'd be curious about your shared experiences, has been very confusing, intermittently successful, and always burdensome for most doctors. And I think your success story is an outlier. I've been part of many, I'm sure many of you, SINs, value-based care. You tell the doctors to change their workflow, focus on keeping the patients out, and there's going to be a reward at the end, and you can spend more time with the patients. And this has been well over a decade now, these efforts, and even CMS and the governments. And I find that we're pretty much where we were 10, 12, 14 years ago, and it was a promise. And so that's kind of why I think this DPC thing is, with the proverbial doctors shoving everybody, the administrators who coordinate this and the TPAs, saying, we're going to just kind of do this for ourselves with the patients, I think is a bit inspiring, whether it works or not. And Dr. Rastogi, I'd like to ask you on that theme. Really, the underpinning this is this, we talked about the change in doctors, but there's a consumerism. This patientism is becoming consumerism. And they're saying, no, I'm not going to just go to an area network. I want to pick my doctor. I'll pay for my doctor. I value accessibility. I'm not just going to accept long waits, which sounds good. I think it's good. But then there's these full body scans, consumerism. There's these $1,000 genetic testing that often patients or consumers hear about, want it, don't know what to do with it. Can you talk about the global theme of increased consumerism in the patient space?
Absolutely. So hi, I'm Dr. AJ Rastogi. I'm the co-founder and CEO of North American Medical Associates. We're a multi-specialty group in New York, New Jersey, Pennsylvania, and Delaware. One of the clinics we run that pertains to this is called Heroes Medical, and we provide primary care or wellness or anti-aging longevity services to those in the community that normally may not have access to it through their regular insurance means. And so from a global consumerism standpoint, what you're going to look at, and I think a lot of the other panelists have touched on it, is you're not going to have access to all the services at all the demographics. We provide hormone replacement therapy for menopausal candidates. We provide GLP alternatives for those who don't get it through their insurance. And those are all out-of-pocket services. And so those who can afford it and those who wish to go through those routes are going to participate. In terms of trying to make this more affordable, I think we've had a lot of conversations about technology. I think that's where technology will help make this scalable. I sit on a board for a company that handles a lot of services for federally qualified health centers. And in those regions and in those areas, they don't have a lot of resources, and they don't have a population that can afford outside of the regular insured service lines. And so in those ways, can we bring down the cost of doing medicine by using technology? Is it the use of an AI nurse that's a lot cheaper for the run-of-the-mill types of tasks that we have our clinical staff that cost more doing? So I think that's how we're going to kind of bridge the gap between these lots of different, different groups with different variability in their income and their ability to participate in the full suite of services.
Thanks for that. And then I think, Dr. Rastogi, you might be the only specialist on the panel. And sorry, you're GI as well. I'd like to ask the two gentlemen a very brief question before we go on. In terms of DPC or concierge medicine, whatever flavor, and maybe this is a good point to mention, we use these terms interchangeably because the concepts are relatively interchangeable. You have a spectrum, you mentioned One Medical Group, you have pay 10, 20 bucks a month, but we still take your insurance. So 92% of their P&L is still Cigna and United, all the way to, we don't take insurance, you pay us $200 a month, and that's what we're gonna accept, all the way to private medical, Atria, and $100,000. And Dr. Peter Tia was on 60 Minutes the other day, six-figure kind of entities. But what you notice is they're all primary care by and large. And the question I have is, do you see, I've seen a couple of this practicing in the New York market. Do you see this happening more and more with specialties? I would exclude like the likes of plastic surgery, where that's been a cash pay play by and large. But let's say secondary specialists like GI, like neuro, like ENT.
I see this now in value-based care arrangements. There are some organizations within GI, for example, Oshi Health is a health tech company where they are virtual first also. Their gastroenterologists and NPs and PAs work remotely with patients and coordinate with local practices. And it's valuable to health plans, employers, anyone that pays for care because it's a lower cost way, but they also have a incentive structure that allows them to have longer visits. And for those visits where, let's say it's irritable bowel syndrome, we know a lot of that is focused on, understanding triggers and understanding some of the psychosocial and behavioral factors that go into it. In a traditional brick and mortar fee-for-service GI office, you're incentivized to just say scope or not scope. Whereas with these virtual first practices, now you can kind of change the dynamics and focus more on that longitudinal discussion. And when those people need procedures, you can still route them there. So that's an example for sure.
And I'd like to at least be able to touch on precision medicine before our time wraps up, and then we can go wherever we want to with any spare minutes we have. But I'd go back to you, Dr. Krishnan, before we go a little deeper on precision medicine. I don't know how everybody else feels. When I hear the term precision medicine, my mind goes to when I hear the term holistic care. I could ask 10 folks what it means. I'll get 20 different definitions of it. Can we start with maybe some, grounding on precision medicine, and then where it can be good, where it's misunderstood, and where you think it's under-leveraged?
Yeah. Well, thanks for that, Ziad. So I think, it's a term that's definitely out there. I think it's in the eye of the beholder and a lot of different definitions, but kind of a basic one is personalized medicine, right? Personalized to the individual patient with a focus on thinking of everything going on that affects their health. Specifically, things that we may have left out in the past in medical care. Thinking about lifestyle factors, thinking about environmental factors, and especially thinking about the genetics component. Genomics, pharmacogenetics, how can we tailor our treatment to this specific individual, and especially, their genetics, which determine so much of what they do. So that's the definition that's out there. I think if you talk to anybody, any doctor, or especially anybody in primary care, Isaac, you could back me up on this, right? We were definitely doing that personalized part before that. Every doctor, actually, right? You're tailoring the treatment plan to those individuals. I think in primary care, we already were talking about lifestyle and environmental factors. It's just hard to do in 15 minutes, right? Hard to give that the attention that the public wants on those areas right now. The genomics piece is growing fast, is very interesting. I look at one of the key things that I work on is asthma, and the identification of what's called type 2 inflammation and the biologic treatments that you can use for those patients has been a game changer for so many patients, but it's not for everybody. So we've seen some advances. I do feel the genomics piece has been the slowest. I feel like I was having this conversation about 10 years ago, where everybody's like, oh, it's coming, it's coming. I'm not quite sure it's there yet, but with AI, with all the other advances, I'm sure it's going to increase. And of course, we see public demand for that. That's my sort of take on where we are with precision medicine. It's a bit wait and see, but some of us have been doing parts of it all along.
Yeah, and Isaac, I'm going to have a follow-up question for you on this. The other day I was talking to probably the smartest doctor I know, and she's in precision medicine in some capacity, and I asked her opinion. She said, and this is what she does, and she said, Z, your BMI is 30. Just, less carbs and walk more, and that's very precise to you. And her point was, with all the wearables that, 64% of us are wearing right now, or all the apps, measuring our sleep that 18% are using, still oftentimes we overlook the most basics. We do have quite a bit of data at the individual level that is grossly under-leveraged. And so I think your point's well taken. Isaac, if you want to just build on that and share your perspective.
Yeah, I mean, I'm going to just quickly, I had an interesting conversation with a gentleman I met at this conference, and I asked whether he had a CT calcium score or not. And he had not, and it's because he's an oncologist, and it's because he felt that the risk outweighed the benefit given his known history. And so when we talk about individualized or having individualized care plans, what's really going to be critical is having all the right information at the moment that you have the interaction with the patient. And being able to pull all this information, all the AI generated, everything that's changing every single day is really what the biggest challenge is going to be for us. And so I would just say that contextually having the ability to put that information quickly, consumably in front of somebody who can help them have a treatment plan decision is really what our biggest problem is.
Yeah, I agree. I think the only thing that I wonder is, more data is not always better data, and oftentimes there's data overload. And I think right now the ability to garner more data is outpacing our ability to digest and effectuate patient care. And I think when I'm listening to some of the AI and the tech stuff, I think that's a vertical that if someone can crack, even with what we have today, not getting more data, but better optimizing the data we have on our patients, would be a great breakthrough. And the last kind of open-ended topic I figured if everybody wants to opine is, broadly speaking, this is a simultaneous patient and doctor empowerment, revolution, rejectionist time, right? Patients are spending more dollars on wellness than ever before with no middleman, and doctors are peeling off of health systems that hired them before or going out of network more than ever before. Can each of you just make some comments through a crystal ball? Where do you think this should go versus maybe where you think it will go? We can start with you, Dr. Wisdom.
I think you're going to continue to see consolidation across healthcare, and so if you're part of a consolidated healthcare delivery model, then you're going to have that support structure where you can practice the routine, methods of medical care as a physician or some sort of clinician. If you're an independent practitioner who doesn't have that kind of resource, I think you're going to be more inclined to explore other ways of providing care to your patients and generating additional revenue to offset declining reimbursement or increasing cost of care. And so I see this being a much more experimental model for those individual physicians who already have a very loyal fan base or patient base that really like them, that think, they have a high level of trust and rapport, and they're willing to spend the time to learn all these other new treatment modalities that are coming out, and they're willing to develop that part of their clinic as an offshoot or as almost like a hobby, right? I think that's where it's going to grow, and that's where I've seen it grow.
Yeah, my answer for where I see it going and where I think it should go, similar for both. I think today's healthcare system, we lump a lot of things into the healthcare bucket. Some of that is preventative wellness, some of that is acute care, some of that is catastrophic care. And it's very challenging for patients to navigate that because it's hard for them to predict what their bill is going to be. It's hard for them to get access. I think where it's heading and where it should head is that you start to disentangle when someone is doing something that is an individual action to improve their health or promote health. That could be through their diet, through exercise, through a wearable, they will pay for that out of pocket, or someone will give them the funds, whether it's an employer or government, will pay for that out of pocket. And then we'll start to see health insurance be what traditional insurance usually is, which is insuring against catastrophic injury or insuring against catastrophic financial damage. And in that system, then I think people will be happier understanding, okay, I'm going to go to the gym, get a dietary plan, and I know the cost for that. But if I unfortunately get cancer, I have this other system to help with that.
Yeah, I think both those models are growing, and I think they'll be a decent part of the marketplace, but I don't think they'll get majority share at all. I think we'd be at a bit of a crisis point if we were getting to that, and I think the public is going to demand other things. Most care delivery, despite all you hear about these models, is still largely done through standard models, health systems, some private practices as well. I'm actually the chair of family medicine, and I have a network that we have like almost all of these models all across our system in various ways. So it's really interesting to see. And what's fascinating is that people get a lot of good care in a lot of different ways, right? I suspect patient satisfaction scores are obviously a little bit higher when you're paying thousands of dollars to see your doctor, but there's good care that can be delivered. But this sort of mismatch between what the public wants and the way that the health system is sort of oriented, I think that's going to have to be sorted out. And I think, Dr. Rastogi, you brought up consolidation. I think that's going to continue to create even more challenges, because the larger systems get, the harder it is for them to meet the needs of an individual patient or population sometimes. So, that's what needs to be sorted out, but I think that's an opportunity for innovation.
I'm going to just, I'll be quick, just reflect on the folks that started the conference and how it's our obligation to improve the system and to take care of everybody and figure out how to do that effectively. And I think in order to do that, we need standards, and we need to maintain those standards across all of the care that we provide, and we have to use data to track it. And I think that the challenges of having very different delivery system types will mean that people with more money will have much better health than people that don't, and that's going to mean those numbers don't get better.
Great, yeah. And when I was in the Uber on the way here, I was reading the article. I think it's Mass Brigham, one of the mass academic institutions, the doctors are unionizing. And when I was thinking about some of the questions for today, and I'm hearing doctors are unionizing, never would I have imagined that. And so I think, suffice to say, there's some kind of revolution. Most revolutions don't make it. We'll see about this one. And so a big round of applause, please, for the panel. You want to give the gentleman the mic, just so everybody can hear?
I can repeat his question. He said that, is there any evidence that patient satisfaction or physician satisfaction got better with concierge medicine?
Yes, that's a question.
I'm not sure on the evidence for concierge medicine and direct primary care, but as a proxy, if you look at Medicare Advantage primary care practices, which are a similar model, in Medicare Advantage, it's capitated, you get paid rate for managing a population that's attributed to you, and therefore those practices are incentivized to do things like longer visits, more frequent visits, building in social care, et cetera. And when you look at data there, both patient data and provider data, it does show improvement in satisfaction and in outcomes. So I think that potentially is a model that could be applied more broadly, whether it's direct primary care or some type of value-based arrangement. And I know we have a panel coming later on value-based care, and that's maybe something for them to dive into.
I think that's a great analog. I used to be at Optum and United, and we did a lot of Medicare Advantage risk. And I didn't think of it that way. I think that's a brilliant point, is it's early, so nobody can give you a hard answer. I mean, my intuition as a doctor says, so let me get this straight. I spend more time with my patients. I don't have to do prior auths and get approvals through third party, and the patient can access me. It's got to be a win-win, anecdotally. Nonetheless, I think the closest analog is the full risk Medicare Advantage. Someone else had a comment?
You asked about customer satisfaction, patient satisfaction, physician satisfaction. So, you know, we may be at risk of losing telehealth services, right? And so if that happens, I mean, we've all, you know, generally become accustomed as using that as a valuable tool to connect with the patient and do a visit if they had transport issues, they were too sick to come in, or it just didn't work out. And so if we lose that on the insurance side, I think that still could be a viable way to treat people on the concierge side. And that level of comfort and that level of value and convenience, that may add some of that value to the price point of delivering those care and making just the life of the patient and the clinician a lot easier.
Thank you, everybody.
Right, thank you everyone. So quick housekeeping note, everyone. If you are near the back, please help us keep the noise level down and the aisles clear. The Yale Club requires it for safety compliance, and it also helps everyone in the room to stay focused. So please keep it a little down back there. Also, over in the Trumbull room, which is on the 18th floor, 2 floors down, the experimental tracks are buzzing. If you haven't checked them out, put it on your list. So, all right, now moving on. Innovation thrives when backed by teams who keep hospitals running 24/7. We're talking about in-hospital physicians, IHP. Our sponsor talk, the steady pulse behind the practice. Please welcome Mr. Hemant Neely, Dr. Hemant Neely.
Thank you. Hey, do you have a mic?
Right here.
Is there a hand mic? Can you hear me? Yeah, thank you. I don't know if this chair is going to help you guys because I might have some slides to show. I know some of you guys up here already met before. Can you still see the slides, or we got to move this probably a little bit more, I guess? All right. Thank you. So my name is Hemant Neely. I'm the co-CEO of and co-founder of In-Hospital Physicians and Zebiltech. We are honored to be a sponsor of the Global Health Congress, and it's a pleasure to be here. Everybody has been talking about AI since this morning. I'm not going to talk about AI. I'm just going to give a pep talk about our 2 companies. All right, so I've only got 10 minutes, but I have like 40 slides. So can I make it? I can. So I'm going to give you as brief information as possible. There are several CEOs and chief executives, corporate executives in this hall. As everybody knows, the success and failure of a health system or a hospital, from my perspective, depends on 7 factors. So if I can line it up, it depends on demographics, payer mix, and effective hospital medicine, efficient emergency room, aggressive surgical volumes, extensive network of PCP referrals, a robust RCM process with good payer contracts, and last but not the least, the fixed cost for each hospital and health system. So if you can line up all these 7 and do a good job, the hospitals and health system will be successful. But we have been seeing news all over the time. It's hospitals failing, the health systems crashing, bankruptcies, closures, and so on and so forth. Out of these 7 factors, we are involved in 3 of them: emergency medicine, hospital medicine, and revenue cycle management. So this is our company, In-Hospital Physician. It's a physician-owned and operated practice management company. It's been in operation for 15 years, founded in Philadelphia. And next slide, please. Do you have the slide mover here? Or can I have it if I have it? Is this the one? All right. I got it. Can somebody show here? This. All right, got it. Thank you, yeah. So our core principles are accountability, provider excellence, and collaboration. Through these core principles, we achieve all the outcomes. So we provide multiple service lines. When a patient comes into the hospital, from the time they come into the hospital and get out of the hospital, we take care of all the service lines from emergency medicine, hospital medicine, ICU, and post-acute care. We place ourselves strategically in post-acute care so that we can create value for our partners, especially if they are in bundle payment models. We also provide mental health services in post-acute care, as well as adult psychiatry and geropsychiatry units. So this has been playing with me, actually, looks like. What's the advantage of IHP? We are very confident in getting a customized staffing model for all the hospitals. Our emergency medicine and hospital medicine synergy works very well. It's well-seasoned oil machine. It provides outcomes, what is required for all the hospitals. We are data-driven. We do have proprietary dashboards, which gives us a pulse of each program on a daily basis, and we can see how it's performing across the board in multiple states. Actually, we do this in real time because of interfaces with the hospitals. We also have a strong recruitment team, which helps us in getting the right staff to the program. We have around 450 providers across 6 states. Everybody goes through rigorous training in terms of onboarding, documentation, coding compliance, and everything. Even though if they've been practicing for several years, they go through this training with us. And that plays an important role why we are successful both in hospital medicine and emergency medicine. How do we provide value to our clients? So this is one of the important slides of this talk, I would call it. Every hospital, when we go in, we can look at the numbers and come up with what's the value we can create. It could be tens of millions of dollars. And how do we do that? So through our emergency medicine, what we can achieve is decrease our length of stay, improve the throughput, and teach our physicians how to use resources appropriately, which enables into risk mitigation as well as increasing the acuity of the patients being admitted to the hospitals. Through our hospital medicine, we can decrease the length of stay, optimize throughput, and if the hospitals have a flex model of nursing, they can cut down their costs because the throughput is improving and the inpatient census keeps going down. We can also provide valuable information in terms of decreasing the readmission rate, decreasing hospital-acquired infections. All those things play a significant value, and our team is focused on it. Our physicians are aligned with productivity and performance based on what we see as the target goals for the clients. So this is the first company, and the second company I want to talk about is next slide, please. So Zebeltech, So this was actually a pet project we did for ourselves for in-house practice management. So we had a third-party vendor, and they're doing a terrible job. They had a predicted as collection per visit, and eventually when they came down, it was like 30% down. I said, what's wrong with this process? It's so easy to do it. Well, it's not that easy. It takes a lot of effort. And we created this for our own company, and eventually it is so technology-driven and so successful that we spun it out and make it a separate company, and now we are making it available to all third-party practice groups, small practice group, large practice group, multi-specialty, so that we can share what we have experienced through our revenue cycle management. Let me give you some blurb about our technology platform on RCM for ZebelTech. So we have a real-time analytics platform called Panorama, which gives you actionable insights into every domain of the RCM cycle. So that helps us improve our collections from the get-go. We also provide a charge capture software for outpatient practices who struggles with sending the claims in a proper time. So what we do is, this is available free for all the providers. They can put in their claims and drop the bills, and it immediately results in reimbursement. The third one is the AI and the automation. I said I won't be talking about AI. Unfortunately, it came into this. What we do in the AI and automation is across all the domains. We have used automation to help us speed up the process. So we're able to collect the money fast, have a cash flow predictability for all our physician groups, and as well as provide accurate coding as well. So these are some of the benchmarks, what we can achieve through ZebelTech. If you look at industry average, it depends on what practice it is. Days in AR could be like 55, 60 days. We are able to get it under 40. The first pass resolution rate, that's the important piece of it. How soon a claim is getting paid without any rejections or denials. We keep it close to 90%. Our denial rate will be less than 5%. How are we able to achieve all those things? If you look at this, one slide back, please. So if you look at all the domains of RCM cycle, patient access is one of the important pieces of it. Demographics and coordination of benefits is the holy grail. The second holy grail is the management of AR. If you can get these two right, then you have a great RCM product. If you don't, probably you'll be still scratching your head, why am I not collecting? So we play a significant time in automation and verification and making sure that we get the patient access right, the demographics right, and the coordination of benefits right. Sometimes you are sending the claim to a wrong payer, and you're saying, why am I not getting paid? Why am I not getting paid? That's because you're sending it to the wrong payer. So it's key to us we get the first step right and the last step right, and everything else will come in play. In fact, our success has been, in the last few years, what we have shown is, when we did a pre-engagement analysis with our clients and say, hey, what's our collection per visit, we're able to achieve exactly the same or even exceed our CPVs. That's because we are able to do a little better job in patient engagement and collection of copay and deductibles as well. We've been using technology all across in all the domains, and it's an incredible journey. And we have left some mini brochures for everybody on the tables. We'd be happy to talk to you. Anybody is interested in this, either the in-hospital physician service lines or ZebelTech platform. And looking forward to have a conversation sometime during the rest of the evening and next day as well. Thank you so much for the opportunity.
right, so now we are moving on to our, not the last session, but last session before coffee break. It's risk, reward, and results. What's next for value-based payment models? And facilitator for this session is moderated by Dr. Michael Kopko, and I will let them introduce their panel members. Thank you.
Dr. Mulik, you want to say something? Yes. All right, hold on one second, folks.
So quickly as Joe Rafferty, take a seat. Craig Cooper, raise your hand. He just swam the Greek islands, 33 kilometers. Give a big round of applause. Where is Purnendu Roy? Wherever there's Purnendu Roy, there's an aggregation. He talks very loudly. He's here. It's quiet. Good. So he's alone. That's a good thing. Guys, please come forward. False accusation. Okay. Everybody, please come up. This is an amazing talk. There's an amazing panel. I know Michael Kopko through my years in healthcare as a CEO. He's one of the most brilliant people I've met. What he's going to tell you, you need to distill carefully because value-based care, Medicare Advantage plans around the country are run well by very few. He's one of them. Please pay attention.
Okay, thank you, everybody. Impressive to see so many people out on a Saturday. What a good crowd. I'm going to start with something that Charlie Munger said, not myself. Show me the incentives, and I'll show you the outcomes. Healthcare is not a mystery. It is a set of predictable events based on what we incentivize and what we pay for. There is no mystery here. We're bringing forward to you today 3 of the preeminent leaders in how value-based care and payment models are changing and how they're applying that to their businesses. And I'm very excited to get into the discussion. I'm going to ask a question, but I'm going to just let you know who's in front of you. We have the leader of the largest and most important physician groups in the state of Connecticut, Lisa Trumbull, their CEO, is here. The SVP of High Valued Care for the University of Vermont's Health Network, the largest system in Vermont. And then the EVP and leader of policy for the American Physicians Group of our country. These folks know how value-based payment models are changing, and we're going to get into the discussion today of how they're applying it. So let me start first. Valinda, over the next 5 to 10 years, how do you see the payment model for our country changing in your seat?
Yeah, so one of the things, first of all, thank you so much for inviting me. It's always nice to be just before the coffee break, so the bar has to be set high. So, Mike, I would tell you one of the things that I'm hearing from DC, particularly with the current administration, is the need to have more savings to the trust fund. And many of these models that we've been testing, MSSP, ACO REACH, many of the primary care models, have been successful in terms of improving quality. However, as you know, Brad Smith had an article several years ago that said out of 34 models, only 4 of them saved money. So right now, the Trump administration is really focused on any of the new models coming out will have to save money for the trust fund. So what does that mean? That means that you will see in the next generation of models, and we're anticipating that CMMI could be releasing close to 10 new models over the next few months. We will see them in which they will have a lot more risk for the participants, but also, Mike, a lot more opportunities for financial opportunities for the participants. So I will tell you what I see in the future from a public standpoint is in terms of higher risk, but higher opportunity.
Thank you. And for panelists, you can just move the mic closer to your mouth a little bit so the back of the room can hear you. There is a huge problem for the government. Today, there are about 68 million seniors. That is a rising population. Will be just around 85 million by 2040. Costs continue to grow. Jessica, you see this problem in microcosm in the state of Vermont. Can you walk through a little bit how you're preparing for this demographic shift? How do you think about value-based care more broadly in the state of Vermont?
You know, first of all, in Vermont, we're already living the demographic shift. Depending on the data that you look at, we're either the oldest or the second oldest state in the country already. Part of what we're doing is thinking about how do we innovate and approach new payment models, and then how do we take the ones that have proven success and implement them well, without trying to do too many things at once. I think that's one of the biggest complications. When you have a patchwork of models, it's easy to try and do too many of them at once, rather than focus on what you know is successful. And so for us, knowing that our aging population is the largest population, that's where we want to focus. And then we want to focus on the models that work. So elements of MSSP, elements of ACO REACH, the things that you know are going to work. You can't just have the model, though. You also have to have an aligned clinical delivery system. And that's more than just provider buy-in, which is really a buzzword. It's really about having clinical leadership drive the change in an organization, and then measure that change and show it to not only the people that work in your organization, but the community writ large, to explain what you're doing. Right? It's not just about talking about delivering care differently. It's patients need to be a part of that and understand when they're receiving care from a team, for example, than just their primary care provider. That's part of the change that you're working on delivering.
Thank you. And Lisa, you navigated your organization through a big change. And the state of Connecticut also struggles with how it deals with the delivery of healthcare more broadly. The prior panel said the shift to value is not a real one, and it's really a fee-for-service culture. Tell us what the state of affairs in Connecticut and for your physician organization.
Yeah, let me just clarify value-based care, because I think everybody knows it. It's kind of like the unicorn. Everybody can describe one, but nobody's actually seen one. And I'm going to be provocative. It's like putting lipstick on a pig and calling it a supermodel, and assuming that it's going to be the thing that's going to save you in healthcare. And it's not. It's foundational. I believe it has an opportunity to do significant improvements in outcomes, both health outcomes and financial outcomes. The challenge is layering it on top of a fee-for-service chassis doesn't work. Because until the payment model changes more dramatically, we're going to continue to see the fragmentation and the results not be what we want. Now, I can tell you value-based care models save money. And for our organization, over the last 6 years, we've saved $110 million, but for our partners, that's payer partners and the government, but not one iota of a cent came out of the premium. And the challenge is how the payment structure works, right? If you're contracting with, the only place where it's actually had an impact is in Medicare, where the Medicare trust fund saved money. But when you're working with commercial plans or Medicare Advantage plans, a lot of times the dollars you save go to the bottom line and don't actually address the premium part.
I'm going to switch over to hospital systems because we have a lot of larger organizations in the room, but just maybe as a quick show of hands, how many of you take risk in your business model today in the audience? Not as many as I'd think. So we're going to leg our way there. So one of the other debates in value-based care that we've seen is that the hospitals are going to hold out. And we've seen payment models, global payment models, very tight relationships with states that will reimburse on a regulatory level. Jessica, maybe you're kind of in the middle of the crux of this. A very heavy regulatory regime in the state, lots of changes in ACA, Medicaid. How do you navigate a health system in a time where reimbursement models are changing and you have uncertainty around them? How do you think about building an organization for that?
Value-based care can no longer be our side hustle. You know, you can't nibble around the edges anymore. It has to become core to your business, and you have to fully change the way that you're delivering care. And I think where a lot of organizations have struggled is it's only been a part of it. You've only taken risk in one area, a part of an area. It hasn't included the hospital. It hasn't included specialists. So, you know, that's my answer, which is we've got to move into a space where it's real. And sometimes you have to do that because you're forced to, not because everybody wants to. And you have to also think about where you can be clinically innovative within that model. So for us, we're looking at hospital global budgets and primary care or total cost of care arrangements. So we're changing things for hospitals and for primary care. I think primary care has a lot more experience in this space and is better situated initially, but there's no reason why we can't get hospitals there. And so we're starting in Vermont by experimenting with hospital global budget models.
Belinda, if you were going to predict kind of what to prepare for if you're in the audience over the next 5 years on a policy level, what would you tell people who are running any kind of provider organization to prepare for?
So first of all, I think you should prepare for mandatory models. It has been very clear that this administration is very eager to implement them. We have the first mandatory model that will be beginning in January, the team model, that will be an anchor in the hospital. The second one will be coming ambulatory specialty model, which will be congestive heart failure and what? No, it wasn't Sue. COPD, thank you. And it will be focused on the specialist. This administration is planning more mandatory models. And why is the reason? Because we have seen that the amount of savings in the voluntary models have started slowing down, because we understand that it's the same individuals that continue to be the participants in it. And we know after a time, the amount of savings that they have starts slowing down. The amount of participants in these models are starting to slow down the growth of it. And we are aware that a lot of the people, particularly health systems, are a holdout because they are saying that they make so much money in fee-for-service, they have no intention in moving into value and taking risk-based. And so the administration is looking at total cost of care mandatory models. And so I would tell you, Mike, that the best thing you can do is get ready for that transformation. And understanding that from a physician fee schedule, we're not keeping up in terms of from an inflationary factor. The only way you're going to be able at the hospital level to be able to pay the bills and keep the margins up is to be able to participate in these value-based models.
Thank you. I want to put Jessica and Lisa, you in the seat of someone who is going to have to take risk over the next 5 years. Let's just say that's true. It's true to different extents. We've talked a lot about technology, a lot about AI, but what do you need from technology to do that well?
Yeah, sure. I think what we need from technology to do that well, we talked about the workforce issues earlier this morning, is certainly to be able to leverage technology to reduce the amount of time it takes to see patients, to allow for a broader segment of patients to be seen in these models, because we know when patients don't get access to a provider, their solutions are to go to a urgent care center or hospital, or to, or not seek care, and then their conditions just worsen. So I would say anything that reduces the amount of time it takes to complete the mandatory regulatory requirements of a visit, and that's true for a hospital stay or whatever. And then any opportunities to advance education of patients. In terms of how to manage their own care, how to self-care, when to escalate care issues, because we find most times they're getting the wrong information from the wrong resources.
Timely access to accurate, interoperable data that can be used in predictive modeling, that you can use in AI, that can drive workflow and decision-making, that can help across the entire continuum of care. We have it in fits and starts and different types of arrangements. You might be able to negotiate certain pieces of data or certain components of it, but overall, we're lacking full, timely access to all data transparently and for all parties involved.
Yeah, I want to piggyback on that because we spent a lot of time this morning talking about AI and the promise of AI, but AI assumes you have the data, you have the tools, you have the information, and we are sorely lacking. Interoperability is not there systemically across the system. It is not there in a way where it facilitates the information in a timely fashion to get it to the clinician's fingertips, unless you are on one big system with all of your providers capturing every ounce of data that could be done to a patient. And we all know that a vast majority of patients' information is outside the medical record now. So finding ways to capture that, finding ways to increase connectivity to produce the intelligent data that we need, that we can leverage tools like AI and predictive and prescriptive options around the use of tools like that.
And I would like to reemphasize that. I think timely data has been a real problem in the CMS models too. All the participants have said, both at the MSSP level and the ACO REACH level, that they need to have timely data, and the lack of it makes it very difficult for them to be able to achieve their benchmark in the savings.
Belinda, I want to come back to you in a second, but Lisa and Jessica, this room's full of a lot of technology companies, vendors in certain ways. There's 1,000 behind them. The problems you describe are real. What is the failure of implementation and solving? How do you kind of wrestle with an organization that wants those solutions but then struggles to adopt them? And what do you need out of your partners, and what do you need to do better as an organization?
I would say there were two challenges before even getting to that. There are so many tools, options, very bright people like all yourselves out there developing solutions for us that could be very valuable. It's really hard to sort through which ones actually work. It's really hard to sort through which ones can actually produce the results that they suggest that they're going to produce. So to the extent that you have tested your solutions in a real marketplace with real patients and can produce the results, it's really hard to figure out how best to invest in and spend the very few dollars that we actually have on the tools that are going to have the greatest impact. And then I would say the second part is how you approach us in pricing your model is a big barrier. If you're coming to an ACO like ours or to a hospital system and you're going to say, well, this is going to cost $10 per member per month for me to operate it, I'm going to say, how am I going to finance it? If you tell me you're going to share in on the savings, great. You want to wait 24 months to see if I have any? Those are the challenges with trying to finance technology and develop and deploy technology.
The other thing I would add to both of those is anything that takes a provider outside their workflow is not going to work. So it has to be integrated into the way that providers make decisions for patients, because the time is so limited. And even if you're working internally on aligning incentives, so your comp models are changing to be more of a more value-based comp model, you still need to value providers' time. We want physicians doing physician work, and so you can't have technology that isn't interoperable into the workflows, into the EMRs, into the way that visit functions, or that piece of data or information needs to be. It can't be somewhere else. And I think that's one of the biggest challenges I see. And I think that's one of the things that we're often told is it will work in the workflow, and it rarely does.
Belinda, I'd like to kind of combine two questions into one, if it's okay. You kind of represent the largest body of ACOs and physicians in the country. You have deep channels into the policy world. How would you advocate on behalf of providers in this moment of time on a payments and technology basis? What are the top priorities you think for the physicians of our country, the ACOs of our country, on the technology and payment dimension?
Yeah, so what I hear from our members at APG that are involved in these risk-based contracts, and they're involved at an ACO REACH level, an MSSP level, and they're also involved at the Medicare Advantage plan level, taking risks with the plans. And Mike, what they say to me is, number one, they need timely data. Not having a data that is given to them in a timely basis really hinders them in terms of identifying where the issues are at. Second is care transformation you have low-hanging fruit and you take care of that, and then the rest is a long haul up the mountain, and it takes some time and effort, and people are looking for a quick win, and sometimes it's not possible at all. And then final is fraud, waste, and abuse, particularly fraud, is becoming a major issue. With the introduction of AI, it has allowed some bad actors to be able to very quickly go through Medicare data and be able to very rapidly be able to distribute some, one of the biggest issues right now is skin substitutes. Last year, it was catheters. And we're seeing it that the ACOs at the MSSP and ACO REACH level, the amount of 10 to 15 to $20 million of fraud that has been found in the ACOs. And I would tell you what I say to the government officials that I meet with is look to the participants to help you identify them. They're real close to it. They know who the bad actors are, and they know where the issues are.
Thank you. I'm going to change the question just a little bit for Lisa and Jessica. So let's say Dr. Oz is here. He was here last year. On the dimensions of reimbursement and technology, what would you want to advocate to him on behalf of your organizations?
I think flexibility is really important. The ability to try different things and to think about it. I think the other thing that's really important when it comes to reimbursement and is the sort of perpetual necessity to count widgets makes the transition away from fee-for-service to value-based care almost impossible. And the fact that everything has to be anchored into, well, how would I have done in a fee-for-service world? And we're never going to break fully into a value-based world if we have to anchor everything back to fee-for-service. And I think we need to challenge ourselves to think about that differently.
I would add to that, to look at the populations of providers that are actually operating in this space and not treat them all the same. There's a general assumption that providers have deep pockets where they can make investments in infrastructure in a way that's going to make them successful in value-based care, and that couldn't be further from the truth. So I think that there's some infrastructure investments that the federal government needs to make to ensure we have the interoperability, we have the ability for data to flow between multiple partners. I have patients that go to Florida every year. I can't get their data easily. But get some standardization in the way data is aggregated, the way data is shared beyond what already exists in terms of regulations, and make some investments in infrastructure. On the payment front, I would say start pivoting away from the fee-for-service models. We need to make that break. For those of us that have been in value-based care models for more than a decade, they're a race to the bottom. You alluded to it. After so many years, you cannot make any more improvement without systemic improvement in the delivery of care or the financing of care. And many of us are getting to that point. So we need the opportunity for payment changes and the ability to manage payments and populations in a different way. And I think the AHEAD model actually gives some opportunity to really look at this and look at value-based care risk of managing an entire community of patients. And I think that's the direction we need to move forward.
Well said. So while a lot of our conversation's been around government risk sharing and ACOs and different payment models, I want to shift gears to the private sector. There was a time where we talked a lot about private sector risk. I'd be interested in your take today. Is it partnership and discussions around how to be successful together, or is it financial risk dumping and offloading? And to the extent you found ways to partner with private payers, what works?
I would say it started as a partnership. I do believe the One Big Beautiful Bill is going to add a layer of complexity here that nobody understands at this point. But the payer-provider relationships are becoming more and more tenuous. And it's moving away from partnership to offloading risk in a negative way, which is pushing providers away from considering risk, especially those that don't have the ability to back risk. Provider systems, physicians don't have risk-based capital to offset a loss of a material amount. We don't have risk-based capital to offset the pharmacy pricing strategy of most of the major insurers. So, there needs to be some parameters and guardrails around this, but I think we're going to face a period of time that's going to be very difficult with our health plan partners to reach a consensus on what's acceptable risk for a provider system versus what is acceptable risk from a payer perspective.
think if you take everything that Lisa said and you layer it into a rural environment, it gets even more complex. And that's part of the challenges that I think about every day. I would say where some of the most unique partnerships I currently have and that I'm developing are actually with employers as the payer. And so I think there's a lot of opportunity in the space for direct-to-employer relationships. And that is a commercial population where I think we can make real change.
Yeah, I would agree. We've been doing similar work in the direct-to-employer space, and I can throw out some numbers for you. 34% drop in premium, 22% on pharmacy spend, a 30% drop in emergency room visits. I truly believe the right answer, and someone mentioned it earlier this morning, is direct-to-consumer, and eliminating all of the middle people that are arbitraging off of every healthcare dollar in order for more dollars to be spent to put systems in place for preventative care and to put systems in place that reduce the cost to employers and to patients.
I'd like to maybe go down the line here, but maybe in your own words and briefly, one of the challenges we've seen in all payment models is the ability to lower the cost of care. What is the definition of bending the cost curve for your organization? How do you lower cost of care?
I think you have to start where most organizations start, which is how do you change care for the patients that are most complex, the most vulnerable patients, polypharmacy, chronic disease. That's typically where most organizations start. I think if you can start there and get real changes, and patient by patient, that varies drastically. I mean, I can think off the top of my head of two individuals, but one in particular who recently did a podcast with us, so he's told his story quite publicly, but struggling with multiple bouts of being unhoused, mostly living out of his car, substance use, constantly leaving the hospital when admitted against medical advice. When we pair that with in-depth care management for a long period of time, actually discovered the reason was really about taking care of his cats that were the most important part of his life. And that was why he was not able to really comply with a lot of the orders, and he was considered non-compliant. But once we figured out a foster situation for his cats, he was able to actually complete the care that he needed, was able to go into treatment, and actually has become much better and has told his whole story about it. Now, would we have had the time, the emergency room physicians that were treating him, the hospitalists that were taking care of him, would have never had the time to understand this. And I tell this story to basically say, if you're able to figure out how to bend the cost curve or reduce the amount of care that those most complex, vulnerable individuals need. Sometimes that is housing, it is food, it is not the things that you think about, it's not a prescription that's required. That will bend the cost curve. The investments needed to do that, one could argue, do those belong in the health system or do they belong somewhere else? I think that's a great discussion to have, probably not one we'll have today. And do health systems have the financial means to be able to invest in these when they don't have the fee-for-service widgets behind them? And I think that's one of the places that we've struggled.
Bending the cost curve, any other definitions? That's perfect.
Yeah, bending the cost curve. The bend is like this right now. But I think the biggest challenge and opportunity for us, to piggyback on what you said earlier, is data and knowing who exactly our patients are. And the variety of models that exist today is another challenge. It's hard as a practicing physician to go in and take care of patients that the rules are this way for Medicaid, the rules are this way for Medicare, there's variations depending on the health plan within each, and the rules are different for commercial, and the variations are different underneath all of those. You can't possibly manage that. We were talking about how complicated it is just to stay up on top of all the medical literature that's coming out, and you can't stay on top of the variations and the types of models. So I think there needs to be some coalescing of the models to normalize what the requirements are, normalize the payment parameters, normalize what risk means in those models, and then deploy the tools to get upstream to prevent some of the disasters that we see for care in order to truly bend the cost curve. Otherwise, we're really just shifting the money around to different parts of the system or between different plan structures.
Belinda, any thoughts from all your conversations with ACOs and provider groups?
Yeah, I would tell you from an ACO perspective in terms of bending the cost curve, it is partnership with the payers. Whether it's CMS, whether it's an MA plan, or whether it's a direct-to-employer. They have to have that partnership. And when the relationship is just transactional, you simply do not have the glue that it takes to make a major difference. You are at that point figuring out, how can I offload my cost onto you, or how can I, at the end of the year, you're surprised that I put something on your side of the ledger. So it is really important for us, if we truly want to change the cost curve, is for us to partner with our payer partners.
Great. I've got 2 more questions, and then if the audience has anything, and then we'll wrap. When you think about the broader construct of value-based care, lots of rules, lots of complexities, but if you reflect on your own organization and what you're great at doing, and thinking about applying that to the value-based care model for you, what is that greatness from your organization?
I think the greatness is our clinical teams. The coordination, the collaboration between our physicians, and it's not just primary care. I think the worst thing we could do is segment out physicians and patients by body parts, because we need all of you in order to be successful. And it's about the coordination between multiple specialties, the hospital system, as well as community-based organizations, and then our population health team that spends the time looking at all the transactional data and the issues that are occurring with the patient population or a particular patient to figure out what's the right strategy for that individual that has COPD and CHF and diabetes and is homeless. That is not an easy solution today to sort through. And I think they're magicians. I think that's our secret sauce, is the ability to be able to pull all of that together in an integrated fashion so that we're reducing the fragmentation that patients are experiencing.
One of the things that I find most unique about living in rural Vermont is the deep caring and compassion that every member of our clinical community and the larger healthcare delivery system has for each other and for their community, because essentially you're taking care of your neighbors and friends. The degrees of separation when you're in rural parts of the country are much smaller, and so it's not possible to go to the grocery store without seeing patients that you take care of. They are your kids' teachers, and that's true I think anywhere, but it's much more poignant when you're in rural parts of the country, and I think that's part of the greatness.
Great. Belinda, I don't want to leave you out of this one, and I'll have one more question, but what is the greatness of APG? How do providers and ACOs best use you to articulate and advocate for their mission?
Yeah. So I will tell you that I get regular calls on a daily basis from our participants that tell me what are the things that give them obstacles to be able to take care of the patients the best they can. Some of it is related to data, as we said, timely data. Some of it is related to outdated regulations. And this administration, Mike, is very open in terms of saying if there's regulations that are inhibiting us from taking care of patients, tell us. Dr. Oz says that all the time. Tell us what regulations need to go away. And so I think we have some exciting ahead of us in terms of being able to integrate AI and technology in a very different way in terms of care transformation. But it's going to take all of us in terms of identifying what we need to decrease in terms of regulations to make that happen.
Great. Okay, my last question, then I'll see if anyone has in the audience. So we're here on this panel, and let's say it's 2035, it's 10 years from today, and it's the state of affairs for value-based care in the United States. What are you describing the state of affairs of value-based care on that panel 10 years from now?
We've migrated to a population and community-based model. Healthcare is local, so managing it nationally is a challenge, which is part of the reason why you see the administration pushing dollars to the states in different ways, or reducing dollars or stripping dollars out, because they want to change the way things are funded. And you have to deliver healthcare locally. The issues are local. They vary by region. What Jess experiences in Vermont is different than what we experience in Connecticut and Massachusetts and Florida and any other segment of the country. So it has to be tailored to the community that is being served. And that's my hope, is that we get to that population community-based model.
In order to do that, I'm going to go back to my data. We no longer have challenges with accessing data, and we is the greater healthcare system. So whether that's a community agency, whether it's a primary care provider, whether it's an emergency department provider, everybody has what they need at their fingertips or in other ways to be able to make sure that they're making decisions based on the full capacity of data available for all individuals. That would be one of the goals I think we could accomplish.
Wonderful.
Yeah, I think in 2035, the care that we render to people will be very, very different than what we see now. But we're going to have to be willing to let go of the past. And as you said, a lot of what this administration has done has been a major disruptor for us. And many of us is like, oh my heavens, now we're not measuring social determinants of health, or we're not doing these assessments. What will we do? And we've got to sometimes let go of the past because it wasn't working. We were not making a difference. We were just collecting data to collect data. So I suspect that in 2035, care will be very, very different. We will be able to unleash technology, unleash AI. The care will be done in a much more seamless manner that is focused on the patient, their needs, and the communities that we serve. But we've got to be willing to let go of the past.
Wonderful. Any questions we can answer for you all? Okay, I'm going to do two so we can stay on schedule as best as possible. Dr. Dodamani.
Financial reconciliation in value-based models still takes a very long time.
Yes.
Doctors don't want to be insurance companies and have to wait to get paid. Is there a way, using all the digital innovation, to move the fee for outcomes and accelerate on how quickly that reconciliation can occur in terms of achieving good outcomes?
The question is around whether we can change reconciliation timelines to pair dollars with results versus making physicians wait a long time for the fruits of their labor.
And I will tell you, Sanjay, I think it depends on how quickly we can have the timely data. As you know, right now, we do a retrospective prospective benchmarking. They put benchmarking for this year based upon what has been almost 2 years in the arrears. And when we try to then move it forward, we still have a run out. So I think it's really, to answer your question, we need to be able to move up our timely data. And moving up the timely data will allow us to close the books much faster, have a run out that won't be 6 months of a run out.
Can I just add on to that? I think the ultimate answer is to get away from fee-for-service. As long as we have fee-for-service, even if the data was perfect, we're going to have this lag. And I think the answer is also different between the government-based programs versus non-governmental programs. There's an incentive on the government side to try to move in this direction to quicker reconciliations, midterm payments, things like that. But when you're talking about the private sector and our health payer partners, it's not in their best interest to do that reconciliation and pay it in a more timely way. They can't manage the data as it is, and it impacts their financials. And to the degree it impacts their financials, they'll look to delay it even further.
Thank you. Okay, last question. Sorry, but gentleman in the back. And yes.
Yeah.
Or just project and I'll repeat it for you.
You mentioned that you don't want technologists to come in and change the workflow, and EMRs are very much part of the workflow for a lot of physicians. So just talking about data, as a result of that, EMRs have become like the store for data.
So you can't really, like you're talking about somebody go to Florida, you can't get the data out. So should the patient own the data, or should it be the EMR who owns the data? And what do you think about that?
I think it's a great question. And I want to just sort of characterize a little bit. I don't know that I was saying that the workflow shouldn't change. What I was really saying is if it exists outside the workflow, then it doesn't work. And so there may be technology that actually helps as an innovation to change the workflow. I think if the data only stays in the EMR, then the answer is it's limited, right? Because unless we go to some universal single EMR, which I don't see that happening, then if the data only stays there, then that's the limiting factor. What I haven't seen done well is interoperability to any real degree. There's bits and pieces of it, and so I think if the patient owned the data or the EMR owns the data, there has to be interoperability for how that occurs. So if we give the data to the patients, they have to be able to then make that data available real time wherever it is that they're receiving care, and the same would be true for the EMR. So for me, it's about the interoperability, not necessarily who owns it.
Okay, I want to thank our panelists for the work you do, and I want to thank you for traveling to come be with us today. Thanks, everybody. Thank you.
Hello. Thank you, Dr. Kopko. Thank you, Ms. Lisa Trumbull, Jessica Moschella, and Ms. Rutledge. I'm sorry that Nidhi and Nikki can't be here right now. They have their own panel downstairs, so I'm just going to take over for the next 5 minutes. So we'd like to then move on to our next panel, Ethical Use of AI in Healthcare. For this panel, I would like to invite Dr. Shiva Kaul. I think he was downstairs. Oh, there he is. Perfect. Awesome. Dr. Avi Mehra, Dr. Anshuman Mishra, and Dr. Sandeep Bajaj. As a reminder, and Dr. Shyam Vishweshwaran, please. As a reminder, we have another session running downstairs as well on the 18th floor in the Trumbull Ballroom. We are talking about being your best self over there, sleep and mental peak performance. Please, sir, if you could please take the dais. Mr. Kaul, all yours.
All right, is that working?
You can choose, you want this or that.
1, 2. I'll do this. This is fine. Do we need more chair? Well, we need 4, right?
Let me get it. You guys want me on this panel? Yes. Okay. Dr. Molly. Oh, okay. That's fine. Okay. 1, 2, 3, 4. We have that.
No, he's my old friend.
You get to run this thing now.
I guess so. All right.
Perfect. There you go. Sorry about that.
Okay. Oh, Shyam, you're. Oh,
Yeah, it turns out that.
I'm in.
Include everybody. Sure, yeah, of course.
I'm not sure. Let's see. Usually 30 minutes. All right. Well, this is a 30-minute panel on an important topic, and we have 5 great panelists here, so let's get started. Let's start our discussion on ethical use of AI, something you've probably all thought about pretty recently. So the first question I'm going to ask the panelists is to just briefly introduce themselves and how their work exposes them to aspects of ethical AI use in healthcare. Shyam?
Sure. So my name is Shyam Vishweshwaran. I'm a professor of biomedical informatics and the chair of the Department of Biomedical Informatics at the University of Pittsburgh. We sit in the School of Medicine as now we do AI, basically. So I have a clinical background as a neurologist and then did a PhD in AI. And I deal with a lot of clinical decision support and AI-based clinical decision support at this point.
Hi, my name is Sandeep Bajaj. I was most fascinated by the last panel. I don't know what you thought about it, but they touched a lot of points on how healthcare delivery is. I guess AI interfaces with all those issues. And just like in medicine, it has to be ethical across the board. So AI just follows the same doctrine of the practice of medicine.
Great. My name is Anshuman Mishra. I'm from the business development team at eClinicalWorks, healthcare technology company. I've, by education, I am a computer science engineer, but over the past 20 plus years, I've been in the healthcare industry deploying different technology solutions, working with a lot of enterprise healthcare organizations, understanding their needs, aligning our goals, and figuring out what are the gaps that we can associate and work as a partner of technology partner of choice. And AI, clearly in the past 2-3 years, have been the focal point across most of the organizations. So clearly that's something that I love to share my experience with you all.
Hello, good afternoon. My name's Avi Mehra. I'm a physician by background based in London. I'm currently an associate partner in IBM's Global Healthcare and Life Sciences practice, and also IBM's Clinical Safety Officer. A lot of my work over the last decade has been around this sort of responsible application of AI in healthcare, both on the clinical side, thinking about designing and implementing clinical decision support systems, but also on the non-clinical administrative side as well. So a big focus on sort of how we lead with sort of ethics and safety by design. As a digital transformation partner to health systems, providers, and payers, we really put ethics and safety at the core of everything we do. We have a very strong ethical framework, an AI ethics board, which really oversees our work internally, but also sets the framework for our work with clients. But also importantly, I do spend a lot of time trying to really change the sort of narrative and flip the conversation. A lot of the times I have conversations around safety and ethics within a healthcare setting. I often find there's this misconception that safety and ethics is holding back innovation, and actually they sit on opposite sides. And actually I don't believe that's true, and I think those who lead with it properly and do it well, safety and ethics can really be a catalyst for innovation, particularly when we're talking about healthcare applications. And so a lot of my time is spent sort of trying to clarify that misconception, turn it into sort of practical application. It can be very abstract at times. How do we make it practical? What are the toolkits that we can put in place to do it? But also, not only is it just the right thing to do, but also show how it also from a commercial perspective, it makes business sense to invest in ethics and safety from the outset. So really looking forward to the conversation.
Thank you. I'm Rachel Azafrani. I'm an AI ethicist. I'm with Microsoft's Office of Responsible AI. I work on governance programs for many different layers of the AI technology stack, all the way from models through to very cutting edge non-production research, for example, novel applications of AI in radiology. And so I work on governance at many layers and thinking about guardrails, not only from the responsibility of a technology provider, but how can we empower users of the technology to deploy the technology responsibly in healthcare and other industries too. Thank you.
Thank you. And finally, I'm Shiva Kaul. I'm an AI researcher at the Department of Population Medicine at Harvard Medical School and Harvard Pilgrim Healthcare Institute. So my plan for today is let's just dive in. Let's look at some actual concrete applications of AI in healthcare that people are using today and think about them from different ethical perspectives. So first, physicians in the room, and make sure you raise your hands because I want this to be, a valid survey here. How many of you used open evidence in the past week? And again, I want validity here, so raise your hands if you did. All right, well, open evidence says, right, that around 40% of physicians use their product to help treat their patients, and that about 100 million Americans go to doctors who use open evidence as part of their protocol. So let's talk about and comment on the ethical dimensions of clinician use of LLMs. Sean?
Yeah, so I think a good place to start, because this will really resonate with both researchers and clinicians, is to just go back to what are ethical principles. So if you're doing research, for example, you've probably gone through these things called CT modules, which basically point out to the three ethical principles that physician researchers follow, as well as clinicians in treating patients follow. So the first one is the respect for autonomy. So the idea basically here is you really take patient consent, you inform them appropriately, whether it's a research study or a clinical intervention, and if they turn it down, they turn it down. So they make an informed decision about their own participation in research as well as in clinical care. The second one is to basically do good and don't do harm. And that is fundamental of clinical practice, but it's also true for research. And this has come from past historical examples like the Tuskegee experiment, where certain people were given syphilis without their knowledge, for example. And finally, there is the principle of justice. And what that means is that physicians who treat patients and researchers who are enrolling people into studies have to do this equitably, so that the entire population is represented to the extent possible, so that we can learn from the entire population and not just from one population. So to me, these three principles, autonomy, do good and don't do evil, and justice, automatically follow to AI. So use of AI, whether for research purposes or whether for clinical purposes, you have to follow these three basic principles.
Sounds great. And how about we just randomize the order, just because that's more interesting to everybody. Flip a coin.
All right. Talking about ethical use of LLMs in healthcare. So where to start with this question? We have so many incredible tools available to us, publicly available, that we can use. And we have to recognize that many of these tools, in the form that they're presented to the public, they're general purpose tools. And so we have to be able to delineate and separate tools that have not been developed for a specific purpose, and then tools that have. In particular, we have to understand, when we are thinking about a variety of use cases in healthcare, there are so many different parameters and standards that we need our tools to meet. We need our tools to meet privacy standards. We need our tools to meet certain standards of rigor and accuracy. And so when thinking about use of LLMs in healthcare, broadly speaking, it's very important to understand the intended use of the technology and fit for purpose of the technology, and finding the right tool for the job. There are many different, very purposeful applications of LLMs in healthcare, but as in and of themselves, LLMs have many different behaviors that it's very necessary to guard in a certain way, so we get that level of rigor and accuracy. And so from the technology provider perspective, we are very clear about the operating parameters that these technologies operate in when we make healthcare applications. But on the other side too, when you're thinking about what tools that you need for the job, understanding the right questions to ask and where to find that information is also very critical. And so there's both, on the one hand, understanding that there are many, many different applications of LLMs. Many are general purpose and not all right tools for the job. They can be very pivotal for healthcare, and we can, at the same time, provide information to make sure that they're selected and used appropriately. So I'll wrap with that.
Right. Go ahead.
You mentioned open evidence, right? Maybe another question for the audience, I guess, is for the physicians, again, or clinicians, how many of you use ChatGPT in your, we're not going to put anything online, but how many of you use ChatGPT to support your decision-making? Honestly. So very interesting, right? And look, both of those tools, open evidence as well, open evidence is for information and educational purposes only. It is not a medical device. ChatGPT is obviously not a medical device. Yet, same in the NHS today, we've done surveys and a huge percentage of clinicians, physicians are using tools, including ChatGPT, to support decision-making. Now that brings lots of ethical implications. We know the power of them. We know they can be incredibly good, incredibly powerful, and give amazing insights. But safety absolutely brings up a big concern. Number one is, yes, 9 times out of 10, it may give you a very, very strong, confident answer, but that one time that it's wrong, and the clinician doesn't double-check or builds enough confidence in the tool to feel as though they shouldn't check another source, who's accountable? Well, of course, the clinician, right, in this case. But the more clinicians rely on these tools, the more complex it gets. I think one thing I want to mention in this clinical category as well is when you start veering into diagnostics and AI-powered diagnostics as well. So not just decision support, but using AI to support diagnostics. We've had a lot in the morning already and conversations around human in the loop. And I personally agree that's absolutely critical. The reality is, though, the technology is advancing very quickly. I'll give you one example. In the UK, we have a company called Skin Analytics. They've achieved a world first, what I believe is a world first, in a Class 3 medical device, certified, approved by NICE and the UK MHRA for autonomous use of detection of skin cancer. Autonomous without the need for a physician to check. So it's coming, it's there. We need to have an open conversation about how comfortable are we with using a tool like that autonomously to exclude patients who've got suspected skin cancer. So that's just one dimension. I'm sure the panel have got others, but I think when we're in this clinical domain, we need to think really hard because at the end of the day, this is directly impacting patient care, right? Decision-making, diagnostics, and we know we've heard from the morning around the tremendous power, but also the risks that these new applications bring.
Thank you. I liked that emphasis especially on the clinician burden there. Now, before Anshuman and Sanjay answer, I'm going to switch up the question a little bit from clinician use to patient use. Here's an interesting patient use of LLMs. This past week, OpenAI said that about 1 million people every week talk to ChatGPT about suicide. All right, so, and I think, mental therapy chatbots are a whole category with a lot of ethical issues that arise, right? So I guess the question, this is another use of LLMs fundamentally, right? But I guess what I'm trying to think about here is how do those aspects get aggravated and how do they change when the user isn't the clinician, it's directly the patient, whether it's mental health or not?
So I think when you think about technology, and I don't want to just focus on AI, I know that focus is that for the session, but in general, any technology, whether the provider is using it or patient is using it, there are a lot of things and the aspects definitely change, right? Especially the ethics behind it. Especially for providers, when we are talking about providers using, let's say, public AI tools like ChatGPT and others, there is a concern with PHI, especially because we are working in a space with healthcare where PHI is something that we all have to abide by, right? So with that in mind, clearly, I would caution anybody who's using any kind of public AI tools. So I think when leveraging any AI technologies, I think one thing is definitely the use case. I think both the panelists here spoke about that as well. And making sure that you choose the right partner of choice. Now, the same thing goes on the flip side, on the patient side, where patients are utilizing the AI tools, especially in the public domain, that has to be, again, used with caution. So I think it might be, at this point, with regulations coming into place, again, that's definitely, I think the previous panel also spoke about it. There is a lot of lag in that regulation and a lot of things that AI is doing, which needs to have better controls in place. But till that happens, I think education is key. And I think a lot of that onus at this point would be on the healthcare providers and technology providers as well.
I think this is an evolutionary platform, and as this information is available and patients can access information from ChatGPT and others that they didn't have before, and the answers they're getting are pretty accurate. So this is just an evolutionary thing that there'll be more improved patient education. Hopefully that'll result in better care for themselves and will help the physician community to lower the burden of care. And maybe at some point there can be some interface and some regulatory changes that all burden is not just given to the physician. So maybe it's a positive thing that this thing is evolving. We're raising the standards. The physicians are not carrying the burden of everything. There may be some regulatory changes that they can make, and there's a mutual exchange of how to live better. And this is just improved patient education. So there's a positive side to it besides the liability part.
Okay, yeah, interesting. Well, do you want to comment on patient?
Sure. Yeah, so I think out of the three principles sort of I listed, LLMs fail miserably on justice. And the reason is because the LLMs are trained on just any stuff which is available on the internet. So we have done experiments, for example, where we take an LLM, give it a patient synopsis, and tell us what should be the next step you do for the patient, or whether this patient is eligible for a particular study. We just flip the race around, and it gives a different answer 30% of the time. And we know that that's because of all the biases which are embedded in the data that the LLM has seen. So you can imagine that when a patient uses this, well, even when physicians use this, they probably don't really have a very good understanding of how reliable these models are. And these are particularly vulnerable to all the fairness issues that healthcare access has had in the country, because these LLMs are basically learning all the practices of care which has gone on in the country for the past 20, 30 years. And anything which is unfair in those practices, like access to healthcare, the LLMs will faithfully reproduce this. And so they kind of fail, I would say, at least on that principle, pretty badly.
Yeah, no, that's a good point. So yeah, so we just talked about diagnosing and treating patients with LLMs, which is obviously a extremely contentious topic ethically. But that's not necessarily the most popular use of AI in healthcare. How many of you have used an ambient scribe before in your practice? Well, it's becoming a thing. I mean, for example, one of these companies, Abridge, has raised $700 million for their ambient scribe. And so that's just one company, right? So there are a lot of users of this now. And the thing about ambient scribing, just so everyone's familiar, it's where when you're discussing things with your patient, the ambient scribe sits in the background, records the conversation, and then produces your summarized clinical note so that you don't have to spend all of that time doing it in pajama hours. Now, it's kind of interesting because to me, that sounds a lot less controversial. Is there an ethical issue with that? I guess you're recording a patient. There's something there. But can any of you think of as a clinician, you might see technologies and say, oh, there's no ethical issue there. But maybe the panelists can surface some ideas about potential issues. Yeah, Rachel?
Sure, happy to talk about this a bit. So when we think about transcription kinds of technology, there are a number of different ways that we think about building responsible guardrails so that this technology is performant. One is actually on the fairness dimension. Does this technology actually perform for a variety of different kinds of voices, different accents, different languages? That's one side of the actual accuracy component of the technology. Is it actually going to perform, for example, when people use shorthand or slang? If people are using natural conversation and we're relying on very high fidelity reports, we have to go through a certain set of deliberate fairness development and training to collect enough data so that these technologies are performant globally or in the context of the communities that they're going to be used. Another thing is actually the lexicon of medical terminology, which out of the box sometimes transcription technologies may not necessarily even be specialized enough to recognize some of the technical and scientific and medical terminology. So there is both an accuracy from a fairness standpoint. We want this to be performant for different languages. We also want it to be performant for different terminology. So those are some considerations from the technology provider side that maybe as you're looking at procuring some of these technologies, actually thinking about asking some of those questions and looking at how these technologies were evaluated for the use case. On the other side too, when we actually think about the production of these reports, we have to understand that sometimes, and depending on the underlying architecture and structure of the technology, what is it doing? If it's a large language model, it may be taking context from the conversation, and we have to recognize where the output can be sourced from within a transcript. To what extent is the model inferring, for example, something that was or was not said? Is that a desired behavior or not? Do we want the report to draw a conclusion that actually was not verbalized in the conversation, or do we want it to be a strict transcription of the conversation? So thinking about on the reporting side too, it also matters what task the AI is performing to transcribe, or is there actually an inference of an outcome? So these are a couple considerations when thinking about looking at software, evaluating software for a particular use case, not only understanding from how it was evaluated, but also the intended task, especially for reporting, is very important.
Great. Right. Any other potential issues with ambient scribing? Because we got more use cases to go through.
Definitely some more issues.
Yeah.
Go ahead.
I do have a couple of them that I just want to highlight, right? I think when we talk about ambient scribe in the space of healthcare, again, in the past 2 years, we are seeing thousands of different kind of technology partner solutions coming out in the industry and from around the globe, right? Many of them don't have the experience of healthcare. Now, one thing that I would always warn any provider using ambient technology is there are vendors out there that are offering the ambient scribe at no cost, literally $0, right? And the question always is why or how? Right? How is that even possible, right? How are they willing to survive? So now the question is, what is being done with the data that you are documenting, the clinical data that you're documenting, and even if it's de-identified, I don't know. Those are the kind of questions in terms of ethics you should really think about. I think we spoke about patient consent because, again, certain states do require two-sided consent. I think New York is a single side, one side is fine, but I think those are areas that you should definitely think about. And when we talk about technology accuracy, again, Rachel touched upon, I'm not going to talk about that. But another piece of it is when we are talking about diagnosis, when you're talking about medications, treatment plans, right? What is the clinical relevance of that with that patient, right? So again, I don't know about all the ambient technology solutions, but with eClinicalWorks, we have the Suno AI. Again, a fun fact, Suno is a Sanskrit word for listen. With Suno AI, we are able to access the entire patient clinical record. So it kind of has a clinical relevance, which is the guardrails that, again, Rachel was talking about, so that it knows, if I'm talking about hypertension, it exactly knows which ICD-10 code we are talking about. And if I'm talking about increasing a medication by 5 mg, again, just using the keywords, the system already knows exactly what it is, and then the provider is in the driving seat. So all of our AI solutions that we build with eClinicalWorks are working in a co-pilot mode, because we are talking about very sensitive data. We are talking about clinical information, and at this point, we do feel it should be assisting the providers and everybody within the healthcare organization, so it's not doing things in the autonomous fashion.
And just to build on that, I mean, within the NHS context where I'm based in the UK, it's without doubt, obviously, ambient voice technology is the hottest area, no question. But it's interesting, about 3 months ago, there was a national directive by the National Chief Clinical Information Officer to slow down the use of AVT within the NHS because of how fast it was moving, and also because of the point you mentioned around some providers' sort of quality metrics not being up to scratch. And this was unprecedented to have this sort of national directive come out. It came out in a single letter, and basically what it stated that was, firstly, within the UK context, all AI scribes within that context would be a minimum of a class 1 medical device, minimum. So immediately, every single AI scribe, if you want to be implemented in the NHS, you have to be a minimum of a class 1A medical device. Most of them likely class 2 and above. Second, to build on the points that have already been made around safety, the hallucination rate and omission rate, yes, they're incredibly powerful, we know, saving a huge amount of time for clinicians, but also there needs to be that education so clinicians understand how these tools hallucinate, how they may omit stuff, and the risk then, even if you are double checking it, that you still may miss something as a clinician, even with a clinician in the loop. So yes, incredible potential, moving at an incredible pace, but to all the points you mentioned, the regulators didn't have the answer either. So this is an interesting point where the regulators are also saying, we're trying to figure this out with you, we're moving at pace, and they've just set up also in the UK now a new national commission on the regulation of AI in healthcare, and their top priority is absolutely ambient scribes. So moving fast, but the guardrails are not all there, and that's why we need to have that caution.
Yeah, so I'll ask you something new, which is right on the tails of moving fast, right? So you may have seen a New York Times article last year about battle of the bots in claims. On one side, we have insurance companies using AI to handle prior auth. On the other side, we have doctors generating appeals letters and processing denials with AI. Here's the thing, does that sort of cancel out the ethics issues? Or like, how do we analyze that when it's AI versus AI, right? That seems a little bit trickier than AI doing something to a human. Like, that's kind of like a techno future question, but.
Well, that just goes to the ethics of medicine today. So it's got, we talk about AI ethics, how about the healthcare today? I mean, we had a discussion before with this panel that this pig with a lipstick, it's a broken healthcare delivery platform. On top of that, you're forcing value-based care when the chassis itself does not support it. The population is increasing in age. We have only 3 places to do healthcare delivery: a doctor's office, an emergency room, which generally sends you to the hospital, or the hospital. We don't have any other concept of delivery of care, like an intermediate care center, et cetera. So first of all, that is broken. And now the insurance companies, the way they work is they deny your claim. And so I went to the Oracle conference, and the conference was amazing. It was all AI-based. Oracle is very big in it. But that was exactly that. They had problems from both sides. They had a clean claim being sent, and to have an appeal process they had put together to get the money back. At the same time, they had a denial process for the hospital system. And they were selling both solutions depending on what you bought. So I think there are more problems than just ethical AI. I think to your point, it's the denial of care is probably the biggest issue today in healthcare, the way I see it. I have a cardiology practice. United Healthcare denied. I was the first ACO for United Healthcare in the state of Florida. I was the keynote speaker at their national ACO conference, and they denied $200,000 of claims from my one-year procedures. So, I mean, this is the state of medicine today.
Yeah, so I think the key thing to remember is that when humans are making decisions, you make a wrong decision, you affect one decision, one person. When AI is doing this, it just scales up bad decisions at a very fast pace. So you can have claims denial running through AI, processing it in milliseconds and dumping it back. And my guess is the other side will start using AI to dump it back. And we might end up going in this really catch-22 situation. You're just circling around the AI talking to AI. And at the end of the day, it becomes really moot as to what's going to happen, because someone has to break this loop. And unless the two sides sort of come together and decide what is ethical, the AI is not an ethical, say, a person, really. It's all programmed in. So if we program in the wrong ethical principles, this is the alignment problem in AI, then it's going to just do this at scale. And that could have problems which are very different from human beings doing one at a time.
So I'm going to repeat that question. I'm asking not just the panel, but the audience too, right? Who decides that? Who ultimately decides what constitutes, quote, ethical use of AI in healthcare? You know, what guidelines or benchmarks or principles, right, ultimately like hold sway? And what would you choose? Or what would you not choose? So I'm asking this question not just to the panelists, but if anyone else has any comments on that, would love to hear it.
Slightly different question. With the use of AI and with the use of personalized medicine, because we had a panel on that as well, when is the greater good bigger than the personal good? Because that's what we're coming down to effectively.
I'm going to start with your question first, and then with maybe an easier one in some ways. I mean, look, there isn't a single organization that is going to be responsible for determining that. I think we can all agree. The regulators absolutely have a role to play, and I mentioned some of the work being done in the UK around that, this new national commission. But we recognize technology companies, including ourselves at IBM, we have a role to play in terms of how we set up frameworks. But there are consortiums as well that are working hard at this. One to mention that may be worth checking out is the Future AI Consortium, was set up about 4 years ago, approximately 117 individuals from across 50 countries, and they've set out sort of 30 best practices in a very practical way, again, exactly around this question of how do you practically implement sort of responsible and ethical AI in healthcare? What are best practices? How can we do it together? And they're working on it. That's just one example. I'm sure there are others. I think we've got a question in the audience first.
Question in the audience.
My name is Dr. Deepak Nandi. I've been in the healthcare business for the last 45 years. Healthcare in the United States is a commercial game where everybody wants to have the Rolls Royce. Everybody wants to drive, not even Mercedes, they want to drive Rolls Royce. They want the best treatment, no matter whether you were taking SNAP food last night. So it has become a cat and mouse game. Having run clinics after clinics, you submit the bill, the insurance company is in the business of denying the bills, but because they have a 5% margin. If we have they have to run within 5%, otherwise they have to raise their premium. So because of this cat and mouse game, you can talk about ethics, you can talk about AI-driven PA, AI-driven RCM, then AI-driven EOBs and payment systems. This will continue to be a cat and mouse game until we realize that this is the game that we have been playing. And nobody is in the business, unlike booking an airline ticket, where they want a good handshake. This AI ethics will have very minimal role because the end goal is how to be outsmarting the other party, the payer versus the provider. And that is the bottom line truth. That is my interpretation of the whole thing.
More of a statement than a question, but that's okay.
One more question.
Question? Oh, sorry.
Hi, my name is Dr. Bandio. I have a statement and a question. So for Dr. Mehra and Dr. Bajaj, both of you went through medical training where I think you were confronted with the question that affects every doctor. When do the benefits of what I give as a treatment, as a diagnosis, when do the benefits outweigh the risks? And you spent many, 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 many hours, I don't think I can emphasize enough manys, learning how to judge exactly that. So when you ask the question about AI, when do the benefits of AI outweigh the risks for the patients? When you learned from your mentors, the people who came before you, in understanding the practice of your art, who is there now to teach the physicians of the modern age how to practice this art? Are they trained in AI? Do they understand the implications and the process by which these models are developed? I guess that's what I would say is the fundamental question. If you ask who is to determine the ethical use of AI, is it much like saying 100 years ago, who is to determine the ethical use of surgery? Is it not the surgeon who was trained and to understand it? So perhaps the problem is not AI. Perhaps the problem is the way we were trained and how we are trained. I would like to hear what the panel thinks. That's my question.
I guess the interesting question that raises, right, is you need to think about, obviously AI is being applied in a lot of different places. So we have to turn inwards and say, what's really special about healthcare and medicine, right? That makes us the moral arbiters of our domain, as opposed to, and it may be the case that we can learn a lot from folks who are applying AI in other domains as well. So, yeah.
So let me answer that. So first of all, beautifully asked question, very well thought of, and those are really important questions. So besides, just like everything in medicine, besides the accountability, no malfeasance, better care, more intelligent care and access to patients, access to care, etc. The single most important thing in AI is accountability. So who is accountable for that AI? Because the accountability is a local phenomena. So whatever your organization is, whether it's a hospital, an ACO, an MSO, a payer, it is deploying AI for its own function, for a certain function within its own ecosystem. And that person has to be accountable for that function. I also think that at today's, we are not making clinical decisions with AI. That has not come yet with the physicians. We are not told, use an AI for diagnosis of pneumonia or this or differential diagnosis. It's still in the hands of the physicians. So we are using it for cursory activity like scribing or appointments or etc. and improving those functions. So I think we should allow that to happen and evolve, because that will reduce the burden of cost of care, and may make the process more expeditious. But from a clinical perspective, it's still in our hands, and I don't think physicians should ever give that up. I don't think the AI should ever replace the human brain, because they cannot be taught all the years of experience and hard work, like you said we did, to get where we are.
Yeah, so I can make a comment on this. So I give a lecture to MS1 medical students in year one at the University of Pittsburgh on AI. And one of the questions which comes up is exactly this. Now, who is supposed to be in charge of using the AI? And most of the times, the medical students come up and say, well, we don't understand this thing. So how can we be the arbiters of actually deciding policies and using this AI? And my response is, if you don't do it, someone else will shove it down your throat. And at the end of the day, you are responsible for the care that you're given. And you don't have to know how a deep neural network works to be able to decide how to use AI ethically. So you can take an example like MRI, right? Which physician understands spin particle physics? You don't need to understand spin particle physics to use MRI ethically for the right clinical care, to be able to interpret the results and to share those results with patients and peers. So AI can be looked at, in some ways, it's yet another tool where at the end of the day, it has to be physicians in charge so that they are the ones sitting, participating at the table when policies are being made, whether at the country level, whether at the FDA level, whether at the hospital level, in terms of who is going to be responsible to use this ethically.
All right. And let's hear one of the non-clinicians give maybe not a counter argument, but maybe just another perspective, and that'll end the panel for today.
Maybe I'll say that there's a lot of opportunity for AI in healthcare. I think I'm incredibly optimistic about it. Not only from a research perspective, I'm incredibly optimistic about the availability of information. to people who may not have access to high quality healthcare around the world. I recently worked on a project in it's based in a couple projects, one based in Malawi, one based in India, working on connecting WhatsApp to LLMs, people who may not have access to high quality healthcare or even legal advice, getting access to information that they may not have had before. And so I do think that there is tremendous opportunity. There's also tremendous responsibility alongside this. Human accountability does not go away. There is an imperative that we define very well shared responsibility between technology providers to furnish information needed by clinicians and practitioners to apply these technologies responsibly, understand their limitations, understand where they should and should not be used, and then ultimately, at the end of the day, we will have regulatory guardrails, as has been stated, around when decisions can be taken by humans or systems. And in the end, responsibility does stop with humans. And so we look at these tools, we must understand their limitations. I think there's still great opportunity at the same time to apply these tools to democratize information.
I would just like to add just a few things as well. When we talk about AI in healthcare space, I think, yes, we need to have regulations. We need to have like the ONC and the other bodies, whether on the state or the federal level, providing guidelines for the development as well as use of AI in healthcare and technology. But in addition to that, it's also on the healthcare systems, right? The health systems, the healthcare organizations that are using and deploying solutions, right? So one thing I always tell any organization I work with is, before talking or reviewing any AI solutions, the question is, what are your challenges? What are you trying to address? What is the direction you want to go towards? Then identify what are the building blocks of AI tools that can fit into that to help you get you in that direction, right? And of course, every healthcare organization has slightly different ethics, internal ethics and internal processes, and I think that's something you should not discount. You can't supersede that just because AI said I can do it, or AI tools are available that lets me do it. I think those are some controls, some limits that has to be set in place on an individual organizational level, but there should be checks and balances on the state as well as federal levels.
All right, that was a great discussion. Let's thank the panels for it.
Excellent. Wonderful. Big round of applause again. What an excellent discussion we've had over there for our moderator, Mr. Shiva Kaul, Rachel Azrafrani, Avi Mehra, Anshuman Mishra, and Dr. Sandeep Bajaj, and of course, Dr. Vishweshwaran. And that actually provides us a perfect segue into our next conversation, which Dr. Bandyopadhyay so beautifully brought up. Education, training, and workforce development for the future of global medicine. Please welcome me, join me in welcoming our future-proof faculty, Dr. Lisa Weishman, Columbia surgeon turning residents into rock stars, Dr. David Berger, Dr. Larry Kaiser, and Dr. Marshall Runge to our panel. This next session, once again, is education, training, and workforce development for the future of global medicine and AI. Is Dr. Zaid also here? Oh, perfect. I would also like to add Dr. Zaid Ibrahim to this. I do apologize.
I guess you all stayed for the best panel in the day. My name is Lisa Wiekman. I am a human. I was born and raised in Italy. I'm a blues singer. I have 3 kids. I'm a wife. I'm a physician. I'm a surgeon. And I'm an educator. And it is my privilege to be here with the panel of luminaries and leaders who you see sitting next to me. And one thing we ask is that if at the end of this long day you're not interested in hearing what we have to say, just step outside the curtains, but afford the panel the etiquette of being polite and listening to what we have to say. So please, if you're not interested, just go. It's fine. So I think we all know that by 2035, the AMA has predicted us to have a shortage of about 86,000 doctors. That's probably an underestimation, especially with the current turn of events from a political standpoint, and that number is paralleled by an equal deficit in nurses, healthcare providers in general, and now researchers as well. That's true for the United States. It's true for my home country, Italy, that is leading the deficit in Europe. And it's due to many factors that we don't need to repeat right here. But this is not only a challenge, it's an opportunity. Because at a time when the job market is being taken over by machines, and we know that Amazon just laid off 14,000 people last week, we have the privilege of being able to transition and to reform education in healthcare for what is the most human of missions, caring for the human race and for life in general. So how do we raise our army and address this shortage? How do we inspire, support, and sustain the generation of healthcare professionals who will be taking care of all of us? We are going to need doctors, and we know how hard it is to pick up the phone and get an appointment, even if we are well connected. So to answer that question, I have the most outstanding group of giants who stand and sit near me and who've been introduced before, so for the sake of time and because it's been a long day, we will not repeat that. But I will start with Dr. Runge. Did I say that right? Who, while leading the University of Michigan Medical School, implemented transformative change and positioned Mission Medicine and Medical School internationally. In a brief conversation that we had leading up to this panel, he shared that his personal view is that we have not adapted medical education to stay up and keep up with the times, and that what we're doing is just pushing the finish line further and further. And this leads to not only the rising costs that Dr. Chowdhury mentioned, $600,000 in debt by the end of an American medical education, but also leads to burnout because of the length it takes for us American citizens to get to that finish line, 31 to 35 years of age. So the question for Dr. Runge is, what is broken in healthcare education? And we don't have a lot of time, so you're going to have to bullet it.
Okay, I'll hit the high points, and thank you, Lisa, for that great summary, because I think that we're at an inflection point where we really need to think hard about how do we best educate physicians and other healthcare providers. How can we use today's tools? We just heard a lot about AI and education, but there are other tools that can be used. And how do we do that in a manner in which we keep in mind that we need to make it much easier for, and I don't mean grade-wise, I mean much easier to enter medicine, whether as a physician or other healthcare provider. And so these barriers of length of education, the cost of education, are all daunting, I think, for people who are thinking about careers in healthcare. And I feel like we're stuck in a transformational change that was made in about 100 years ago called the Flexner model of education. Now, that was a great thing at the time, but now we're in a different world, we're at a different time. We're very concerned about the size of medical school classes. Maybe we ought to rethink that as well. Michael Crow, who's president of Arizona State University, would like to start a 1,000 student medical school class. So I think it's time to think broadly, and I think leaders like those of you in the room can help us try to figure out what the best approach is, and then how can we do that. And I know one of my colleagues at least will talk about how can we standardize that a bit so that we're providing the best education and a consistent education.
And just full disclosure, I graduated with zero debt from the University of Florence, and I think that is one of the things we have to start thinking about here in the United States is we cannot afford this medical education, but we do need doctors, so we have to think outside the American box, and this is why this global forum is so important. Dr. Kaiser, what are your thoughts in terms of what is broken with healthcare education, and what would be your first point in terms of tackling a solution?
Well, I think you have mentioned already the issue of debt. I recently saw the list of the schools with the highest amount of debt of their graduates. The number one on the list was Tulane, where I went to medical school, and I sent Lee Ham a note, the dean, and said, this is not I'd like for you to be at the top of things, but being number one in medical school debt is probably not where you want to be. The cost, no question about it, is a significant barrier, I think. I think one of the things is we want to maintain the quality. And expanding class size, and especially at some of these schools where tuition is the major revenue source, you start compromising on quality. How many students, and again, the preclinical piece, problem-based learning, I think we've done a great job with that. Students can watch the lecture at home. We don't sit in classrooms, in one lecture hall anymore for the entire year. So problem-based learning, I think, has done well. I think it's the clinical education where how many students, if you've got 15 students on a surgery rotation, that's probably not optimal in terms of education. I think the other is we are at the point now where the number of residency slots that we have in this country, the number of graduates and the number of spots now are intersecting. And we have not done anything. The residency levels now are capped at 1996 levels because of the 1997 Balanced Budget Act. Yes, most of us are all above the cap, but I think that's really going to be a problem as well. What are you doing in postgraduate education? It's one thing to finish medical school, but now what about postgraduate medical education? And I think that may be one of the barriers.
And that also ties into the other comment Dr. Chowdhury made, which is we don't start earning real money to pay back our loans until much, much later than many of the other professions on that slideshow, including nurses who come out at $120,000, almost the same amount a pediatrician makes, but a lot sooner. So debt and also compensation for training, I think, are both things that need to be discussed. Dr. Ibrahim, I knew that you have a particular interest in multiple things, but my passion project and thought is education and addressing the issue of disparities in healthcare, which starts with the disparities in healthcare providers and lands into disparities in healthcare recipients. I think Hofstra and Northwell have done an exceptional job in modernizing the medical school curriculum and have addressed some of both the issues of disparities, but also hands-on training that we think is required to update the curriculum. Could you comment on those?
Yeah, no, that's really a great question, Lisa. Thank you for asking that. So there are really two sides to the question. One is because we live now in a multicultural and a very sort of diverse communities, and we have to deliver care to the very diverse communities, the best way to do it is to actually have a diverse workforce in healthcare. There's no question about that. So the question becomes, how do we diversify the healthcare workforce? And I'll say a few things about that. I think the other side of the question is, are there really innovative ways that we could educate the future generation of healthcare providers? And what are some of the examples of that? So with respect to the first one, I've actually spent almost 30 years as an NIH-funded investigator studying sort of equity and who has access to surgery and who doesn't, and what are the social factors and other factors that shape that. And what I've realized is that the specialty that I focused on was on orthopedics, which is the least diverse specialty in medicine. But you know, of course, I couldn't do any studies where I could sort of randomize the physicians. They were all of the same kind. But one of the things we have learned is that yes, insurance matters, and a lot of the studies that I have done were done actually at the VA, which is the closest that the United States has to an equal access to healthcare system. Because if you are a veteran and you are getting care at the VA, you have access to all of what the VA, and yet disparities exist at the VA in access to care, and sometimes in outcomes as well. So the challenge is really, you know, one of the ways, not the only way, one of the ways that we could actually provide more equitable care is to diversify our workforce. I think medical schools have come a long way. I mean, I am now a dean of a 200-year-old medical school. It's not the oldest one. The oldest medical school is actually the University of Pennsylvania, where Dr. Kaiser and I have been faculty. Dr. Kaiser is still there. But Jefferson Medical College was founded in 1824. It's the 5th oldest medical school. And I was actually sharing with some of the panel members earlier that this last weekend we had the alumni reunion kind of meeting, and I met the first woman to graduate from this medical school. Can you imagine this? And now the class is 54% women. So it's come a long way. And so we still have a lot of things that we need to do. But cost of care, of education, is one of the factors that's really, in addition to the administration-related kind of obstacles that we face in trying to diversify our work, our students. But we're committed to this. We have to do it because that's what the society expects of us. The most important thing, in my opinion, about the competitive advantage of the United States is its diversity. Look at this room. Look at this room. This is what makes America great, and this is what needs to be done at medical schools as well. So it's a very important challenge, but it's something that we're working on. Regarding the different ways that we have to innovate healthcare, when Abraham Flexner produced his report in 1910, his goal was to systematize and standardize medical education. I recently had a meeting with the Council of Deans in Washington, and we wanted to compare notes, and what we realized is that if you have seen one medical school, you have actually seen one medical school. Everything is sort of becoming so different based on local context. So at Northwell, where I was the chair of the medicine, Department of Medicine, and SVP for the medicine service line, their medical school is really innovative. For instance, one of the things they do is that they introduce clinical experience early on, just within the first few weeks. And the students could actually earn a certificate as EMTs. So they become engaged in the health system and earn some money. So that's a very innovative way of really educating students. Where I went to medical school at Case Western School of Medicine, it's one of the first schools that did what's called the case-based learning, where instead of just memorizing everything, you really have discussions. I think, in my opinion, the future challenge is how do we incorporate AI into medical education? What is it that we need to do to prepare our future physicians and healthcare providers who are going to need to use artificial intelligence? What do we need to do to change the curriculum? And that's one of the most important conversations that's happening today in healthcare, in medical schools.
And I think that's a perfect segue for our next speaker. But before we move on to Dr. Berger, just a comment, which most of you probably know, but many of you may not, which is the number of African-American physicians in this country is 5.6%. The number of Latino physicians in this country is 6 to 7%. And those numbers are abysmal, and they speak to the issue of trust when a patient walks into the office and sees someone who looks completely different, giving them their opinion, their recommendations, their diagnosis. And that's where we need to start focusing on addressing the issue of disparity, which is in so many of our publications and research goals. It's a noble issue, but it has to be changed from the giver side and not so much from the receiver side. So,
But therein also lies part of the problem, trying to attract diverse groups into medicine. One of the most difficult is trying to attract black men into medicine. I mean, you have to start early, I think, trying to get people interested in STEM fields, because that's really one of the great areas. I think those of us who've been deans have seen how difficult it is to find.
Yeah, I agree. And if we have time at the end, I'll share you a snippet of what I've done. And with 2 weeks has completely changed some of that perception in all the students I've interacted with. But I think the issue of innovation in the medical curriculum leads us to speak to Dr. Berger, who during this meeting in the earlier panel was sitting next to 3 medical students. And of course promptly asked, because he transitioned from leadership to clinical to now venture capital and innovations in AI, he asked the students, how many of your attendings of your faculty actually teach you about how to use AI and how AI can augment your learning process and help you learn better? And of course, the answer was?
0. So I had the fortune of sitting next to a few medical students this morning. But before I go there, first of all, congratulations, Dr. Ibrahim, for becoming dean at Jefferson. That's the last job on the face of the earth.
I think he means condolences.
I would ever want. And it is so difficult to be a dean of a medical school these days because you don't control the clinical revenue. You have a faculty, you have to provide education, and then you have all these challenges with how to manage the curriculum in this time of great upheaval in terms of transformation generated by AI. So anyway, back to the question. So the students said, no, none of our education, formal education, is currently being provided by AI or using AI tools, but every night we are using AI to help our education. So I really think that we're at an inflection point where we need to think about really transforming how we provide medical education. So why is it you go to one medical school and you've been to one medical school? You want all physicians to have the same basic core knowledge. So why are we doing it differently at every place? Secondly, and again, we're talking about disparities, so it's worth bringing this up. There are medical schools that have, and there are medical schools that have not. So their ability to innovate and take on new technology and explore new curricula is actually limited. And that's part of what contributes to the fact that we do have these differences across medical school, and you've been to one medical school, you've seen one medical school. So again, we're at a transformational point of time, and using artificial intelligence tools, we can work to standardize medical education, and we can personalize experiences. So this is a disclaimer. I'm an advisor for a company called Copient AI, which builds AI agents to provide one-on-one education. And what we're using it for, and one of the use cases, is I'm very passionate about training physicians as leaders. So we have created scenarios, and one of the things you need to teach physician leaders is how to deal with difficult conversations, deal with disruptive physicians. So we've created an agent that can be any physician you want. It could be a surgeon. It could be a female surgeon. It could be an African American. Any kind of physician you want. And you can then tailor that physician to be disruptive, combative, is able to see and be reflective, and then you set up a conversation in real time about something that this physician has done which is outside of acceptable boundaries. So, for example, yelling at a nurse in an ICU. And then the agent has the conversation as the physician. You act as the person who's supposed to have this conversation, and then you grade it at the end how you did in this conversation, and you learn to have these difficult conversations in a lot more effective manner. So that's just an example of how we can personalize our education and tailor it to what we're really trying to get across, provide instant feedback, and make sure that we take advantage and understand what the weaknesses and strengths of that learner are, and then reinforce their weaknesses and build on their strengths.
So just to shift gears a little bit, as we briefly talked before coming up on stage, Dr. Runge brought up the important point, why 8 years? Why 4 years of undergraduate education, 4 years of medical school, 2 years of research to then get into a residency that now requires additional research? Most surgical residencies are 7 years. And that finish line keeps being pushed back. I asked the panel to each, in 1 minute, kind of summarize how they could see us shortening that timeline so we can match our international colleagues and get to that finish line, say, by 28.
Great question. 1 minute's not very long. I think that we have to take a look at what value do we get from the regulatory agencies that regulate medical education, the LCME, graduate medical education, ACGME, all smart, well-intentioned people, but I would question what is the value of that. I'll question one other perception in academic medicine, recognizing I've been in academic medicine my entire career, except for some outside the medical center clinical activities. Does every single clinical rotation have to be in the academic medical center, or every residency training opportunity? And Dr. Kaiser mentioned that the paucity of being able to have enough training positions, but if we incorporate the vast number of practices and clinicians outside of academic medical centers, I think that can have an impact. And the last thing I'll say, stretching my minute, is that there are medical schools which have adopted that model for ages. One is a medical school I spent 6 years at, University of Texas Medical Branch. The demographics of the medical school class there are today as they've been for 30 years. It's roughly a third, and a third Caucasian, African American, and Latino.
Dr. Kaiser, how would you shorten from 8 or 10 to, say, 6?
So, as you know, there are already schools who are doing it. NYU has for 3 years. I think most people have realized what goes on in that fourth year is probably wasted much of that time. Think about, oh, we're going to go interview. At least now we're doing it virtually. But I think some of that fourth year may be combined into the residency, which is what NYU is doing, what others are doing as well. As you also know, there have been a number of schools over the years who've had combined programs with an undergraduate school where you can do the 6-year program, and I think the quality has been outstanding in those programs. So we're doing it. I don't think that it's widespread at this point, and you know, we're a little bit stuck in the past. I mean, it's always been 4 years of medical school, 4 years of undergraduate. So I think there have been some innovative approaches, and I think now, again, with information so widely available, and pretty much everything you need to know is right here, no longer are we constrained to memorizing everything as had been mentioned. Now it's a question of how best to use the information, and I think utilizing AI is another way to do it. So I think we'll be able to shorten the time of education based on using technology now.
And
Dr. Ibrahim.
So no, I think that I think the question was very much answered. But let me just add one more thing. I think one of the promises of AI that I see with respect to potentially reducing or shortening the training time is that, you know, the first 2 years of medical school is really all about knowledge building. And if knowledge becomes something that's accessible, through your computer, then the question is, do you need 2 years to really sort of to do that? So, I mean, this still needs to be proven, but I think if AI becomes as good as we expect, it's conceivable that students could actually cover the first 2 years with probably sort of less than a year. So that's one possibility. The other possibility is that 2 years of clinical experience is that necessary, as Larry said, that the fourth year is actually, most of it is actually wasted anyway. But I mean, the whole idea of residency and clinical experience has always been that the more you see, the better doctor you become. Well, that's because you have to wait and actually see patients many, many times. You have to see pneumonia many, many times. What if AI could actually show you, or share with you a simulation that shows hundreds and thousands of pneumonia cases over the last 30 years? Will that mean that we don't really actually have to see the actual pneumonia case? I mean, obviously, every step we take in one direction in knowledge is a step away from the other side of medicine, which is the human side, the touch, the ability to sort of hold the patient's hand. I mean, we still have to really attend to that because medicine is not just about science. There's more to it than that. But I think I see scenarios where shortening residency and medical school is a possibility. But we have to get past our history because history is still sort of is holding us back because that's really, the typical medical school is still 4 years.
I'm going to make a comment, which is in Italy, many of the countries represented here, we go from high school into medical school. Yep. Do we need a year of chemistry? Do we need a year of physics? How much of that do we remember right now? And instead, that patient-doctor interaction is not just about disease recognition, diagnosis, treatment. It's about communication. It's about learning to read the room, learning to know what the patient who walks into the door, I'm a breast cancer surgeon, 39-year-old walks in, I know what she's thinking of is not the cancer, it's the baby she won't have because she was going through IVF when she was diagnosed. So reading the room is, I think, something that we need to be careful not to lose. But we should lose chemistry.
Yeah, I'll give it to David, but let me just add one thing. One experiment that we have been toying with at Jefferson Medical School is that we have a relationship with a medical school or university in Rome called Cattolica. And we try to sort of come up with a strategy where their medical students could actually come to Jefferson and attend our 4-year medical school and get a degree from us and an MD degree from in Italy so that they can practice either in Europe or in the United States. Very fascinating concept. But what we couldn't get past is these are students straight out of high school. So they're not comparable when we are evaluating them for admission to our medical school to our to students who are coming out of the United States. As it's become a very difficult sort of a thing to work out, and so we're still trying to figure it out. But it's an example of how this whole notion that the way we educate physicians in Europe or in other parts of the world and the United States, it really should become one and similar, in my opinion.
David.
Thank you. So you touched on important points, Saeed, and that's, it's not just the problem at medical school and undergrad is 8 years. The problem is the residency training is so long. And you have to think about the incentives for why residency training is so long. And the incentive is simple. I'm a former hospital CEO. Residency training is a profit center for hospitals, right? We get paid depending on whether or not they're CMS-funded positions. If they're CMS-funded position, you make anywhere between $150,000 to $250,000 per resident physician, and you don't pay anything near that for their salary. So think about trying to reduce residency training, the impact on hospitals, and how they'll push back. So remember, every system is perfectly designed to give you the results that it's designed to give you, right? The incentives align with what you get. So I think one of the things we need to start looking at is how to change the funding of residencies. But yes, residencies are a target. I'll give you one example of where I see a huge problem as an example. And that my daughter, Lisa, they're breast surgeons. They did 5 years of general surgery, and then they did a fellowship, 1 to 2 years, to do breast surgery. And I'm not taking anything away from the technical aspects of breast surgery, but did they need to do pancreatic resections, liver resections, colon resections to be competent breast surgeons? And should they have had instead learn about medical oncology and radiation oncology and reduce the training from 6 or 7 years to 3 or 4 years? So it's not just medical school. We really need to look at and design our residency programs appropriately. And I agree with Larry, 100%. We have to stop spending years of medical school teaching people how to memorize the Krebs cycle.
But I also think, you know, one of the things that we've not done, so we have general surgery program, 5 years plus 2. We're not looking at competence. If we started looking at competence, it may not take somebody 5 years. I only did 4 years of general surgery. Why? I did 2 years. I went into the lab for 2 years, did a surgical oncology fellowship. They said, you don't need the R3 year, you can come back as an R4. So if you start looking at competence and measuring competence, you'll be able to shorten residency.
And the other thing,
some are going to take longer.
Right, and the other
Some
thing
are going to take longer.
And that's 100% correct. And the other thing that can improve the competency is by using AR and VR. And it's been demonstrated in orthopedic surgery, you can significantly reduce the learning curve for an orthopedic resident to do a joint replacement by just putting them through a virtual, augmented, assisted lab. It's very simple. It's available now. You put on the goggles, and you can do orthopedic surgery.
Once they learn how to go to Home Depot to get their tools.
Well,
so.
that's a different story.
I'm going to make a final comment. We have 1 minute. So to your point, you know, young black men not going into medicine. I, in 2022, put together a program where I brought kids from Harlem into the operating room. They were able to feel the aortic valve through the drape because the cardiac surgeon showed them what it looked like, told them it was crunchy like an eggshell because of atherosclerosis. They watched the heart stop. They watched the patient on bypass. They met the perfusionists, the CRNAs, the nurse anesthetists, the fellows, the residents, the surgeons, and they came out transformed. 2 weeks in high school. Every single of the 92 kids I've had since has gone into healthcare. Some went into research, some are going into nursing. Many of them are going into surgery. The operating room was the life-changing experience for all of them. So I think we have to show them possibility first. We have to show them that there are people who look like them and have made it to the finish line. And I'm lucky to work at Columbia where we have an extremely diverse faculty and very talented and generous faculty. 120 faculty welcome these kids into their operating room, their wards, their ICUs, and 2 weeks is all it took.
And the issue of role models is critically important. At least, by the way, you started them off watching a cardiac operation, which of course is the pinnacle of surgical specialties. Thank you.
Thank you.
Wonderful.
I think our time is up, but I'm glad you all stayed.
Hey, Larry, long time.
Yes, indeed. Great to see you.
Hot mic, any hot mic comments you want to make?
It would be legendary. Wonderful. I think that was an excellent panel discussion. Maybe one of these days that somebody can answer me, why do med residents and medical students never read their textbooks anymore? Everything seems to be first aid and review notebooks. But AI is not going to help with that. Anyways, coming to our next panel, which is the Innovation Lab sponsored by Onyx Systems, I'm going to call upon our facilitators, Mr. Meghdud Roy Chaudhary and Mr. Lawrence McMichael to chair this session. This is a session where we'll be making use of PowerPoint presentations, I believe. So I'm going to go ahead and remove some of the chairs from the dais. Meghdud, you want to take over?
Yes, absolutely.
Mr. Larry McMichael? Perfect.
Larry.
Okay.
Yeah, I think we called them. Grab a chair. You don't need just one more mic, maybe. All right. I've been asked to give 5 minutes of break. In the meantime, if you guys want some jokes, we can call. There's Chai Shai down in the corner. Aruj is serving up some really good rose and saffron flavored tea, which is unique, I guess, from the subcontinent. Really tasty, can definitely suggest. I think the coffee is all done. I don't think we can help with that. Yeah, we can just sit here if needed when the presentation is going on, and then might as well start, I think, no? He said 5 minutes and it's 5 minutes. I don't know. No, this is the marker. 1 second.
Probably the big button on the top, right? I've seen this system before.
Check. AV is up there. All right. While we're waiting, might as well talk to some of the people sitting here. Can we have some questions for the audience, if you don't mind having a little interactive session before we get into the next session? I've been scolded and asked to wait for the other session to finish. Maybe somebody, okay, the gentleman in the second corner. Can we get him a mic? Hello, sir. Where are you joining us today from?
I'm from Boston.
Right. Are you a doctor yourself?
No, I'm not a doctor.
You're not a doctor. It sounds like that TV show, right? Brooklyn Nine-Nine. At the end, they say, not a doctor. Yeah. This is this guy. It was based on him. How's the experience of the conference been so far?
It is amazing. Whole conference is amazing. It raises also a few questions from the last couple of panels. I see that one for Dr. Annapurna, that how we can make it like she was telling that you need 80 or 90 minutes when that cardiac attack happen, you need that services. So, and most of the people cannot make it. So how we can make sure that means as a medical group or as a like a city people and others, means how we can provide that services quickly. What we can do, like we can use the drone, we can use that AI technology, or we can use other ways so that initial medical support can get these people.
Maybe you can pass her the mic. I think there's an issue with the mic. Sorry, we handed you a faulty one.
Yeah, interesting question, and that is where I think a group like this could help to answer your question.
Dr. Annapurna, could we request you to come up front perhaps, and then I think everyone
see
can
me.
see you. And if you don't mind, just quickly recapping the question as well. He said
If
the
everybody
question
heard.
while he was turning towards us. So if you could just quickly recap the question.
So his question was related to what I discussed early on during the lunch session about the technology we have been using here within our hospital in treating patients who are having a heart attack. So, heart attack is a condition where there is acute blockage of blood supply to the heart, and based on the guidelines and all the studies, that once something like that happens, wherever the patient is, usually patient is in patient's home, he has to reach what is called as a cath lab. That's where we work within 90 minutes. So physician like me and other people who work in the cath lab are able to get onto that heart and open that blockage physically. So how can we improve the system? So what we created was a communication platform. So there's a communication, what the vision was, communication should be from the EMS. So we know here in America, EMS is excellent. I think 911 you call and somebody is within your house, supposed to be within 10 minutes. EMS then should connect directly to a physician like me who can look at the EKG and then make a decision. Yes, this is a heart attack. Don't waste time now going to the ED where usually you lose another 20-25 minutes, bring the patient directly to the cath lab. But the system has been created such a way that we cannot change it, but our goal is in the next few years, we should be able to get that system changed. The current system is, especially here in New York City, you have the NYPD and other emergency takes the patient to the nearest emergency room. So that emergency room may not have a cath lab. Then what happens is the doctor in the emergency room will contact a nearby cath lab doctor, usually through a pager, a phone number. So it's still outdated system. And then from there, the patient is transferred to the cath lab. So American Heart Association is trying hard to change it, and that's a number I gave, that transfer. Even in America, which has the best healthcare, I would say, trillions of dollars are being spent, only about 25% of the patients are reaching within 120 minutes. 90 minutes is your own hospital, 120 minutes is transfer. So there's a lot to be changed, and a group of smart people who are collecting here can go to the government and tell them, and this is one condition. If you act on time, you literally save life. 50% of the patients who have a heart attack don't even make it, because once they have a heart attack, when the artery closes, they go into what is called as irregular heartbeat, which is ventricular fibrillation, and that's what we call a sudden death. Oh, the guy collapsed, and before anybody could reach to him or her, or any medical help comes, the person usually passes away. So it's that 50%. So there's a lot to work on, and that is what Mount Sinai, our goal in the cath lab has been, is how to help that particular condition and truly save life.
And if you have more questions for Dr. Annapurna, then you can ask her. She is going to be presenting some of the solutions that Mount Sinai is proposing currently, and I think we'll have a little better understanding of that, including Sophia AI, right? That's one of the solutions that is currently being proposed. So you'll have to wait for a little bit till her session, but in the meantime, I think we can probably start this last panel that we have. Dr. Annapurna, we'd request you to please take your seat. Thank you so much. Thank you for the question, the gentleman from Boston. Ladies and gentlemen, welcome to the last panel of the day. It's always a hard one, doing the last panel. It's like we're running a solid 45 minutes later than scheduled, and half of the people are downstairs taking a break. But with whoever's here in the audience, my name's Meghdut Roy Chaudhary. You'll have to deal with me for the next hour, and my much better co-panelist and co-facilitator, Larry.
Great. Thank you. I don't know how much better I am, but while we're waiting for the rest of the audience to arrive, I want to share a couple things with you. One is, as a lawyer, I'm used to being in a courtroom and talking to judges and juries. I'm not used to talking to all these very smart people who are doctors and healthcare professionals, and I was very apprehensive about being here. For those of you who still have short-term memory, you may recall that I was on the first panel this morning, and I am wrapping up on the last panel. And I feel a lot better right now than I did this morning. And I'll tell you why. We got through an entire day without a single lawyer joke. Yeah. And I'm not going to tell any lawyer jokes now.
I'm
but-
so disappointed. We had a deal that he was going to do a lawyer joke, help us ease into it. I'm really disappointed, Larry. Why did you do this?
No,
to me?
no lawyer
Did me
jokes.
dirty.
No lawyer jokes.
Yeah.
But seriously, my topic and what I've studied and prepared to discuss throughout the day today, and I learned a lot actually, was on healthcare equity and how to improve it. And I have ideas about how to improve it, basically by lowering costs, innovating, and using technology to make care more affordable and therefore more available to people who need it. And I think that what I've heard throughout the day is a lot of good stuff about improvements that have a chance of doing that, improving healthcare equity. And I think this next panel is going to be really interesting, because we're going to see how that is actually taken shape in practice with some actual technologies that are now in use that some of our panelists are going to talk about.
All right.
So other than that, unless you want me to start telling lawyer jokes, that's where we are.
So I think we got the context set by Larry. We're going to get straight into the session. Ladies and gentlemen, welcome to the first innovation panel at the Global Health Congress. Behind every algorithm, behind every molecule, behind every single device, there's a heartbeat. And that heartbeat is why we innovate. With that thought, let me welcome you all to the innovation panel, where we'll be taking you all through lighting the future of global health. That's what we've decided to call this panel. And I'm an educator by profession. I'm the Chief Innovation Officer of Techno India Group, one of the largest educational groups in India. I have about 100,000 students across our group, and that just means a whole lot of responsibility of making sure the next generation of young people who are coming into the workforce truly get access to the best of what's available. In my normal life, that could be ranging from engineering, architecture, design, to nursing, paramedical, and medical degrees. And here, when I am in the midst of so many people from the medical profession, I see today that whatever's happening in the world of AI, in the world of the availability of technology, the kind of technology that we have, innovation is happening at breakneck speed. And it's going to be a responsibility for all of us, the people who are in this room, to ensure access to that technology to enhance the quality of the future that we give to our next generations. So with that note, today's session brings together brilliant minds redefining how we diagnose, treat, and care for our patients. So we have everything from AI-powered decision-making to next-generation devices that quite literally let us see or hear the human body in ways that we would have never thought about before. And today our goal with the innovation panel is very simple. We want to make innovation human again. So with that, on that note, I'd like to call upon stage Jay Grewal from Onyx. We already have his presentation synced up on stage. And just a quick little brief about Onyx and the work that they're doing. So imagine if your doctor could instantly understand your entire medical history the moment you walk in, and not through endless paperwork, but through artificial intelligence. That's what Onyx is doing by helping hospitals unify data across dozens of disconnected systems. Google recently interviewed them at the HIMS, and they've been talking about this fragmentation of data across the medical sector and how you can bring that together and make the whole of the healthcare system more integrated. And Jay, we would love to hear from you. You'll have about 7 minutes to present what you're doing at Onyx. You do need a clicker. I think this is the, yeah, this should be the one. This is the next one, and that's the back.
Okay.
Right.
Thank you.
Can we have a round of applause and get him going? I think at 6:15 p.m. we need all the energy that we can garner. Yeah?
All right, thank you. So yes, my name is Jay Grewal. Thank you very much. I'm from Onyx. So those who have not heard about Onyx, we are the largest partner for the Google implementation of their data and AI solutions. And we are a global company for around 2,000 people. And we have been doing this very successfully for a very long time. As just mentioned, we were recently interviewed by Google because one of the things which I'm going to talk about, which we have been hearing since morning, is AI. what exactly is AI, how we can implement, and what exactly it brings in terms of an ROI for the end user. So I'm going to keep it at non-technical level, but at the same time, we will talk about what exactly it does, right? So if you look at any kind of a healthcare data, about 30% of the total data generated as of today is a healthcare data in the entire world. And out of that, 80% is unstructured. And if you're really looking at that, I went to my doctor, and my doctor said, it took me a while for her to see her. And as I saw her, when she came in, and she was like, I am reviewing your documents, I was reviewing your history. On an average, the American doctors typically spend about 5.5 minutes, this is an average, on reviewing the history of a customer, or their patient, right? I call her customer. And that is about 33% of their day's time that is being spent on it. And what did my doctor say? If you could have helped me just save 40 seconds, Jay, I will owe you anything you would like to. So my mission here is to help her save that 40 seconds if it is possible. And that was the mission. And if we look at, and keeping the physician at the center, there are so many systems, as Dr. Kinney mentioned, EHR, there are many other systems, right? In the back end, somebody's looking at some medical system, the lab systems, whatnot. All that data, when the doctor has to come in and review a patient, they have to understand where all that data is coming from. But to make sense of your life's decision in 5.5 minutes, that's asking too much from a human being, because what is important, what is not, is based upon the experience. But a lot of times we say that there is hallucinations and others, but AI does this job wonderfully. And I'll show you how exactly what we do. So when we look at that problem, our customers do come with these kinds of problems to us, and one of our customers did come to us, and what did we have? We had the best-in-class team, which we have as SMEs on our team who are capable, are research scientists who have been in this field for a very long period of time. We have the best IT team. We are the largest Google partner in the world. And that said, that's on one side. That's the trust which we bring to the table. But at the same time, we are also having AI first, what is the disruptor mindset. So that, with that mindset, what I am going to introduce here is that our thought process was from, if we can, whenever a customer like the one which I'm going to talk about, they're going to come with the problem on hand, we are going to have AI first approach, number one. Number two, whenever those come, we are going to take them from sick care to well care, so that there is proactive approach in how we address, how we help our customer address the problem like that. And that said, the customer's name is Meditech. Many of you guys may be using that. This is the number 3 EHR provider in US. They have about 100% market share in Africa and some other parts of the world. So the major problem which they shared with us was that our customers, their customers, Meditech's customers, when they're using AHR, their systems are all over the place and they're not able to see everything concise and in one place. So what we propose to them, is what we will build it out for them on the Google technology is the search and summarization, which is based upon Google technologies underneath the covers, so Vertex AI. Now, there are a lot of questions, what LLMs they are trained, they're not trained. Now, anything which we pick from the market, just keep that in mind. In the market, in the raw format, was never going to give you the results. But what companies like us, Onyx, what we do is we come in and train that LLM so that we can eliminate that bias, and that LLM is trained to answer your questions. Underneath the covers, we had the AI processing power, the data power, and connections to all the systems behind the scenes. And when we are putting this in the technology terms, what we really did is looking at the various systems. On an average, if a customer spends about $1.5 million in the initial stage, the ROI is so significant, they are willing to go from and this is, by the way, just rationalized data across the different customers, they will go to 10-fold spend because the ROI is there. And when I say there, if they're 1.5 million to start the project, going with the 10 as an MVP, typically within 6 months, they will be asking vendors like us, we are ready for the next phase project. It is $15 million, $20 million. The reason why they are spending that much is because they are getting about 278% of the ROI.
Last minute.
And that said, on an average, when a customer like Meditech leveraged the solution which we built for them, they were able to save per team about 17 hours every week. That is about 600 hours a year. That is 1/3 of an employee. They are able to get additional workload, not only from search and summarization, which they are doing, but also from their discharge summary and many other areas where they will be able to pull in all the information, put it together, and present it in a format in which the doctor can ask a human question to the system, what happens this? And the system should be able to highlight what exactly the issues are and where to address. So for any questions you may have, if you would like to set up any sessions to understand how we can help you, the contact information is here. If you scan this QR code, you will be able to get that. Thank you.
Thank you so much, Jay.
Thank you, Jay.
Thanks for keeping the time limit. That was exactly 7 minutes and 4 seconds. All right. Larry, you want to take on the next one?
Yeah, well, there are no time limits on the moderators, so we've got plenty of time here. Our next guest, Dr. Brian Kolsky from Corstasis Therapeutics, going to talk to us about taking care of heart failure patients at home.
Can we have a round of applause for Dr. Brian Kolsky? Yay!
Should be good.
You got the clicker? Yeah. Which button am I hitting here? Okay, great. Well, I very much appreciate Dr. Molick for inviting me. I'm helping him with some projects in Southern California, so I appreciate being here with all of you guys. And I'll just share a little bit about where the background of this company came from. As an interventional cardiologist and heart failure doctor, I take care of one of the biggest pain points that we see in the office. And I think as you guys have seen the technology that's out there, there's a ton of fire alarms, sensors, intracardiac sensors, cutaneous sensors, Bluetooth scales. And what we decided was, it's great when we have all these fire alarms, but we don't have many fire extinguishers, so we wanted to become the fire extinguisher company. It's our disclaimer. And essentially our mission is to provide intuitive outpatient therapeutic options to help patients with fluid overload from heart failure, hepatic and renal disease. So this treatment loop, I think some of you in this room are familiar with, but essentially how it works is patients that have heart failure develop symptoms of congestion. They get shortness of breath, they get edema. That typically leads to an escalation in their oral diuretic therapy, which as you can ask, survey doctors, about 30% of the 40% of the time that works, but when it doesn't work, what it does is drives the patient into the hospital for intravenous diuretics. And oftentimes in the hospital, the length of stay is approximately 4 or 5 days, at which point hospitals start losing money and patients start having poorer outcomes. Each of these admissions is a sentinel event in the life of the patient. What we aim to do is to create something to disrupt this treatment loop. This is our flagship product. It's called Enbumist. And what we did was piggyback the technology of nasal Narcan, which I think everyone here is familiar with if you live in a metropolitan area. It's probably in every EMT rig and in most people's pockets. So we use the nasal plume geometry and technology from the Narcan delivery system. And our task was, how can we hyper-concentrate a potent loop diuretic to where we can deliver meaningful therapy with one unidose delivery system and spray. I would like to say that we got our FDA approval about 1 month ago. So we took our idea, we raised about $20 million to get it through the regulatory process, and through that regulatory process, we generated the most data on oral diuretic absorption that exists in the current medical literature. How the spray works is essentially one unidose delivery up the nostril, and it gets directly through the mucous membranes into the bloodstream, thereby bypassing the problem with oral absorption with these medications. What we showed and what the FDA required us to do was show that you can deliver this therapy and get IV similar results in the bloodstream, which is what we did. Our indication and label for the drug is the exact same as the listed drug for Bumex, which is the loop diuretic that we used. It's a loop diuretic indicated for the treatment of edema associated with heart failure, hepatic and renal disease, including nephrotic syndrome in adults. And it is not intended for chronic use, which is, I think, an important thing to mention. This really is meant as a bridge, and I'll talk about what I think the use case for this really is. So heart failure is the biggest spend from Medicare's standpoint, dollars spent in the United States for a chronic illness. So it's a huge, huge unmet need. And what we know is patients that get admitted to the hospital, they stay for a long time, and they're often discharged with minor improvement of symptoms. This is a potential bridge back to their oral medications so they can be discharged earlier. This is also a way to keep patients out of the hospital that are suffering from congestion to avoid going to the hospital in the first place for IV diuretics. And then there's also, I think, a use case in the emergency room to try to prevent that same cycle of patients keep coming back. Our clinical trials were published in Circulation. And as far as the intellectual property of because this is a generic drug, the science behind formulating it into a hyper-concentrated 100 microliter solution is not intuitive and took about 3 years of animal testing, bench testing, to get a molecule that was stable at 2 years, room temperature, where you could literally put it in your cupboard and have it and still have it be effective. The pathway we went through was very similar to an accelerated pathway through the FDA, where we did animal testing, toxicology, first in human, and then ultimately our pivotal trial. We have global patent coverage because of the new chemical entity used patents all the way throughout to 2040. We do actually also have a pipeline, because what we didn't realize is when we formulated this drug is 100 microliters of this potent diuretic is also the same viscosity and really the same concentration as insulin. So you could put this into any insulin pump, which are now Bluetooth compatible, eventually potentially taking patients out of the treatment loop. And then I think as we've sort of seen how this fits into the current contemporary heart failure practice, you have patients with all these devices that can monitor them, tell them when they're in trouble. You have a connected app, and then eventually you could potentially have a connected delivery system. Team-wise, we're a very seasoned team of people with both commercial sales experience, scientific PhDs, and the who's who of congestive heart failure. One of our advisors is the CMO at J&J MedTech. And strategic-wise, we really have piggybacked on the shoulders of the gentleman who started nasal Narcan, Roger Crystal, and then the other nasal product, which is recently FDA approved, called Neffy, which is nasal epinephrine, to eventually avoid using EpiPens. And just from our side, from this final slide, we are currently raising capital, which is why ultimately I'm here. And we are currently running a dual process to get our company funded to scale it to become commercial. I can say that the first prescriptions went in last week and 80% were filled. So this is highly promising. So thank you guys for your support and eventually your money.
Amazing. Exactly on the dot, 7 minutes. Thank you, Dr. Brian. I think the coolest thing I'd heard this year before this speech was the fact that now you can have text to video on AI. So you can put some text and then it makes a video in a style that you want. And now that we know that you can use a nasal spray for fixing your heart, who'd have thought? Thank you so much on that presentation, Dr. Brian. We're going to move on to the next one. We have Dr. Mohsin Shah from CareView and Carenetics. So every minute during a stroke, nearly 2 million neurons die. CareView's breakthrough headset can detect large vessel strokes in under 3 minutes using acoustic and EKG data before a patient even reaches the hospital. Over to you, Dr. Mohsin. This is your mic, this is your clicker, the stage is all yours.
All right, well, thank you very much for being here, and especially at the end of this time, I'm going to try to urge this up. It's going to maybe sound like I'm on meth, but I'm going to try to talk as soon as possible and get some credit. First of all, I have to say this is the first time I've been here, but what a wonderful gathering of, not just, physicians, but entrepreneurs and all that. I mean, this is really a gem of a training. Thanks for Achintya and Gautam and everybody. I mean, I really appreciate it. This is the opportunity over here. So I'm a full-time neurosurgeon. That's what I love doing. That's what I'll always do or so. But I have to say, my technology, or our technology, I have to say, because this is an iteration of it, would not even exist in the current day unless we had what I would call LDM, which is large data modeling or so, unlike large language modeling or so. So, and the reason why, I'll give it pretty quick, I'm here, I had the very busy Level 1 Trauma Center, one of the busiest in Southern California, and I mostly do my work as trauma, and I'm also a neuroendovascular surgeon. So when we deal with strokes, you literally have minutes to really intervene and reperfuse those vessels. And the longer it is, again, every minute you're losing 2 billion neurons. So that has a huge impact on not just the overall cost of care that it amounts to almost $35 billion a year in the healthcare system, but also in the productivity that's lost and the quality of life as well. So what our diagnostics does is, this is very interesting, it came to me. So I do a lot of work for other medical device companies as consultants, and also as, for some venture capitals and for private equity groups assessing their technologies. This technology is actually piggybacking on something else that came in, which is very interesting. Great idea, but just not the right fit for that problem. So the idea came for concussions. And the idea was that you can actually put headphones there and be able to screen a patient, or let's say a footballer that just had a concussion, and screen him for actually based on the acoustic signals that came out of whether they've actually had a concussion or not. Now, the basis of that was a little bit more basic, but you could tell that actually there are acoustic changes coming in from the ear in a concussion patient. Now, the only thing was, great technology, nobody wanted to buy into it because nobody wanted to know if their players actually had a concussion. And this was very eye-opening. And the first thing with the company that tried to, down in the Southern California areas, tried to take it to their coaches, and they're saying, I'm not going to take my best player out of this thing. And on top of that, the players didn't want it, and the family didn't want it. I mean, you're talking about people who are, they're looking at their, star players potentially being taken out of games. And so they basically were folding. And I told them, listen, it's a great technology. I'm sure there's an idea for it, but we got to find what the proper usage for this. But I definitely believe that technology was there. So I finally figured out, well, let's try to put this on another disorder called migraine, because I had a lot of experience in the migraine world with TCDs or so. And I said, let's see if this works for that. So we took we took a studio, we brought in 10 normal people, we did our studies and got a baseline. Then we took 10 migraineurs, known migraineurs. 7 of them actually had pretty significant findings or so, which I thought was going to be very difficult to find. I thought the problems would be very subtle. We put it through this, actually a DeepSeek model of data analytics, and boom, to my surprise, 7 out of the 7 had drastically different signatures for migraine, which to me kind of proved a point is that you can diagnose these, which right now is only diagnosed based on a clinical setting. So what then the problem that arose is that, well, okay, now you have a new technology, you have a new field, but how do you actually prove if somebody actually has a migraine just based on the acoustic signature? There's just nothing to compare it. How do you compare this to something else? Then we decided to do this into stroke, which is more impactful. Number one, because you have a signature, but how do you know whether it's actually corresponds to that disease or not? So in this case, it would be easy. What we would do is basically take the signature if it was abnormal, and then we would prove with a CT angiogram or cerebral angiogram whether a patient actually had a large vessel occlusion or not. This is much more impactful because you can imagine when minutes count, there's still not an easy way out in the field for somebody to say, hey, this patient's having a stroke, because you use the basic EMS criteria for doing it, and that's based on a very subjective way of doing it, a LAM score, what we call it, or so. And then those patients are taken to the nearest stroke center. Well, guess what? Most of those stroke centers don't have capacity to do interventions. So if you did have a stroke, then it would take another hour or so to be transferred to somewhere else, where again, you would, by the time they would bring people in or so, you would have lost an hour or two, and then again, the earlier intervening, the clearer, the better the outcomes. The more delayed the findings or the ability to get them into an interventional suite, the worse the outcomes. So what we did is basically we took about 150 patients, we brought them in, and this is all through the ER that are in our center and 2 other centers, including one in Florida or so. We basically screened them before they even got to the CT scanner or into the interventional suite. And then we basically got their signatures we got about a 10-minute read on each of one of them. But putting it through this putting through this data modeling or so, we were able to clearly find very unique signature effects. And I'm going to go there. So the one on the bottom right, that is what a normal signature in a patient with a normal
last minute.
A normal signature would be. The one on the left is the patient actually having the stroke. What's impactful about this is that, number one, you can, as soon as you have this, you can screen and instigate a immediate recall of your resources hospital to get the interventional lab ready and then ready for them. So this is one of the unique features of this is that, number one, it allows recruitment and it allows mobilization of your whole hospital resource force. In other words, each time a stroke activation is implemented, the hospital probably spends around between $3,000 to $7,000 and that could be a false flag, in other words. And there are quite a bit of false stroke patients that do come in that don't require it, and by that time you've already put all those resources in. So our goal is to be able to utilize this in the field, to be able to, or at the moment they get into the CT or into the ER, and before they even had a CT scan, help actually supplement the fact that, okay, this patient's having a large vessel occlusion, let's get the interventional suite activated, you're bringing your people in, you're actually using it to actually do the intervention rather than summoning up all those resources when it becomes a false flag. So our currently what we're having is we've already done through a phase 1 and through our phase 2, we're actually preparing for a 510K submission, and then the commercial launch is expected to be in 2028. And for our funding, most of it is started from just a group of surgeons and physicians and neurologists, and we're in the process of having a National Science Foundation application for $305,000, and then of course future funding that will be. But we're hoping from this NSF funding to be able to generate some papers. This is a whole new field, and I can tell you from this is that you could almost call this the field of neuroacoustics, where each individual problem, whether it be we've already shown in migraine or stroke, and also in future we could tell traumatic brain injury, brain hemorrhage, even conditions such as Alzheimer's. So this is where the value of this is in these large data models, be able to identify unique signatures for each neurologic condition with simply just putting your headphones on and making a reading in under 30 seconds.
Hey, thank you, Dr. Shah. That was very enlightening. Sarah, even lawyers learn things. Sarah View listens to the brain, the way a stethoscope listens to the heart.
It is the stethoscope to the brain. That's what we call it.
That's a technology that will save lives and bring better care to people who need it. We appreciate your work there.
And cost effectively. That's the most important thing.
Yes, right. So next up, we have Dr. Annapurna Kinney, Mount Sinai Hospital, who has already been introduced, so we'll save another minute. I'll skip the introduction and just invite Dr. Kinney to the stage to talk about her technology. I'm really interested in AI nurses.
Question is, do I just stand here? Because I probably have the most slides for 7 minutes. So let us see, it's the doctor speaking or the artificial intelligence. Anyway, even for now, at 5 o'clock, we have so many people there. Like I mentioned earlier, if you see this is the cath lab, very challenging place. More than 16,000 phone calls we do per day.
I am Sophia, a virtual
And we created Sophia.
to assist patients like you with their cardiac care at Mount Sinai Hospital. My focus is on providing clear, accurate, and helpful information about your procedure, answering your questions, and ensuring you're well prepared.
So this is that voice that I have been talking, calm, cool, collective voice, never raised her voice. So these are the questions that have been asked already. If you see here, over 15 committees, 15 committees at Mount Sinai Hospital went through this and finally gave the credentialing, and Sophia was onboarded. We started our pilot early part of this year. Very complex process, like you see here. What happens every day in the cath lab, and Sophia is right there making phone calls to the patient. So what is great thing about the phone call of Sophia? If it's human, it's 1, maybe 2 phone calls you can do per person. Look at Sophia, 15 calls at a time, You can take care of multiple people at the same time. So, like I mentioned, it's always checked and double checked. Once the call has happened, the nurse quickly goes through this, and once that's done, there's an automatic report that's come, and once it's done, then only it gets into the Epic. So this is what we found. The regular phone call done by a nurse used to take about 15-20 minutes. With Sophia calling, double checking, it used to be about 2.2 minutes, so we saved a lot of time. So the phase 1 was, if you see here, where the human checked and double checked, there was a gradual improvement, but despite that, there was a 90% success rate using the agent. This was the first of its kind, the agent being used in clinical practice and in a busy cardiac cath lab. The phase 2, where the training, everything was completed, only the nurse checked it and looked at the final numbers, we were still about 90% or so. The biggest question was, did patients like it, or what was it? So we did create what is called as a feedback from survey from the patients, and when whoever spoke to Sophia had interaction, and then they filled this. If you see that, about 94% positive feedback from the patients when we did it. Moving on to the question where most people are talking about, and just now what Dr. Shah actually presented, for us is somebody is having a heart attack, there's an occluded artery, like I already told you, within 90 minutes they have to reach the cath lab, or if they are somewhere far away in another hospital, 120 minutes, and there is a registry, American Heart Association, we have to enter every single patient into this registry. So way back in 2018, we created what is called as a coordination or a communication platform for taking care of these patients, what we call as a STEMI app, So if you see US average, which I mentioned, about 20%, in healthcare system that is that great, can make less than 120 minutes with transfer. Mount Sinai, which we thought we are the greatest in taking care of even the transfer patient, we rarely reach 75%. 75% is what the American Heart Association wants, that's a number they'll blame. But after using the app, we were about 100% getting there. Then going to education, and a lot of this has been already discussed, but we thought about this long time ago. From way back in 2019, instead of books, we created what is called as apps, and from 2009 onwards, we have what we are calling as live cases, free educational apps that we created. Now the question comes is that can we use artificial intelligence and make something that is what is called as a special LLM that we only curated for interventional cardiologists, and what can we gain is that they are going to learn from the specialist from Mount Sinai how to take care of a complex procedure to be done exactly, to be learned from the masters that Mount Sinai that we are. So making it uniform so patients all over the world can get the best treatment that we can. So next question comes is, same thing, patient has come to Mount Sinai Cath Lab, and Dr. Sharma just appeared here, who has created, massive enterprise. How can we take care of the complex lesions, right? How can we take care of the complex case? A lot of patients are being referred just because of the name that Cath Lab is. So then the question comes, first you need to train the so-called the AI. Can it detect? So this was the first of its kind, because majority of the time what has happened, the AI has been trained to detect still images, not moving. Angiogram is a moving video. So we were able to train, and we have got so far that it can detect what is called as a blockage. Now we want to go to the next level. Okay, you have detected a blockage. It's a complex blockage. How can that complex blockage be taken care? We already have the app. We have algorithm in there. That is what we are working on. That yes, complex blockage is there. We are going to put the algorithm of how to take care of that complex blockage and just create that. The future is a smart cath lab, directed by the masters, the LLM created and the bot created by us. So in coming years, I think a lot of things have been already discussed. One thing that I did not discuss is personalized medicine. For 15 years, we are working on a trial where we can find which patient need to be treated for a blockage, whether they get statin or the next level treatment, PCSK9. And that will be hopefully in our next meeting. Thank you. This is the kidney think tank. Some of my members are already here, right here. And it's a small group, but very intense, where we think super intelligence, creating artificial intelligence. Thank you.
Superb. Not only is she one of those speakers that you want to listen to the whole time, but she's also dressed immaculately. What she's wearing, by the way, very interestingly, if you like trivia, she's really into sustainable fashion. We were talking about this before. She's wearing a Kanjivaram sari, which has been upcycled as a dress. And I think we definitely need more, people that can carry stuff like that in an audience filled where I think it's always nice to come up and spread some joy. So thank you, Dr. Kinney, for joining us today and sharing your highlights. You do have a super group working with you. Thank you for doing all that you do for us. All right, next up.
I just want to thank the whole group of people who have arranged this. This is amazing. I mean, when I came earlier in the afternoon, there was no space to come inside. So we have Gautam, Malak, then we have, of course, Achinta Maulik, Sanath. Dr. Sharma is also there, who has just come. But I think a lot of work has gone behind. Nidhi.
A round of applause for all the organizers of the Global Health Congress. Thank you very much. All right. I'm getting a lot of flack from this side of the stage, so I'm not going to look at them anymore. We have like 10 minutes to finish the last couple of presentations. All right, so next one that we have. All right, so the next team that we have is Antelope Surgical. They are actually giving surgeons night vision for cancer, making the invisible visible. To represent Antelope, we have Dr. Amy Wu. Can we please cheer her on with a big round of applause They are redefining cancer surgery with a 3-in-1 technology that lights up tumors during operations. And as somebody who has absolutely no idea about anything that's going on in that field, I'm going to pass on this mic and this clicker for you to present us. Yes, the green button. Thank you.
Okay, we named our company Antelope thinking we will always be first, but we are actually last today. So I'm second to last. Okay, great. I'm Amy Wu. I'm a surgeon, I'm a mom, I'm a New Yorker, I'm a wife, but I'm also founder and CEO of this company. We're about 5.5 years old. We're right here in New York City, downtown. We started at NYU Biolabs before we spun out. Antelope's goal is to light the future of surgery and oncology, literally. Surgeons, we need to see better. We do our best with pre-op imaging, with all these technologies intra-op, but there are still errors. There are errors in biopsies, in diagnostic imaging. There's high recurrence rates even after surgery, chemo, radiation, immunotherapy, you name it. We have more and more therapies because there are failures. This means a large cost to patients, their families, and to the US healthcare system. That's over $5 billion in prostate cancer alone, and this model copies itself over and over in other cancers. What Antelope does is we literally make cancer light up by using what's called fluorescence technology. We have all heard fluorescence, right? There's jellyfish fluorescence, there's natural bioluminescence. We use fluorescence in all kinds of chemicals in the lab. Even our food is fluorescent. But Antelope uses fluorescence for surgical tracking. It's a small IV push at the time of surgery, and it homes to the cancer cells. It makes them light up with our device. Obviously, fluorescence is not always visible. You need to excite it, and then you have to see the emission light. But what that really means, so here it is in a mouse model, and you can see the fluorescence, the tumor right underneath the skin. There's background lighting, and if I were to show you this video, you can actually see everything move in real time. So I believe the future of surgery is going to be AI-guided, led by surgeons, but powered by drugs like Antelopes. This is a real paradigm shift in precision oncology and surgery. We have a 3-in-1 production that shortens go-to-market. And I apologize, I refused to pay from Microsoft, so I didn't do this in PowerPoint. So this is Google Slides converting to PowerPoint, so it looks crazy. That's not how the real slides look. But we actually do radiotherapeutics with diagnostic imaging, which is in the form of PET for staging cancer, and fluorescence-guided surgery, all in one production. Plus, we have an imaging device. So we are a theranostics platform company with device. But what's so special about us is we've proven our process with our first IND. Sorry, I clicked that too fast, but it's AS1986NS is the first tracer we have IND cleared as of November 2024. And we do this in a really smart 3-in-1 small molecule warhead. Currently, it's linked to PSMA, and the urologists in this room know that is on most cancer surfaces for prostate cancer. But our linker is a tracer. It's a fluorophore. It glows. It's a dye. With an additional step, this small molecule becomes radioactive. It becomes PET active. And another step, it becomes a therapeutic agent. Or we could have both. Imagine a patient gets treated for metastasis, and you could track how the disease melts away in real time with PET. And the surgeon goes in and says, I want to cut out this lymph node or this localized area of cancer. They can still see it with our drugs. Furthermore, this is a platform play. When we change out the targeting, which we have already started for the next agents, this becomes a drug for other diseases with the same play, fluorescence, PET, and therapeutics. Compared to others developed in development or on the market, They are single-use agents. These receptors are getting saturated, and patients have to wait 4 to 6 weeks before they can have another agent injected. And these are individual CMCs, that's manufacturing, IND, that's regulatory process. We do this in a speedy way. What we provide, now focusing on fluorescence, a precise intra-op dye, a tracer, plus the device. Here's Intuitive. So there is none on the market for prostate cancer. Intuitive has this one. You notice how the background is black. Notice how the cancer is a green blob. It's blurry, it's not clear. The edges are blurry. These are others in development, even worse. Here's Antelope's. My co-founder's hand in white light with our proprietary multi-channel fluorescent imaging system, you can see very bright spots light up. They are crystal clear. Here are all the benefits. I apologize for the errors in translation. Clarity, brightness, microdose. So this is an agent that is a drop in Olympic-sized pool. That means safety, faster approval. And we keep surgery in mind because as a surgeon, I want to finish the case as fast as I can in the best way possible for the patient. So this agent is injected at the time of surgery. It's not injected a day before, very much like other agents being developed.
Last minute.
We're AI-powered, vertically integrated from R&D to CMC to IND to NDA. We've made significant accomplishments with just very little funding because we use AI. And then in the next 2 quarters, we're hitting major milestones, and we will be starting Series A in the coming year. Our use of funds is quite aggressive. In the next 3 years, if we raise $70 million, we will accomplish full NDA and device 510K, as well as get into clinical trials for the PET and the therapeutics. My co-founder is Dr. Richard Ting. He and I met at Dr. Roger Chen's lab. Roger Chen was a 2008 Nobel laureate in chemistry for his work in green fluorescence protein. So we have the premier team. So join me for the future of precision oncology and surgery. If you message me on LinkedIn, please mention that you heard my talk here so I know who you are. And I look forward to sharing more. If you have any questions, I'm available after. Thank you.
Wow, technology that lets doctors actually see cancer in real time. Very impressive. But last but not least, Dr. Sanyal is the CEO of Life Plus. He's going to talk to us about needle-free monitoring.
Thank you, Larry, and thanks for having me. I think I am the one standing between you and the dinner, so I would like to be very short. So we are a company based in Silicon Valley and focusing on transforming chronic disease monitoring. This is probably one of the, to our best knowledge, one of the first multivariate, non-invasive, effortless health monitoring platform. We all know in this room that the chronic disease management is one of the largest cost drivers in the global scene of healthcare delivery. And to manage chronic disease, we need ongoing monitoring of the primary biomarkers behind those diseases. But there is a problem. Either those devices that are used today are either invasive or require a lot of attention and involvement from the user, or if you are suffering from multiple chronic disease, you are thrown at different devices to use, and finally, you end up spending a lot of money if there is a consumable involved. So as a result, the compliance of using these devices is very low throughout the world, even in the United States. So what providers and patients need is a single, simple, non-invasive, multivariate, effortless device to monitor chronic disease. So that's what is our promise. We have come up with a solution called LifeLift, which is a wrist-on wearable. I'm actually wearing it on my own wrist. It stands on 3 pillars: non-invasive glucose, cuffless blood pressure, and cardiac rhythm, all coming out of the photoplethysmogram signal, which is a pretty well-known signal for many decades in the healthcare industry. So what we do special with this signal is that, first of all, we understand and appreciate the challenge with this signal. This is a wrist-on device. The signal suffers from tremendous sources of noise, external, internal. And our job has been over the last 7-8 years is to learn more and more and appreciate these sources and how to denoise those sources. That's the first thing that we do. Second thing is, we have been able to come up and understand multiple features of this signal which have very low-grade correlation with parameters like glucose or blood pressure. But then, before AI, it was not possible to use these features and come up with a robust, accurate solution for prediction of glucose or blood pressure. But with AI, with deep learning, that is slowly becoming possible. Finally, we were able to come up with a restored product level solution very early so that we could take advantage of taking this device to people rather than bringing people to lab and get the calibration data. So I am very happy to say we have more than 1,500 beta users in over 18 countries in Europe, Middle East, and Asia today who have contributed to our calibration dataset. At this very moment, we are getting into a large 600-subject calibration study with PGI Chandigarh. And we are starting our operation in India as well. So just a quick look at the competition. At one end, we always hear about the giants, Apple, Samsung. They have been working on non-invasive, glucose or blood pressure, etc. On the other side, we have the startups who are all doing very credible research, but they don't have a restored form factor that easily possible to take to data to the users that we have today. And in the middle, we have the established RPMs. This is the platform we built homegrown. So we have our own designed, fully manufactured device, Bluetooth connected Android and iOS app, and backend cloud hosted at AWS. We have a portal for the user. We have another portal for the care team. This is already integration ready for any EHR system. This is a quick view of the market. We are starting right now in a non-regulated market in the developing countries, primarily positioning it as a fitness and wearable wellness product. This is about $3 billion market. Then with FDA approval, we will be getting to the longitudinal monitoring of the chronic diseases like diabetes, hypertension, etc. And finally, we will have our own patented sensor-based, fully integrated therapeutic solution. So we have been navigating through the FDA and the CE MDR route, and we are positioning our first product, which is the product that you are seeing, as a longitudinal trend monitor for the low-risk application. And on the second product, where we'll use our own patented sensor, we will go with the full therapeutic solution. This is a snapshot of data. By the way, we partner with some of the premier institutions of US as well as outside. We partner with Mayo Clinic. We partner with Cleveland Clinic, Abu Dhabi, in India as well, a self-standing metabolic research institute from Escondido, San Diego. So we compare data against both fingerstick as well as Dexcom. And right now, I'm happy to say that with calibration, with a few early calibration, on any individual, we are having less than 10% mean error with respect to fingerstick. For the blood pressure also, we are getting very close to the FDA standard. This is our product roadmap. We have the watch already available. By mid next year, we will have the band, because we are slowly moving from the watch side, because we are not going to compete on the watch. And that's the wellness prevention positioning. The second product, using our own patented sensor, will be an integrated solution with the insulin pump. And our revenue model is very simple. We work on B2B2C. We sell the product at a wholesale price to the distributors, and we retain a subscription. We see that our current, we have about a $2 to $3 million revenue this year, ending this year. And after next year, we are expecting the FDA approval by end of next year. Then we'll see that hockey stick curve. We are right now raising a round, a $10 million round for the next 24 months in target. We have a lead investor with $5 million committed already, working on the closing of the first deposit. And we are looking for other investors, including strategic investors as well. This is a quick view of the team. Myself and Ben, we are the two co-founders. We both come from the deep tech industry, but we are complemented by a solid physician team, as well as a seasoned business people. And Alberto is our Chief Regulatory Advisor, who was FDA's in vitro diagnostics unit's director for many years. This is our other academic and physician colleagues who advise us, and we avail their guidance all the time. So thank you very much. That was my presentation.
Thank you, Dr. Sanyal. Very enlightening.
Thank you, Larry. Thank you, Megdud.
Well, that brings us to the end of this session and today's programs. I want to...
It's not the end.
Not quite the end.
Yeah, let me just correct Larry on that. It's not the end. It's also not time for dinner. We have one more session. It's not a panel. We have a very special session coming up right after. But Larry, I'll let you finish on that. We have some unfinished business.
I completely missed that. Sorry about that. So thank you for allowing a lawyer in your midst, and thank you, Megdut, for organizing this presentation. You did a great job. I followed along, and he did all the work. So did a really nice job. I think everything we've heard, all of these innovations, and there are many, many more of them. You just have to keep going, and ultimately they will improve healthcare quality. They will. It will have that effect.
I think more than anything else, entrepreneurs, especially in the medical field, all of them deserve that recognition. They're all superstars in their own light. Can we have a massive round of applause for all 6 of these medical entrepreneurs? And also, can we all have all of you back on stage once? We unfortunately could not take a photo with all of the innovation panel together on stage, so I would request all of the speakers of the innovation panel to please make their way up onto the stage so we can take a photo with all of them together. I think since they aired Shark Tank, started airing Shark Tank in India, and that's been going on for so long in the US as well, you realize suddenly that entrepreneurs on Shark Tank suddenly have the same social status as Bollywood superstars, and rightfully so, perhaps even more if they're saving lives with their incredible technology as these ladies and gentlemen are. So let's keep the applause going on. Thank you very much for joining us today. And with that, with 1 minute left to go before Nikki drives me off the stage, I would like to invite her back on stage to introduce the last session. Thank you very much, Larry. Thank you, gentlemen. See you right after for cocktail hour after this session is done.
All right, so music as medicine, music as food for the soul. Speaking of food, we'll have cocktail hours on the 22nd floor, which is the rooftop. And after that, we'll have the gala dinner, which will be back here on the 20th floor. But before that, after all that science, let's get something soulful.
Because sometimes the best therapy doesn't come from labs. It comes from sound. And as we know, life makes us dance at its tune. We are only asking, please play a song that we enjoy.
So please welcome Grammy-winning composer Barry Goldstein for our closing session, Music as Medicine.
Thank you so much. And I'm sure a lot of you have come here to listen about the new technologies. What an amazing day, and I just want to honor all the people that came before me. Let's give them some energy. And tonight I'm also going to be speaking about some older energies as well, some ancient traditions. In addition to AI and the amazing innovativeness that we've experienced, I'm also going to be discussing EI, which stands for emotional intelligence as well, and we can incorporate that into medicine. And usually when I do CME lectures, I usually see a couple of people in the audience kind of like this, and doctors saying, what's this music guy doing here? And I just want to let you know that I am an MD. I'm not a medical doctor, but I am your musical director for the day. And I'm going to be providing some of the science behind how music's being used in medicine, as well as some micro experiences that we'll be doing together, and also a protocol, a 3-step protocol that you can incorporate with your patients in your own lives and also with your families. So music as medicine, I call this acousticeuticals for health. They're precision sound tools that target wellness outcomes. And this is in addition to pharmaceutical nutraceuticals. Another pillar of health is acousticeuticals. And this is nothing new. So music as medicine has been going on for thousands of years. And in traditional Chinese medicine, they understood the power of therapeutic music, so much so that we see the symbol of music in medicine. Albert Einstein said if he was not a physicist, he would be a musician. And his wife talked about when he was going through his theories and he got stuck, she would hear him from the other room picking up his violin or playing piano chords and annotating new things on his paper. So how can you use music to create breakthroughs in your medicine? We know we have an inner pharmacy that is activated with music. When we listen to relaxing music, stress hormones can be reduced. When we listen to music that we love, our preferred music, with any genre, we know that we can increase dopamine. And when a mother sings a lullaby to her brand new child, we know she produces oxytocin. So music has a way to induce this internal pharmacy. And I want to show how this can be incorporated, how it's incorporated in our lives. So I've literally created 3 identical videos, all the same scene. The only thing that differs in them is the music. So I composed 3 different pieces of music that target different emotions. And when you look at this, I want you to listen beyond your ears. See if you can feel anything in your physical body as you watch each of these scenes. And put up the volume. Oh, we're going to have to start that again. Sorry. So I need the music volume up on that. So how many of you were able to feel the difference between that same scene? Could you feel that in your body at all? So music can either be medicine or it can be misinformation as well, depending what music. Just like the power of individualized medicine, individualized music. So how are you programming your own music in your life? How are you becoming the DJ of your own life? Maybe that first scene, you felt relaxed and your parasympathetic system would just relax. Maybe on that second one, you felt that sympathetic kicking in, and maybe you felt like you needed a little bit more popcorn, like you were watching a horror movie. Or that last scene, maybe you felt like texting your loved one for a date night. Who knows, right? We all have different effects, and music can be used in different ways. So some more studies on music. This is in cardiovascular health. We know that listening to relaxing music can increase heart rate variability, as well as can reduce our blood pressure, anxiety, and even pain. And it's done through the mechanism within music of something we call entrainment. So your heart is a metronome, and it can actually synchronize with the metronome and timing of music. So we can create designer music to actually facilitate this. In stroke patients and TBIs, we have something called melodic intonation therapies that's used. This is a combination of melodies and tapping the fingers on the left hand at the same time, and it's literally relearning language in stroke patients with aphasia. In Parkinson's disease, something called rhythmic auditory stimulation. This is when specific auditory cues, mainly drums, are used when Parkinson's patients are walking, so it improves gait and stability and less incidence. In cancer, relaxing music can be used to diminish symptoms such as nausea and also be used for pain management. It also lowers pro-inflammatory markers IL-6 and HMGB1 and shows that music has a use as an anti-inflammatory intervention as well. And a lot of new technologies, exciting technologies, not just with music, but how sound and vibration can be used as well, with high-intensity ultrasound and also low-intensity ultrasound, as well as many other new ones that are not just being tested, but also some of them are FDA approved. In Alzheimer's disease, music and autobiographical memories. So the part of the brain that is connected to that, when we hear familiar music that we know, and it lights up the brain of autobiographical memories. This has been very breakthrough in Alzheimer's patients, and I'm going to show you how this can be utilized, literally awakening a patient who was almost in catatonic states for 10 years.
Papa? Hi, Papa. How long has he been in the nursing home? Approximately 10 years.
Looking more or less for religious music for him.
We first see Henry inert, maybe depressed, unresponsive, and almost unalive.
Let's try your music, okay? And then you tell me if it's too loud or not.
Then he is given an iPod containing, we know, his favorite music. And immediately he lights up. His face assumes expression, his eyes open wide. He starts to sing and to rock and to move his arms, and he's being animated by the music.
What does music do to you?
Give me the feeling of love. No man. Figure right now the world need to come into music, singing. You got beautiful music in.
This beautiful new technology, you can have all the music which is significant for you in something as big as a matchbox or whatever. And I think this may be very, very important in helping to animate, organize, and bring a sense of identity back to people who are out of it.
Now, if I would have shown you a before and after picture, would you have been able to guess that music is what took him there? So a lot of people ask me, does this work with other kinds of music as well? Does rap music, for instance, work? Can that be medicine? And this is actually a brain mapping of showing how this works in what's called freestyle rap music. So it's not rap music that is read off a lyric sheet, but it's in flow state when someone is actually just creating lyrics on the spot. It is associated with the areas of the brain that induce creativity and also our judgment centers as well. So how could this be used in medicine? How could this be used in education? So we saw Henry, who is an elderly man, but imagine if we use this with younger kids, and you're gonna see literally this 4-year-old child who's barely speaking is learning to count, and also he's learning to connect to joy with rap music.
your mommy?
I'm Kian.
I'm Kian.
He your weapon.
Yeah.
Can he your weapon?
So you feel that joy of, imagine bringing that into your day and into your life. And music is literally that bridge that takes us from one state to another. And we can start this at an earlier age as well. So it's literally the cycle of life from childhood all the way to even utilizing music. I've used my music to help people pass in hospice as well. So it carries and follows through the circle of life. So this is where ancient meets modern, and this is where I'm going to need all of your help, and we can actually integrate the day a little bit together as well. But utilizing an ancient chant, and the Alzheimer's organization showed that the chant of Kirtan Kriya, which is the Satanama, literally can improve memory, it can improve blood flow in the brain, improve sleep, it can decrease stress, and also decrease anxiety, and it actually increased telomere length as well, just by 12 minutes of this. So I'm not going to take you through 12 minutes. We've all had a long day, but the beautiful thing about chanting, and I want you to think about this, we have people from all over the world in this room coming together, and we've connected in learning new things, but music has a way of integrating all of that together. So I'm just going to ask for a minute of your time to join me in this. And the sa is going to be from the thumb to the index finger, the ta, thumb to middle finger. And the first one meant knowledge, the second is patience. The na is the thumb to ring finger, meaning vitality. And the ma is thumb to pinky finger, which brings in communication. And it's just going to be 4 of each. First, we're going to sing it. Then we're going to whisper it, and then we're just going to recite it internally. Nothing you have to do, just follow my lead. And if you feel like you'd want to close your eyes, you're welcome to do so as well. And we're going to begin. Remember, Satanama. Satanama, 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 Satanama. Whisper. Satanama, Satanama, Satanama. And in silence. Good, and just give yourself a big breath in. Want to hear a big exhale out. Great, you guys are awesome. Give yourself a hand. So I'm going to talk a little bit and just give you a protocol that you can use for yourself and also with your patients. So just like we nourish ourselves with food, you can nourish yourself with music as well. I said the 3 most important times of the day are in the morning when you wake up, in the afternoon to recharge your energy, and then in the evening to wind down. In the morning, you heard me at the beginning talk about emotional intelligence. I'm going to discuss that a little bit more. Heart entrainment, which is the mechanism of moving into those smooth and orderly heart rhythms, and then creating a gratitude playlist as well. So the emotional intelligence, this was done by a foundation called the HeartMath Foundation. Some of you might be familiar with them, but if you're not, they study the measurable effects of specific emotions on the heart. And it showed that when we move into emotions such as love, we produce a coherent spectrum in the EKGs. When we move into anger, they're incoherent. And as well, that we can move into those orderly rhythms and actually change our heart rate. And that is measured in beats per minute, which is very similar to music. You'll see those coherent, smooth, orderly waveforms right in between 60 and 80 beats per minute, where we know the human heart is at a relaxed state. And when we're in frustration, they're not in those orderly fashions. So what else does that? Besides just the emotion, music can bring us into those smooth and orderly heart rhythms. And when we do so, we're not just affecting our heart rate variability, but we're also producing more alpha brain waves. Now, this is the state that really benefits us in moving to flow states, new ideas, and is also beneficial in going to sleep at night. So combining these together, when you combine that elevated emotion with music that brings you to a state of gratitude, it can actually calm down the deep limbic areas in your brain. So it moves us from survival to wisdom. And that is really the way we want to start our day, in that space of gratitude. So I invite you to create a 3-song playlist. Not a lot, but just 3 songs where you wake up in the morning, where you're coming out of those delta brainwave states, your resting state. Before you pick up your phone, listen to those 3 songs and allow yourself to move into that state of gratitude. In lunchtime, we like the midday reset. You want more energy. So breath work with music is amazing, and I'm going to do a minute of this with all of you. What's special about this music and breath work, it's programmed so that it incorporates 5.5 breaths in and out in that 1 minute. And this has been studied to optimally move us into heart rate variability. So it's just going to be in 2, 3, 4, and then out 2, 3, 4. And we're going to do this together. 2, 3, 4, and out. 2, 3, 4. Inhale. 2, 3, 4. Exhale. 2, 3, 4. Now relax those shoulders. Inhale. 2, 3, 4. Exhale. 2, 3, 4. Inhale. 2, 3, 4. And exhale. 2, 3, 4. Next one, let out a big sigh. Inhale. 2, 3, 4. And 2, 3, 4. And inhale. 2, 3, 4. And exhale. 2, 3, 4. And you could just gently open your eyes, come back in the room. And if that 1 minute felt like a vacation for you, you're probably working a little bit too hard. So the evening sleep protocol, I think of that kind of like dessert after dinner, something sweet to kind of cap your evening off. So about an hour before bedtime, when you start to wind down, play music at that 60 beats per minute. And you can look that up anywhere on YouTube. I have some great playlists on Spotify as well that I've done with Dr. Daniel Amen on sleep. And the harmonic recipe that's been studied has been that it's low and slow frequencies, not a lot of melodies, because when you are listening to melody, the analytical mind wants to like it or not like it. And also no lyrics, because lyrics take us more into, again, that analytical mind, and we don't want to do that before sleep. So this is a great way to process your day, to move into that place of gratitude. And I like to place my hands on my heart before I go to sleep and feel my life force, my heartbeat, my breath. I call this your inner symphony. Our body is a miracle. It's producing all kinds of sound with all kinds of benefit. At night, it's time to move into sacredness. So we've moved away from that. Most of us are still firing and wiring and playing with our phones before sleep. So this is all about reconnecting back into that heart and being thankful. remember the first sleep clinics were actually temples. And that's where people really valued as sleep as something that was healing. Music can take us there. So 30 years ago, if you would have told me that my music would be putting people to sleep every night, I would have considered that an insult because I was a rock musician. But now, 30 years later, I can say that I'm proud to say that people from all over the world say, I sleep with Barry Goldstein. Thank you very much. If this inspired you in any way, thank you. And you felt the power of music in this 20-minute presentation. I'm doing another presentation tomorrow. But also, I'm very open to speaking about new areas of research for music as well. I think there's a lot of new innovations that can go on, and I'd love to hear your experiences as well. So feel free to talk to me. I won't keep you any longer. I want to thank this beautiful conference for having me here, all the organizers that made it possible. We've done an amazing, amazing job, and an amazing day to all the presenters as well. Thank you so much.